Mic check. Start. It's on. Start. Start. Oh, sure. Mic check. God is good. It's a great day. Good morning, everyone. My name is Shirley Hibbert. I'm a Program Development Officer in the Ministry of Health and Wellness in the Emergency, Disaster Management, and Special Services branch. I want to especially welcome you to today, Day 2 of the 50 National Health Research Conference. It has been a wonderful time so far, and as we continue, truly, we expect some rich, highly educational sessions as we go through today. To start us off, we're going to open with our conference proceedings with the blessings of the Lord. And so I call upon none other than Mrs. Sanja Parchment. She's the Executive Secretary in the Policy, Planning and Development Division of the Ministry of Health and Wellness. Sanja, welcome. Please lead us to the throne of grace.
Thank you. Good morning. Let's pray. Most righteous, eternal Heavenly Father, how we worship and adore you. We magnify your holy and precious name. Lord, we come before you with gratitude in our hearts for your gift of life and all the other blessings you have bestowed on us. We thank you for this wonderful opportunity you have given us to gather at this 50 National Health Research Conference. We are not taking it for granted. Oh God, how we thank you for the commitment of the persons you allow to work every year to put this conference together. May you continue to grant them knowledge, wisdom, understanding, and the fortitude that is needed, as we know it is not an easy task. Bless this gathering and everyone present, scientists, researchers, healthcare providers, policymakers, and all the other persons who support this noble cause of working to better advance the health of our people and our nation. Gracious God, we ask that your wisdom and insight be so evident here today as we seek to examine solutions to complex health challenges that we face on a daily basis. May the research presented here today be a beacon of hope that will aid in paving the way for breakthroughs that will ease suffering and thereby promote the flourishing of mind, body, and spirit. Have your way as we ask these things in Jesus' mighty name. And we all say, Amen.
Amen. Amen. Thank you so much, my sister Sandra
You,
Parchment.
you are welcome.
And so we kick off day 2 with this feature presentation number 2. It addresses heat-related effects and health. And truly, this is very topical. And who better to start us off on this journey than our own Dr. Nicole Dawkins Wright. She's the director for the Emergency Disaster Management and Special Services branch of the Ministry of Health and Wellness. She also serves as the National Health Disaster Coordinator and is the director for the Health Emergency Operations Center, or as we call it, the HEOC. Not only that, she's a consultant emergency physician and the Ministry of Health and Wellness's climate change focal point. And if that was not enough work for her, she is also the focal point for the Smart Healthcare Facilities Program and the emergency medical teams. Ladies and gentlemen, Dr. Nicole Dawkins Wright is a committed healthcare specialist and public health practitioner. She's driven to contribute to nation building through the direction of programmed activities and that increase the resilience of the health system to optimize healthcare delivery for health practitioner, health protection and medical treatment in emergency and disaster situations. Please help me make welcome Dr. Nicole Dawkins Wright as she addresses health, heat-related effects, and health. Thank you very much.
Thank you, Madam Chair, colleague, friend. Let me first say thanks indeed to our conference secretariat, National Health Research Conference, for allowing me, honoring me, humbling me to participate in what is a very significant milestone, the 15th anniversary of the National Health Research Conference. I'm indeed quite pleased, and I don't take this lightly. I must also say, you know, it's one of these topics that's near and dear to me. So I'm happy that I have the opportunity to share on this particular topic. And guess what? You know, if you know me well enough, I welcome this time of year. Not only is this month a very special month, you know, it's my birthday. Amongst several others. Happy birthday, my colleagues. So, you know, that beautiful cake from yesterday, I do appreciate it. In all its sugary and salty state. Love it. But not only that, it just heralds another wonderful time of year when it gets a little chilly and we appreciate something a little bit more when we talk about heat, warmth. But like everything else in nature, anything in excess creates problems. So that's what we're going to talk about. So not only do we must talk about how good it is to get warm, we have to do things in moderation. Unfortunately, we have a problem, and that's the problem of heat. And it's an urgent problem. There's a lot we can talk about this. I could spend a whole day talking about this. I could sit with each one of you and say something differently. But our colleagues here is going to be very nice and say, no, Doc, we only have a few minutes. So I took the time to try and curate some information, which I think are nuggets. It's not comprehensive. It's food for thought to help to understand where you fit. And in keeping with the theme of the conference, everybody's business. It doesn't matter what you do. There's a role to play in this very urgent situation. And so, I've packaged that set of nuggets into 3 key areas, what I think are very pertinent and relevant to consider in the context of heat and health. And to segue into what is really the frame of how to address the heat-related effects as it relates to our health considerations, and that is the matter of what is now a very generic term, a heat action plan. That is what it requires. Now we tailor that heat action plan to our context, and so I will also go a little bit into where we are for consideration within the Jamaican context. Apologies for the fitting on the slide. It looked a little better on my computer and held better, but no problem. It says it. We have to start back at the fundamentals. As we point out, heat is not the enemy necessarily, unless we misunderstand and not appreciate that it has a role to play. We are beautifully engineered machines, you agree? And in that wonderful engineering that has happened for us as human beings, it works so perfectly that regardless of how diverse the temperatures are, generally speaking, as long as humans have walked this earth, we've done well to combat and match the challenges of temperature changes, whether it be very cold, from us below zero, several degrees below zero, or very, very hot. Somehow our body has always been so well equipped to maintain a very narrow 5-degree range of temperature between 33, usually in about 38.2 as normal. And we average about 37 degrees. And we do that because we have this excellent system inside of us, our thermoregulatory system, that works. Now, we could get into that and discuss it, but there are some key, very simple things. The beauty about complexity is that complexity is multiple simple things. And the simplicity of this thermoregulatory system, our skin, the sensors, our blood vessels that helps to control it, our muscles that work together, depending on what's going on. So that very stable core temperature is what helps us to optimize, enjoy this earth, enjoy this season, enjoy salt and sugar in our lovely birthday cakes, and enjoy the Yuletide season, because it works. And depending on where we are on the globe, we take advantage of things to help to maintain that body temperature. So back in the day, you can see I'm very young, right? Back in the day, we had houses that were on nice open spaces. If we got a little hot, we go outside, we sit under the shade, and we cool down. We're good. If you happen to be in the north and very close, we get fancy clothes, and we wear nice things around our neck. And we manage. We understand, yeah? So we get that, but things have changed. It's not a new issue, but there's something very different that renders this matter something topical that we need to talk about. How it works, it's a very basic mechanism, like I said. Simple thing as sweating. Some of us, like me in particular, I don't want to sweat. But some of us enjoy sweating, and we need to. It's necessary to keep, that's the main mechanism by which the body controls that temperature in that very narrow range. What does it do when we sweat? Evaporates and takes the extra heat off. Energy. Energy uncontrolled is going to do something. So either we control it or it does something. Energy is good. That's what heat is. However, when we don't allow it, our body to do what it's supposed to do. So for example, if we have a lot more air, water vapor in the atmosphere, evaporation doesn't happen. So if there's a problem in our environment that allows humidity levels to go up, then this beautifully engineered body with this simple mechanism of sweating doesn't work as well. And it's not just the human body. The same thing happens to the earth. If the earth is not able to manage its cycle of temperature and control through the movement of air in that normal way that we call climate, the earth also cries. And when it cries, we feel it. We had tropical storms, we had Hurricane Beryl, we feel it. The earth feels it. Similar things happens to human bodies, it happens to plants, it happens to animals. The higher the temperature, the higher we have to manage and move that energy around. Again, what do we need to do if it's a problem? If we are working harder, a lot of us, we go outside and we exercise in a controlled way. That's fun. But some of us have to work all day outside. We have to wear PPEs that prevents us from the evaporation from occurring. So in order to work properly, we now have to clothe ourselves and prevent that system from working. And that can lead to the bottling up of all that energy, and we now call that concept heat stress. When that happens, and this system that we have here in terms of how the body operates, because we have that narrow temperature to work, for the body to work, the brain to work, the kidneys to work, the heart to work, if it becomes overwhelming, the brain also doesn't work. So if we're handling a machine and our body is not able to cope with the temperature, we can end up with injuries, as simple as it sounds. You talk to our exercise physiologists, they do wonders with our athletes. But if they themselves don't recognize that that athlete must also acclimatize to the production of the heat that happens from exercises, then we have our athletes collapsing on the field. And so this thing that we enjoy, our annual events and sporting events, they become situations that threaten health. Our poor hearts can take it. We now recognize that we have an NCD epidemic in the country. If we are already working our hearts and our lungs to manage that high blood pressure, and then we add on to that additional work to control the body temperature, the heart is also going to give out. The kidneys are going to give out. In the system, in the buildings, they happen. So we sit in a building that we used to enjoy, the nice, comfortable wooden buildings. We now live in block and steel. Can't handle the heat because they also will trap the heat. Our vehicles, we've had news and episodes of our cars and what we transport in, has the same problem because we call that civilization. And that's necessary. But again, if we don't understand that that's what happens in terms of running heat, then what is supposed to make our life easier becomes the threat to us. And the thing about it is, like I said, energy doesn't sit. This is one of those things. You'll be comfortably here for a minute. Your body get overwhelmed. It passed that threshold. And within minutes, you move from just being a little dizzy to collapsing and not able to be resuscitated. That's now a heat stroke. And we see a lot of persons that are saying, oh boy, this was a lot of work today. The same work that probably 10 years ago would not have overwhelmed our body, not recognizing that probably we are not as productive as we used to be, or the work is a lot harder, simply because our body is working harder to maintain that lovely temperature. So we tired faster. We move slower. And it happens very, very rapidly. The expert who is going to resuscitate, the clinician who must manage the person who now collapses from this, can be very good at it, but will not get to that person who is succumbing to the extra heat stress fast enough. Would you like to guess how quickly this progress can happen? 3 to 4 minutes. Once that system becomes overwhelmed, that person collapses under severe heat stress within minutes. The nurse's station, which is just around the corner, the time it takes for that team to respond is too long to recover that person. So it means that whoever you are, whatever you do, the cameraman who's sitting right there and the person collapses right next door must be able to recognize that that person is suffering from severe heat stress and assist. How do you do that? You must know what it looks like and recognize it, because that's how we're going to render persons, because the science has told us that these maladies related to severe heat stress are completely and totally preventable. It's not inevitable. Everybody's business. That's our theme, right? Everybody's business. And so we can speak about the individual, the human body, and the ill effects. So there's a spectrum. The most common thing we see is fatigue. We can get dizziness or have fainting episodes. We had a few of that. Some of our schools would talk about that. And its most severe forms, we hear athletes, I get it when we exercise, heat cramps. and then more severe form, the heat stroke, of which mortality rate is as high as 90% if it happens. But that's not the only way it manifests itself to be a problem, because as we said, 1 in 3 persons in here and outside there has an underlying condition, and therefore they are less able to tolerate heat stress. The person who takes medication is not going to be able to manage and cool because we've now interfered with the normal cooling system. If it is that we have an increase, or already our system is already burdened, our health system will come under pressure because we have a problem, an increasing burden related to increasing exposure to heat stress. And those are the direct effects. There are indirect effects of extreme heat. We spoke about the matter of work. So if you're an economist, you're going to see the effects of it because your people are not going to work as well when you calculate what needs to happen. So when the health economist looks at what it costs to manage healthcare, probably it's going to be underestimated if we don't address the situation, because the burden on our health system is going to increase, right? In terms of what needs to happen from the amount of cost from emergency situation, that's going to go up. How we store our foods, how we store our medicines, all that is going to change. So we have increased wastage because for some reason the drugs appear to look unwell when we store them the way we used to store them, not recognizing that the temperature in that warehouse is now not what it used to be. So we're throwing away more stuff. Food, so we give guidelines in terms of our catering services when we say put the foods a certain way and put X amount of ice. That's not going to work anymore because, again, the same mechanism is changing because the way heat and that energy is moving is no different. But more importantly, every year we complain about, every couple of years, we have an issue related to our vector-borne diseases. We now recognize that these vectors are also changing their behavior to this difference in terms of our ambient temperature. And we've now characterized the common problem, dengue, a little bit differently. Is it related to the fact that our vectors are behaving differently because they're now adapted? They have adapted to increase heat on the environment. And so they're now much more effective at being the enemy to us and transmit diseases to us. So we have a greater problem related to these things that we think we know about, and we're experts at, and the burden becomes more. And it's not just that. Even if you're not in health, even if you're not the economist, even if you don't have to manage the facilities, the other set of persons who are working in other industries will now have problems as well, because productivity is going to be affected because their machines won't work as well. So the indirect effects are also myriad. What's the theme? Everybody's business. We need to know that this is a problem and it's an urgent problem. How we manage, of course, we have to prioritize. And there are some people or some situations that render persons or things or systems more vulnerable. We're focusing on human health. So the human health factors that contribute to increased vulnerability may be what happens to us. We now have more persons who are now aging, more aged persons in our population. So we have an increasing proportion of persons who are going to succumb to the issues. Because of the increasing occurrence of our chronic diseases, again, persons are more likely to suffer from increased heat stress. We now have a widening and burgeoning employment sector, informal employment sector. Most of those occupations take you outside. That forces those persons to be exposed. So occupational health and safety consideration comes into play. Even the way we do our clothing, how we equip ourselves and adorn ourselves, has also what we have to do, because you have to wear uniforms, for example. Some uniforms, we probably need to have a relook at what that uniform ought to be, because some of those uniforms are not conducive to allowing persons to adapt to the increasing temperature that we're experiencing. And so around the world, wherever you are, the vulnerabilities tend to be the same. Within the Caribbean, we have identified that there are probably about 6 main groups of vulnerable populations. We mentioned the elderly and the extremes of age, or chronically ill persons, or babies. What becomes sensationalized in the news, the occurrences with those very poor outcomes in our infants that are exposed. Again, minutes is what it takes when it becomes overwhelmed. We are now having a lot more persons who survive, but they are differently able. The disabled population tends to be at higher risk. And we're now seeing an increase in the number of persons experiencing homelessness. And so that increases the amount of persons who may be exposed. So the problem really is that we know we have enough data to say that in the current climate is a very data-driven concept. Very few things you can do in the context of weather and climate without having data. And the evidence is very, very clear that the average temperature of the Earth has already gone up. So our records are showing that wherever you are in the world, your average temperature is about at least 1 to 1.5 degrees higher. When we spoke about it last year, 2023 was the hottest on record. And we now have already evidence to suggest that 2024 is going to be even hotter than 2023 was. So if we think 2022 was hot when we complained royally, and 2023 was hot, that's probably going to be the coolest we're going to experience. I can remember my mom telling me that she used to enjoy hail as a childhood, in her childhood. Do I know what hail is? It's a reason, and we need to take these things and recognize that there is a difference. It is happening in the north as well, but let's keep it down on our tropical area, because we think that because as a tropical country, it's okay. We sell sand, sea, and sun. Is it now working against us? Because that is no longer a good product, necessarily a good product, because people can't enjoy the beach anymore. It's too hot. We don't have enough trees around. Most of the trees are being cut down for buildings. So even that is a problem. The concept of urban heat island is not what is happening. What that means is that even though the ambient temperature is recorded to what may not seem to be too significant, the set of persons who occur where there are a lot more concrete buildings, it's affecting persons. So just those numbers that we're seeing, urbanization, which is a developmental plus, is actually making it harder for us to survive in the context of increasing heat. So urbanization is working against us, albeit developmental, but it's working against us. And we've mentioned, of course, the increasing number of persons who are more vulnerable. Now, if you like numbers, numbers abound. If you talk dollars and cents, the dollars show. So we won't get into that, right? Because the numbers are alarming. The WHO facts, that's weird, all right? What that should have said, is that it's not the 5 or 10% increases in the occurrences of persons who are dying from occasions of heat waves. Do you want to guess the kind of rates of increase? Within the last 10 years, the rate of increase of persons who are dying from severe heat events is 87%. That's almost a doubling in 10 years. Now, if you're not alarmed, let me say it again. 87% are the facts. It's an urgent situation. That's dying. There are others. We all know that that's just the tip of the iceberg. So persons who have the other effects are also going up. That's what bullet number 2 is with all those squares in terms of the numbers. Right? It's not single digits. Right? Now, whilst this was a feature in the other side of the globe, even that pattern has changed. It's now right on our doorsteps. Our numbers are showing it, not numbers. Our anecdotal experiences are showing it. We don't have numbers because we have insufficient research data to suggest and directly tie it to so. And why that is so? We didn't think it was a big problem a couple of decades ago. We're tropical. We can handle the heat. We now need to really look at it. But we can't code it unless we are all very clear that we can diagnose it. Because it's in the books. We learn about it. You learn about it, right? We know what it is. When we faint from heat, we go to assembly at school, and every assembly, somebody collapses. Everybody knows that. You've all experienced it at school, right? Is it happening a lot more? And where's assembly at school? Out in the sun. And then one little nurse may be at school. One nurse may be at school. And again, how far is she from the assembly? And our children are now feeling it. We are saying that our classrooms are full and maybe that's impacting the quality of education. Is it possible that our children can't learn because the classrooms are too hot? Are we missing something? Everybody's business. And so climate and weather and heat, there's a lot of information, like I said, globally. But what we do know is that what I need to do in downtown Kingston is not the same thing I need to do in New Kingston. And so we can't just blanket and apply measures. We have to drill down and tailor to the context. We have a general idea as to how we can tailor some things in Jamaica. We still have a challenge in crafting that intervention, that initiative, because it has to go right down to community level. So whilst we know that this is the coolest year, whilst we know that most of our population live on the coast, those at the end of Portland will need a different intervention from those on Ocho. Same Northeast region, remember. But one little team now has to craft a different plan for the 3 parishes. And within the parish, they have to tailor it to the community level. Because that's what happens with climate and weather. And remember, when you are going to succumb, it's minutes. So it's not something that we can take our time to plan. Everybody's business. Who deals with urban planning? Who's responsible for that? Who deals with how people move in our vehicles that are now overloaded? And who deals with the fact that we're spending 2-3 hours in our motor vehicles, some of which may have AC, because we take some public transportation, don't have it. What happens when they come off that system? Are they functioning, or are they going to step off the vehicle and reach to the door and collapse? Because they had reached that point and we didn't realize. Do our transport operators need to know this? Who's going to say it? And how are we going to deliver that to empower every single person to understand what the situation is and what they need to do in that space? Who's going to tell the daycare center staff that the babies that they have there, they're burning them up in there? How are we going to handle that? Somebody has to do it. We know, again, our tourism sector, it is there. There are security companies, or private security companies, stand on the outside usually. And if you notice, most of them wear jacket and tie outside. Practical? Everybody's business. Our data has told us that we have also recorded the highest temperatures in the recent times here in Jamaica. It's not far-fetched. Most of our people, the data is showing, are living in more urban settings, so they are therefore exposed to urban heat island effect. It's our problem. That lovely blue bars to the right, that's the proportion of older persons who are highest risk. Those are who make that 87% increase. And then the babies are also similarly there. Within the Caribbean, we don't have specific data, certainly not for Jamaica, but in DOMREP and in Puerto Rico, studies have already documented that we tend to see a lot more persons attending emergency rooms during the heat season. In the Caribbean, we do have a heat season. In Jamaica, that's the graph on the right, there appears to be a correlation in the number of admissions to our public hospitals that is correlated to the heat season for Jamaica. But we need to be more clear so we can target our intervention. It's not just those acute episodes. For example, persons who do sleep disorders or manage sleep disorders have also documented that there are impacts on the quality of sleep. And we know the value of sleep. It's not just because the bed feels nice and because Yuletide season and it's warm. Sleep has a purpose. And if the quality of our sleep is infected, it has spin-off effects. So the sleep physiologists have now documented that where nighttime temperatures, which are going higher, accumulated heat stress is happening because our bodies are not cooling down the way they used to during the night. That doesn't happen. In parts of Africa, lots of studies that look at the quality of foods in relation to where there are pockets of heat. So our nutritional considerations now need to factor that nutritional value changes because of heat effects. How much we don't know. But we need to know because we understand that nutritional guidance is important for health. So we need to know. Oh my gosh. I don't know what's happening here, but sorry about that. So in the multiple squares was really to say, again, it's everybody's business, and there are ways to address it. Now, the way we do it is through heat action plan. And like I said, that's the term, the generic term. A key part of that is an early warning system for heat, because like I said, this is a very time-sensitive condition when we get complications from severe heat. And so it's important that whatever system we put in place has a time component, because time to respond is critical. And that's what makes a difference. Right? So everybody needs to know what it is so that you can put a measure in to adjust and provide and keep the person from succumbing to the ill effects of severe heat stress. We need to organize in terms of our planning. Right? Caregivers need to be taught. But at the very crux of it is the matter of monitoring. You can't monitor something you don't know what to look for. Right? So we need to change that. There are different guidance that's available, but they all say basically the same thing. If you're going to make manufacturing companies, the science and technology development, there are things that are more adaptable to a warming climate or a warming space. So industry needs to get on board and manufacture things that are more conducive to the state of affairs. Or guidance in terms of how much water we tell people to drink, as basic as that, comes down to it. When we have our occupational health and safety wardens in our workspace, they need to know how to advise their staff how to work, how to pull their teams together and deploy them. When JCF or JFP, etc., deploys their team, they need to know when to pull them back so they don't collapse under the stress. So all of those things are there to guide it. But the fundamental thing is that it's everybody's business. It requires a systemic response. Right? So whatever it is, it may just be a simple matter of general guidance on the first aid for any of the conditions that are heat-related. But we need to advance to a policy position from a country perspective and develop a heat health policy that is applicable to us. Policy depends on evidence, it depends on information, and it depends on what we know. We usually, everybody knows, because we're used to rainy season, no event organizer plans an event and don't have a wet weather plan. It's now clear that we also now need to have a hot weather plan, routinely. We get wet weather, hot weather is not so common, but we now need to make that normal. That's something we have to work on. Right? We are working now on the matter of how we share information. Information is readily accessible now. How do we create information so that we can be very responsive with bulletins that speak to heat stress in our country? And of course, it comes down to why it's everybody's business, it's personal responsibility to protect ourselves. And so we know that we have a challenge because we have already documented and affirmed that the professionals, the healthcare worker, knowledge of this situation is grossly insufficient. And so whilst we are to be the go-to, we don't have that level of awareness that allows for it to happen. At present, we don't have enough research to specifically craft the intervention. And whilst there may be generic standards globally, we have to tailor standards for the Jamaican context. We can't craft the standards for our context as yet. So even though we know we have a problem, even though our hospitals and our A&E departments are showing ill effects, We can't speak to what needs to be the standard as yet. So there's work to be done. But it is necessary, right? We have to recognize that more and more persons are going to be falling. More and more systems will collapse because of the heat, right? Right now, we don't have mature systems to address the problem as urgent as it is. And so whatever we do, the approach is going to be in addressing those threats, a risk management and mitigation posture that we need to have, because things will go up. We need to build the health system's capacity to deal with the effects, the ill effects of extreme heat. We have to go across sectors to ensure that we have heat wave health risk management plans. That is multi-sectoral and multidisciplinary. We need to get there. We need to prepare our health facilities to better handle fallouts from severe heat stress. And we need to complete the plans in terms of our heat wave early warning system by the health sector so that when it happens, we can deal with it. Again, we need to have the policy, not just operational policies, but national policy. That is not just going to be at that level, but we have to take it down to our parish levels, right, so that it can be handled and it becomes a standing item for discussion in terms of what's going on in the community. And of course, build the community resilience by empowering our people at that level. Do we now need to build in our spaces cooling centers in our town centers? Do we need to put them in schools? Maybe. Do we need to have it when we have mass gathering or events? Clearly. I don't know how often you see it, but I don't see it very often. But it is necessary, right? And so, just to share that some work is being done, so it's not, we are not at a loss. We have started, thanks to the communication team who will highlight the issue with the anecdotal events, but we do have a national policy framework to guide it in, and we have already taken up to a year and a half ago, we would have sat down and had that everybody's business conversation with multiple sectors to discuss within the context of climate change for health, and of course, the people who consulted said heat is one thing that we must address first and foremost, and so it comes out. I must say thanks and thanks and thanks again that we now can bring this as a feature conversation at this forum, because I think this is one certain way we're going to ensure that we elevate the level of awareness of the challenge that we're having. And I hope, Dr. Grant, that I can stand here at this podium again next year and speak related, because it is important. We've started and just piloting in terms of our curriculum, but clearly we need to get into more in the education aspect and expand what we're doing in terms of that. And just to mention again, we don't have Met Office here right now, but of course capacity has been built with our Met Office to be able to provide climate and weather services aligned to heat systems. And now what is needed now to advance that is to link that information to our health data. I think this may be our last slide. There are policy information that has been provided as guidance for us. So we're not without resources that can help us. So maybe Dr. Webster-Carr, one of our policy forums, can speak to how we deal with this matter soon and very soon, so that we are not caught flat-footed on this, because we know what is going to happen in Jamaica. Ignorance is not our excuse anymore. It used to be a decade or so ago. We now have very sound facts that tells us what we are anticipating and how soon. That's not an excuse anymore. We've started the matter of our early warning system. That's still early, it's not a year yet, but still it's an experimental stage, so we will go through measures to take there because we recognize it's urgent. So we started it, and it's really was a remarkable milestone for us in country, and we now need to push forward on it. In terms of the stakeholder consultation, we need to beef this up, obviously. We have started, but we need to go more. I can very proudly say and happy that the National Disaster Risk Management Council is now prioritized it as one of the activities that we need to do, and it is now mainstreamed in the conversation for Ministry of Local Government in terms of urban planning and fact. So it is now prioritized, and so we must not miss the opportunity that has presented itself, because, again, the stars are lining up. so that we can properly address this in a comprehensive way and address the matters at hand. Again, the theme is quite appropriate for this particular topic. Addressing the adverse effects of extreme heat is, in fact, everybody's business. I thank you.
Let's give Dr. Dawkins-Wright a resounding applause for that very insightful presentation. Thank you so very much, Dr. Dawkins-Wright. It's everybody's business. It's now time for our question and answer session. Do we have any questions from online or in the audience here?
Good morning.
Good morning.
There are two questions online. The first goes, what effects has the heat wave affected our elderly in Jamaica in regards to hospitalization numbers, as well as, is it possible to review the effects of classroom temperature on students' academic achievement or performance?
Proceed? Good? Yes? All right, great. Thank you very much for that question. Yes, indeed, we do have a problem. Unfortunately, at this time, it's anecdotal. Again, as I would have pointed out in the presentation, in terms of how we capture the data at present, documenting and recording someone presenting, even in the elderly, with a heat illness, we don't know the scope and the extent of the burden of that problem, because we don't capture it in our e-codes at present. It is something that we need to address, but from anecdotal experience, and again, the elderly is recognized as a vulnerable group. It is the group that is showing the most significant increases in poor outcomes from extremes of temperatures around the globe. We have observed it in country, but to say that categorically, convincingly with data, we don't have it. So it is in fact a problem. In terms of what is happening in our classrooms, again, this is now on the table for conversations, recognized as a challenge. Certainly within the education sectors, the parents will render that as a concern, because the children complain when they go home. The teachers are experiencing it, and so I do know that there's a conversation around rendering the space within classrooms a lot more accommodating to deal with the effects of increased temperature. How bad the problem is at present, we don't know. So there's work to be done in terms of putting a number or figures and science and data to it. But we know experientially it is a problem.
Okay, thanks. And there's one more. How soon can we expect the sensitization of the HCW and the public to get started?
Let me just update. Thank you again for that question as well. So as indicated, we would have had a consultation in terms of how the plan of action for our public engagement in the context of heat extremes. And in July of this year, we crafted or reframed as to how we develop that plan to expand that sensitization program. I see Mrs. Hodges right around the back there. She does know that we have work to do. Our PR team is also fully on board, and we anticipate that we should commence full activities within the next 12 months. We will scale it, obviously, because it has to be tailored and contextual information. And so we anticipate you'll see a lot more coming out within the next 12 months.
Question in the room, yes.
Not a question, but certainly I want to thank you for such a powerful presentation. We know that climate change is a very topical, it's very topical in today's, globally and even locally. And I am happy that you came and shared with us today and anchoring the theme about it being everybody's business. So while we take care of the communities or the persons whom we are advocating for and, nudging that, I'm hoping that the message would be cemented with us as healthcare providers so that we too can tap into this resource for ourselves. Because if we, so I'm sharing that, anchoring that part, that everybody's business, we need to take charge of that and ensure that we are also looking after ourselves while we are engaging to help others to improve their level of health within the society. So thank you very much. I feel more transformed this morning to go out and be just there, badgering for us to improve as it relates to climate change and the heat situation on the ground. Thank you.
I appreciate those extremely very kind words. And I am very happy that we can see the measure of where it's going to go. In terms of empowerment, it starts with me. It starts with self. Thank you for that.
No more questions. Well, thank you so very much. You've been such an attentive audience. And we are going to take a short break, and then we'll get right back to you. Thank you so much for staying with us.
Two months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are gonna drop.
No go so. A 5 I want me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear them talk about breastfeeding support with the clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to,
I don't eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
Good morning, everyone. We wish to express our great appreciation to Dr. Dawkins Wright for such an excellent and thought-provoking presentation. And as we, at this time, recognize that this is her birthday month, as she has shared, we hope that this will be another aspect of the celebration, and definitely we will be inviting her again. So thank you so much, Dr. Dawkins Wright.
Thank you very much. I do appreciate it. You're welcome.
Thank you. And we also wish to thank Mrs. Hibbert. We want to express our appreciation for the time taken to moderate the session, and she did so excellently. So thanks very much, Mrs. Hibbert. At this time, we will return to commercial break.
What you girl?
I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are gonna drop.
No go so. A 5 hour me breastfeed. And none of my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor. Me hear the matter about breastfeeding support group down at clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to, you know.
They're going to eat Friday when I go clinic.
And make sure you ask for the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water cycle in open container. For them we read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, you fi burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. If they in at the table, on the side or the back. If you check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. If they in at the table, on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You for zoom in on the nutrition facts. If they in at the table, on the side or the back. Vitamins, minerals and vitamin 2, 20% and more. That good for you. You for zoom in. Check the nutrition facts. You for zoom in. Check the nutrition facts. You for zoom in. Check the nutrition facts. Less sugar, less salt, and less fat. You for zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica.
Zoom in on the nutrition facts. If they in at the table, on the side or the back. If you check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. If they in at the table, on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You for zoom in on the nutrition facts. If they in at the table, on the side or the back. Vitamins, minerals and vitamin 2, 20% and more. That good for you.
Pleasant good morning to everyone. I was going to say warm welcome, but after the presentation session before, I better say cool and, greetings to everyone. And thank you for joining, both those of you present here in the hall and those of us joining online. This is our special presentations session, special presentations about applications of technology, as in information technology, in public health. In this session, we will explore the use of technology within the public health system. The special presentations will allow practitioners to give greater insight as to how information technology is or can transform the healthcare landscape in Jamaica. These presentations are about data, information, and knowledge about e-health, about digital health, and there are obviously, hopefully obvious to you, a number of policy issues as well. There are two presentations in this segment. Firstly, we'll hear from Ms. Rachel Cockett, who will tell us about an application designed to reduce or eliminate delays experienced when using hard copy or paper-based mechanisms for Class 1 notifications, and then we'll have the Q&A in the usual way from the audience and those online. The second presentation, we'll hear from Dr. Talia Gervan, who will tell us about SNOMED, which provides a standardized way of representing clinical phrases, clinical concepts, and enabling automatic interpretation, and then question and answer. So Ms. Rachel Cockett on my right is a member of staff in the epidemiology unit of the Manchester Health Department within the Southern Regional Health Authority since October 2021. Under the supervision of the Parish Medical Officer of Health, Dr. Nadine Williams, the epidemiology unit aligns with the parish's surveillance department. Rachel is a past student of Manchester High School and a past and returning student of the University of the West Indies. Her academic qualifications and work experiences are core and business information technology related. However, her passion remains lifelong in health and wellness. Ms. Cockett remains rounded in her extracurricular activities in every organization she has been a part of, often equipped with leadership roles and responsibilities. Therefore, ladies and gentlemen, let us make welcome Rachel to the podium as she presents on revolutionizing vigilance notified. Revolutionizing vigilance notified.
Good morning, everyone. All right, that was a bit of a tongue twister. I'm hoping I fare better. So it's revolutionizing vigilance through an application named Notified. All right, so just to give you a little bit of a backstory here. When I started to work at Manchester Health Department, and I got exposed to the notifications, the hard copies that would come to my desk, each time in my mind, when I saw a notification, there's a little saying that would come up, "You've been notified." In my head, it kept playing each time I saw another notification. And then I thought to myself, why is this not an application? Because it has all the features of it's an alert system basically. And it can be simply formulated into a type of messaging system where alerts come on time with all the necessary information. So there and then I started to draft my ideas in terms of Notified as an application. So to begin, what is Notified? So it's an application designed to reduce or eliminate delays experienced with the use of hard copy Class 1 notifications. And all being a part of the public health system, we know that this is a factor that we face a drawback that we face in terms of the turnaround times receiving, submitting, and addressing notifications. Secondly, it's an application designed to efficiently and effectively collate data by any given demographic detail, for example. This being said, for example as well, in Manchester, we have the regional hospital. So notifications come from varying parishes for patients with different diseases, syndromes, events, conditions. So therefore, the app itself would be able to filter and collate patients based on their address information. Thirdly, an application designed to give more of an accurate representation of epidemiological data for any given geographic location. So we know that the notification in itself has the type of class 1 specifically disease that is being notified for. So we'd be able to collate and filter according to that information presented. How does Notified work? So it's a real-time database of all licensed to operate medical professionals nationally or locally with core functional access to the application as notifiers. So correct me if I'm wrong here. Each license to operate medical practitioner has a unique number assigned to them. This number can be incorporated into the app as a part of their registration process, as users of the app as notifiers. A simple template would then come up, which would be reflective of the current notification sheet to be completed by the notifier. It's a prompt system that instantaneously delivers notification once submitted to the inputted parish, regional, and national levels without saving said data, which will be submitted. Why this pointer is important, there's a lot of information that comes in when we count notifications on any given week, month, year, especially during outbreaks or pandemics, for example, COVID. To create an application would not be able to support saving all of that information. So it just needs to be a medium of submission. So once the notifier goes in and inputs the information, all required fields, and submit that data, it's sent off and not stored on the app. So it simplifies the system, and it doesn't create a whole need for each person that uses the application to have this large storage or then be exposed to security issues, which is something that we currently have. Emails are hackable. WhatsApp isn't ideal to send certain communications, to eliminate that whole security aspect. We do not save this information via the app. It's an added alert system or option with a ranking scheme to submit unofficial cases of concern. This point becomes relevant with the theme as well, where health and wellness is everyone's business. Sometimes a neighbor or someone else is becomes more exposed to a particular condition or sees a certain situation before a health practitioner sees it, before it's presented to the health system. Upon a situation like that, a neighbor may be able to, further down the line, not right now, when the application develops, may be able to log in as a case of concern, input the information that they have, and submit based on what they see happening. So it's like a heads-up system. Why use Notified? So with real-time notifications, the scale will become more heavily weighted on the side of prevention rather than that of damage control or cure. The basis of the application will still be largely notifications upon suspicion, of course, and that will almost, if not immediately, be placed under investigation through the members of the public health system. By extension, with the already existing messaging system in place to advise the population of general matters of concerns, Notified can be easily incorporated to provide advisories where necessary or applicable. So therefore, to say, do you remember in COVID, if there was a particular case that was in your area, I don't know if anyone ever received a message to say, there's concern of a COVID case in your area, so please be more I can't remember the exact wording of the message, but I remember receiving a message before where we were advised that a case or cases of COVID were in the area, so we should take further precaution because we might be exposed to it. In the case of any emerging pandemics, this system can easily be incorporated into the messaging system to advise the population of any new cases of concern without a general scare, to say incorporate further precautions because there's concerns in the area. When to use notified, Predominantly, notified will be used for Class 1 notifications at first point of medical contact upon suspicion by the notifier. Additional features of the application will allow for notifier to create a notification for any other case to be placed under investigation by the surveillance unit at the various levels, parish, regional, or national level. A final feature, which is what we spoke of earlier, that allows for unregistered or unlicensed healthcare worker with basic demographic and contact detail of a patient to rank and create an alert for a case of concern. Where can notified be found? Just like any other application, notified will be a downloadable application to any smartphone, tablet, laptop, or desktop device. Access to the application will, however, be limited or restricted to the intended user. Notified user interface will vary according to parish, regional, and national levels. This variance will accommodate to the functions of each level, which each level, such as regional or national, is expected to perform with the data received. Database entries, investigations launch, generation of graphical data, collation of reports, production of printable copies will be manipulatable accordingly. All right, getting into it. So for this section, I wanted to have a prototype here, but given the time constraints, that wouldn't be feasible for each person to sample the application. Moving on. Current drawbacks and why the application is necessary. There are currently statistical gaps in data at varying levels, parish, regional, and national levels. Private practices whose data are not added cumulatively to database due to reporting requirements that may or may not exist. So the app itself would also allow for private practitioners to send in notifications based on cases upon suspicion or cases of concern. So there is that extension to the wider group, persons who aren't immediately employed to the public health system. The simplicity of the application allows for easy understanding and incorporation into daily life or their daily practice. The ease of access to the application allows for less running around with getting a notification done and submitted. Physical delays experienced in movement of the notifications from location of generation to appropriate parish of representation for investigation. So an application would eliminate this drawback. Notification can also become lost or misplaced in transit. Illegible data that creates an obstacle in contacting patient, launching investigation, and completing data entries would also be a thing of the past, as we would not have to be deciphering through the varying handwritings that we sometimes receive. Incomplete notifications that have missing important patient detail would also be a thing of the past, as there would be required fields on the application that the notifier would not be able to move beyond until it's completed. So more completeness. No notification booklet being available on hand at first point of contact with the patient would also be a thing of the past. So even through the introduction of this application, it's not saying do away with the physical booklets. We're always going to have the paper booklets as a backup, but also now transform the system into something hybrid where you have soft copy and hard copy available to get the notifications done and submitted. Notifications done at the start of the weekend that are, well, this is also something that we face. Notifications which are sometimes done at the start of the weekend, because, you know, we're public sector. We're not really at work on the weekends, that are sent to the representational parish sometimes aren't acknowledged until the start of the following week. With an application as notified, that would also become a thing of the past, because once a notification is submitted to a particular parish, there's a copy or duplicate that's also sent to regional and national levels. However, the parish would still hold, there would still be the protocols as is to have the acknowledgement of the notifications done by the medical officer of health and investigations done within parish. But in the case of an urgent case of concern, once that notification comes in at any point, the team can know what to do next based on level of urgency. While there are many aspects of local government that are very much paper intensive, there's an irrefutable continuous global shift to simplify and advance life through technology. Notified is a step in that exact direction. It's also a response to have on hand when responding to emerging pandemics. A tool geared towards improving the response time of the public health worker. Under the Ministry of Health and Wellness, considering the mission statement, considering the purpose of surveillance, and considering what epidemiology is, Notified becomes a central accelerator to new yet achievable standards in healthcare, a clear indication of the care for health nationally. An opportunity to create a strong merger in the most effective and efficient direction. For example, with the move of PAHO to technologically advance the health ministry via smart clinics, epidemiology, surveillance, and management information system will become more formidable, relatable force or entity. Food for thought. Could this application be life-saving? Improving responsiveness to gatekeeping capabilities. Would there be a greater analysis of our strengths, weaknesses, and opportunities and threats if we eliminate drawbacks by efficiently and effectively incorporating the app into the system so that timeliness is recognized once a notification is submitted? A basic review of World Health Organization website revealed a need or look into digital health. This is a move in that direction. Data-driven healthcare or policy, important for policy making, will become more accurate as notifications, deduplication, time spent for deduplication, drawbacks in terms of turnaround time for submission would be eliminated. Though we are passionate about our own areas, we're just one perspective, and that was by Dr. Kenneth Sher, Policy Implementation, the Case of Congenital Syphilis lecture. Thank you.
Hey, thank you so much, Rachel, for really interesting, enlightening presentation. I didn't know this was happening in your head. And while the people are putting their questions together in the room and online, I'd just like to say, I might say inappropriate things. I'm over 60, so it's okay. You probably have a career in health informatics, but you just don't know it yet. Okay, so just send me your CV at Michelle. Okay, time out. Right. So let's go to the serious work. Are there any questions from persons in the room? Oh, you're not allowed? Are you allowed? Okay. Okay. Yeah. Any from the floor first? No? Yeah? There is one? Okay, so Dr. Dawkins, right? This is their mic for her, please.
Thank you very much for that. And, modernization of our systems is always something I look forward to. Just to confirm, is it that it's conceptual at this time, or you've actually developed same and tested?
Hearing me?
I don't know if online is.
Oh, hearing me? Okay. All right, so no, it's not just conceptual currently. I have a sibling who is in the computer programming system at UTech, and from 2021 I introduced the right to him, and he has been working on it. When I saw the time frame for the presentation today, I told him he didn't need to wrap up anything to bring here today, especially he's really involved in exams right now. But he didn't need to wrap up anything because the time given, we wouldn't be able to go through the prototype that we have. So, yes.
And the other short question, just for clarity in terms of its functionality. So once a user clicks submit, can that user go back in and edit? So there's no editing option?
No.
And there's no room for correction of information?
So the user, if there's a need to submit information that wasn't submitted, when you click submit, you would have to just recreate another notification and send in. There's a comment section. You can link the invoice. For example, you have an invoice number, a sheet number attached to each. Yes. So you would reference what your receipt number was on the previous that you're sending in the new notification as a correction.
You can always link it. Okay, understood. Thank you.
Yes, you're welcome.
And congratulations.
Thanks.
Hey, Dr. Gervin.
Hi. Morning. First of all, we'll have to talk after this. Can you clarify the data points that you're looking at collecting? Like, is first name, middle name, last name, date? What are the points that you want to collect?
All right. So for everyone here, I think they're fairly familiar with the notification booklet. On the booklet itself, there's the date of reporting. So really and truly, as is everything there is crucial, but there are certain information that should not be missing, such as first name, last name, address, the syndrome or the class 1 disease that you're sending in the notification for, onset date seen, so forth. There's certain information that, as is via protocol or what is expected now by the surveillance unit, will be upholding on the app. You need to complete those information.
Okay. So it's pretty much almost a mirror image of what's in the book now. Okay.
Yes.
You had mentioned that the data collected wouldn't be stored in the app.
No.
But then towards the end you said that we would be able to do some data analysis like graphs and stuff.
So once you click submit and the app goes off to the parish, that's the other phase now of the plan, where in parish they would have to have data banks. So once it's submitted from the application, it goes into a bigger system in parish, in region, or nationally, where each person with their different responsibilities go through.
So the analysis would be on that end, not the app. Okay.
No, not the app end.
Thank you. That's it for now.
Yes.
Okay, thank you. Other questions from the room?
Sorry, Dr. Ruth, thank you so much.
Deputy Chief Nurse X.
Miss Cockett, thank you so much. I hear your passion, and I'm happy that you brought this to the forum because, you know, as a surveillance, we have had discussions before, right? And as a surveillance officer on the ground, we have been grappling with a lot of issues regarding the timeliness of these notifications. And I'm glad, you know, Southern Region, young lady. I know the team in Manchester is really embracing this because I've spoken to nurse on the ground as well. And I'm certain that, you know, I will be embracing it at discussing it with Doctor at the region because I really see how, you know, if you're given the support with this particular thrust, it can really take us to another level as we move forward to close the gap with these notification issues so that we can improve the quality of data, reports, and what we are doing for people on the ground. So thank you so much, and I'm looking forward to have further discussions with you, and we'll be embracing it even further to take it to that level so that we can have this product in the region.
Yes, thank you, nurse.
Executed.
Thank you very much. Any other questions in the room or online? Okay.
Good morning. The question follows. The app should not have lay persons gaining access as the verification process for the notification get removed in such an instance. Why give lay persons access then?
Why give them access? So immediately it's not a feature, but down the line it's definitely something that we're considering because sometimes, for example, they tend to say that men have poor health-seeking habits, and sometimes someone else in the household, for example, knows of a particular concern before any medical practitioner can. Want to give them an opportunity to just send in a case of concern and not overlook it. Of course, this has not been fine-tuned, so open for discussion there.
Okay, thanks.
Is that it for online?
Yeah, that's it.
Right. So, no more? So I can say the last word, huh? Only for today. So, Rachel, thanks again for your presentation. I think the last words hung on me probably the most. Though we are passionate about our own areas, we are just one perspective. It's not a put down, but it's a very important statement by whoever the person was, which you should really bear in mind because digital health, e-health, and the governance of all of that, information systems for health, is very, 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 very complex, very difficult. You have everything from advocacy from the top all the way through, policies, and more policies, all kinds of specialized skills, more than IT, more than health informatics, and the whole governance. How do we make decisions about everything? But there's probably a second CV you need to send to me, nevertheless. But thank you very much for the thought-provoking presentation. And it's good to know that in the field you're trying to help yourselves, but we still have to bring everything back to center for decision-making and so on. So thank you again, Rachel. Really appreciate that presentation. Let us give her another round of applause, please. So moving on to the second special presentation on the information systems. Let me introduce Dr. Talia Gervon, who is a clinical informatics analyst in the Information Systems for Health branch of the Ministry of Health and Wellness, which is within the Policy Planning and Development Division. Dr. Gervon brings over a decade of invaluable clinical experience to her role, having served as a medical officer at the Bustamante Hospital for Children. She has a deep understanding of the unique challenges and complexities of pediatric healthcare. Her first-hand experience in cardiology and emergency medicine has equipped her with a comprehensive knowledge of patient care, workflows, clinical decision-making, and the critical role of accurate and accessible patient data. Leveraging her clinical expertise, she's committed to advancing healthcare through effective use of technology. And let me just add 30 seconds here. So we work together in the same team in the IS4H branch. I'm going to say it's an absolute joy working with Dr. Gervon, but she's appointed, so she's not available. Let's just make her welcome to the podium as she speaks to us on the development and release of the first SNOMED CT Jamaica edition, a milestone in national health informatics. Dr. Gervon.
Thank you, Dr. Ruth. Good morning, everyone. To add, I'm from Clarendon, so I'm kind of from the south too, so you know, yes. Thank you for that introduction. The work that was done on the development and release of the first SNOMED CT edition was done by myself and Dr. Keisha Barwise, who is the Digital Health Standards and Health Informatics Consultant, and of course, Dr. Ruth as well. So I'm very, very excited and very, very proud to discuss the SNOMED CT and the Jamaican edition. So what is SNOMED CT? So it is, well, first of all, let me say SNOMED CT stands for the Systemized Nomenclature of Medical Terms. It's the most comprehensive, multilingual clinical healthcare terminology in the world. It is a resource with comprehensive, scientifically validated clinical content. The SNOMED CT clinical terminology has unmatched depth, enabling clinicians to record data with consistency and enhanced accuracy. SNOMED CT supports the development of comprehensive, high-quality clinical content in the electronic health records. It provides a standardized way to represent clinical phrases captured by clinicians and enables automatic interpretation of these. So we need to get you to know SNOMED CT as well. So SNOMED CT creates a common language for clinical information and ensures consistent and standardized data benefiting patients, healthcare providers, researchers, and data scientists. So consider a patient being admitted at various health institutions and diagnosed with the same disorder, but they're worded differently. For example, let's say Maypen Hospital, the patient is diagnosed with intervertebral disc prolapse. And then they go to the Denby Health Center and they're diagnosed as prolapsed intervertebral disc. And then they go to their local health center, another health center, and all they write is slip disc. So there are 3 diagnoses in the 3 different records, but they're the same clinical meaning. So when data is recorded using these diverse descriptions, data analytics can prove to be challenging. So what SNOMED CT does is it allows new software to capture data consistently, regardless of the specific user or healthcare settings. This standardized data is then easier to analyze and use within the application. And this is just one example of how SNOMED CT can be used to improve healthcare delivery and interoperability in the Jamaican healthcare system. So our goal was to develop a SNOMED CT Jamaican edition to facilitate further integration into clinical applications in health. So our key objectives were to create new SNOMED CT concepts specific to the Jamaican healthcare system, to incorporate our local colloquial terms as synonyms to already existing SNOMED CT concepts, and to establish mappings between SNOMED CT and other coding systems that are commonly used in Jamaica. Okay, so let's look at how we went about doing this. So in 2022, Jamaica first joined SNOMED CT via an affiliate license. So after we embarked on the procurement of our first national electronic health record system, we then became a full-fledged member of SNOMED International in 2023. We are the 45th member of SNOMED International and the first Caribbean country to become a member. So Jamaica is represented in the SNOMED International by the Ministry of Health and Wellness, specifically IS4H. And our Information Systems for Health branch has the responsibilities of the National Terminology Release Center, which is the hub of all things SNOMED CT in the Ministry of Health, as well as other terminologies as well. So then in July of this year, we successfully released our first SNOMED CT Jamaican edition. Because of the So I'm sorry, I'm not able to show you and to play with the browser because of time constraints, but if you want to see, just let me know and I'll guide you through it. So since becoming a member, we've established the National Terminology Release Center, which I mentioned before. We have our National Terminology Release Center email. We are currently in the process of establishing guidelines and standards for access to and national distribution of SNOMED CT, as well as other terminologies. We've attended SNOMED International business meetings and expos, both virtually and in person. Most recently, last month, are we in November? Yes, last month we went virtually to the SNOMED business meeting and expo in Korea, which I'm sure Dr. Roof enjoyed the 7 p.m. to 3 a.m. Meetings, but it was awesome. A few of us have completed the SNOMED CT Foundation course, and then some of us have gone on to start the implementation course. And we've already started, and continuing as today, sensitization efforts to various stakeholders, introducing SNOMED CT at various health forums and to various healthcare providers, including clinicians and health record coders as well. So being a member of SNOMED CT International allows us to have access to multiple training opportunities and innovative tools such as mapping tools, specifically Snap to SNOMED, and the RefSet and translation tool that allows us to add our colloquial terms as recognizable in an EHR. So far we've created a few new concepts relevant to the Jamaican health sector. One of those concepts is accidental ingestion of bleach. So in SNOMED, in the general SNOMED CT browser, you'll have accidental ingestion of poison or etc., but specifically bleach. They only had like not accidental, but like intentional, to say you wanted to poison somebody. But in our setting, especially with my pediatric background, I see that this happens a lot, and I see where we could use a concept like this, the accidental ingestion of bleach, in research and in creating new policies, etc. We've also added colloquial terms as synonyms to existing SNOMED CT concepts. So if you go to the SNOMED CT browser in a Jamaican edition and you type in hand middle, you will see exactly. You will see I always use running belly. Running belly is there. Foot bottom is there. Neck back is there. We've done a lot, and those colloquial terms, we did a lot of research, even from before I started in IS4H. We did a lot of research reaching out to doctors all over the country. What do patients come in and say? How do they describe this? You know, them say, tumok, you know, so those things. And of course, it's not extensive, and we can add as we go along, because I said this is the first edition. So we're working on just developing as well. So with Snap to SNOMED, we were able to create maps from SNOMED CT to the Roche LIMS lab coding system, as well as a partial map from SNOMED CT to the International Classification of Procedures in Medicine, which is the ICPM. So that partial map is just looking at the surgical procedures and this map can be integrated into various digital tools. So this is a milestone achievement for Jamaica. The SNOMED CT Jamaican edition is a huge step towards enhancing data quality in clinical documentation, improving interoperability by enabling seamless data exchange between healthcare systems, and improving healthcare for patients by supporting evidence-based care and informed decision-making. So, what's next? So the Jamaican NTRC, or the National Terminology Release Center, will continue to upskill and strengthen our team so we can continue to enhance the healthcare system of Jamaica for Jamaica's SNOMED CT implementation. So the Ministry of Health and Wellness is working on integrating SNOMED CT into our national electronic healthcare records, and also other data collection platforms, so like, you know, registries, the National Cancer Registry, the Electronic Immunization Registry, and whatever else comes as well. So we will continue our training and sensitization efforts for healthcare providers and other stakeholders. We also want to share our experience with SNOMED CT and encourage other countries, particularly in the Caribbean, in our region, to consider, you know, SNOMED CT in the region's digital health transformation. So, okay. I hope I wasn't too quick. So in conclusion, the development of the SNOMED CT Jamaican edition is a significant step towards achieving a robust national health informatics infrastructure. This initiative paves the way for improved data quality, interoperability, and patient care in Jamaica. The Jamaican experience can serve as a model for other countries in the region embarking on their digital transformation journey. So thank you, and thank you in advance for your questions.
Hey, thank you, Dr. Gervin. So while people are scribbling questions or thinking out the questions, let me just say a few things. I've said to our team in the branch more than once, more than twice, and I'm sure I've said it to CTD, Mr. Lynch, who's our boss, and I'll say it to you. This is a personal opinion, okay? It doesn't represent a team. What we're doing in information systems for health, one thing you just saw here is SNOMED. I believe that it's the most exciting thing happening in the Ministry of Health and Wellness at this time. I really, really believe that. It doesn't matter that we're such a small team or you're not hearing a lot about it. We know, we believe, so we keep working at it. The other thing to say is to emphasize a little bit, well, first of all, she didn't speak the truth quite at the beginning. I had nothing to do with the Jamaica edition release and all of that, except to make sure the money was paid, okay? It was herself and Dr. Keisha Barwise, period. That's the truth, okay? Right, so any questions from the audience present here? Make sure there's at least one. Say something, please. Yes, Mrs. Hibbert. You have a mic?
You don't have to twist our hands. We have questions. Congratulations. Thanks very much for both presentations. Lovely. Just one little thing. I recall my sister. She's much older than I am. She went to the doctor one day and told him that she was having operation, which meant running belly. So I don't know if you have that one.
Maybe it's just me. I believe so, but I think the issue was, I think some terms like operation somewhere else, like in a certain region, maybe something else. But I don't remember. But afterwards, I can pull up the browser and show you.
Okay. If it's not there, it can be done because the editions keep being updated over and over. Okay. Any other questions from the floor? There is one. Oh, sorry. Yeah. Dr. Dawkins, right?
Thank you again. And I just wondered, in terms of the updates to the edition, I think what I'm paraphrasing here is that it almost sounds like we're putting the Jamaican dialect into the standardized nomenclature. And I'm saying that because I do know that the dialect of the Jamaican dialect is very, very diverse. And I wondered if it is the audio of the dialect that we're capturing, or is it both audio and the spelling, the phonation? So I just wondered if the intention is to capture both.
No, the intention is to capture the spelling. So what we will have to do is go back to I think there's a Jamaican patois dictionary, right? So we'd have to make sure that it matches, and if it doesn't match, then we'd have to correct it.
And just even with that dictionary, one of the concerns has been it cannot be used across the country because even within one parish,
right,
there's so many variations. So that's the concern. We
do have to be mindful of that as well. So that is going to come with clinical engagement and teaching as well, because if somebody leaves out one letter, like if you write, for example, I, we say yai. If the clinician is not spelling it how we spell it in the SNOMED CT browser, then it's going to be off. So we're going to have to train clinicians or nurses, whoever, the data entry person, to know that, all right, if it's not really coming up, then maybe revert to English. But it would be so nice if a patient comes in, a mom comes in and says, boy, doc, my baby have running belly for 3 days now. Instead of translating it in our head, which we do. I mean, we usually do that. But it was so nice to write running belly times 3/7, and it be captured. And if we're doing studies, if we're doing, okay, how many patients came in with diarrhea, how many children between the ages of 3 and 5 came in with diarrhea over these 3 days, even though you didn't type diarrhea, it will be picked up. It's really exciting.
I'm just sorry. I hope I'm not taking too long because I'm trying to appreciate, and I'm not undervaluing it. I'm trying to appreciate. We normally engage with the patients, and when we ask, we turn it a different way and confirm, and then we write the standard, the English or whatever it is in the notes. Is it that SNOMED CT is attempting to capture variations of presenting complaint, or is it the complaint? So we'll have operation, running belly, and stuff. So is it that it's trying to ensure we pull all of them in one place, or is it that we're just trying to help maybe a doctor who doesn't know that operation means running belly? Who is the primary beneficiary of SNOMED CT?
Wow. I mean, primary, there's so many stakeholders, there's so many persons who will benefit from SNOMED CT: patients, clinicians, the vendors, the researchers, everybody. But more to your question, it's about standardization. So it's about being able to capture the relevant data in a way that it can be analyzed properly. So, as I mentioned, let's not focus on necessarily the colloquial terms. Just look at, say, heart attack and myocardial infarction. If it is captured as heart attack, it's correct. If it's captured as myocardial, it is correct as well. But in terms of analytics, we using SNOMED CT to standardize that data is going to allow us to get more accurate data in terms of the numbers, because there are so many ways of capturing different diagnoses and presenting complaints, etc., in an electronic health record. So the aim of us adding our colloquial terms is to help to standardize data.
So it targets the presenting complaint as against a diagnosis, because the diagnosis standard won't change.
Correct. But it's not only presenting complaints, it's, I don't want to say everything, but it's pharmaceuticals, it's procedures, it's presenting complaints, it's examination. Yeah? It's almost everything. There is diets in SNOMED CT. Like I was saying yesterday that I'm sure if you type apple pie in the SNOMED CT browser, it's there.
Thank you. I'm.
Yeah. So I don't know if there are any questions online, but there is? What happened? Oh, sorry. And there's, I think, one. No, she was before. Can we do that one quickly, please?
Good morning. There are quite a few, actually. So one person is asking if you can map to ICD-10 or 11 as well. There are several ICD-specific ontologies or data systems, and they wonder how it could be mapped to SNOMED.
Okay, so there is actually multiple ICD maps. So they're there. So ICD-10, there's already a SNOMED CT to ICD-10 map. In terms of SNOMED CT, in terms of ICD-11, the WHO and SNOMED International are currently working. There is a collaborative effort right now, but we do not have a map for ICD-11 just yet. But whatever the terminology, the clinical terminology that is used, it's possible to map to SNOMED CT and vice versa.
There are tools for that.
Right.
Okay, another question. How can or will nurses be brought into this initiative? Most schools of nursing utilize NANDA as the primary nursing language, and will SNOMED CT be available to be taught in nursing curriculums?
I love that question because I think that informatics and informaticians, it's not only clinicians, it's not only IT people, it's everybody. And I have been voicing my passion for getting nursing informatics into just SNOMED CT, pharmacy, lab techs, all of the, everybody, all of the healthcare providers need to be familiarized and sensitized to SNOMED CT. So that is a project that I'm very passionate about in terms of educating healthcare providers in general about SNOMED CT. What was the second question? In terms of med school, in terms of schooling, oh my gosh, that's another passion project in the future for me. I would love to incorporate SNOMED CT. I'm sorry.
It's in the plan, the longer term strategic plan to get it into all the healthcare training. So you had one more, please? I think we're out of time.
Okay, so someone wants to know if there's a plan to add dialects from other nationalities that are here in Jamaica. Say, for example, Haitians, Indians, Chinese, etc.
Not anywhere in the immediate future, I can tell you that, okay? We have enough work and too few people. Okay, and then now a question from Rachel.
It wasn't necessarily
Is it on?
Yes, it was for clarity. There are medical practitioners who do type the symptoms as the Jamaican dialect. It's not always standardized after interpreting what the patient has said. It's seen a lot on the notifications as well.
Yes, that's right. Okay, so I think there are no other questions. I think we're out of time, right? So I'll just say, this whole SNOMED thing is one piece, but it's a big piece, and it's a global piece. We didn't make it up. It's a global thing. Belize has also joined SNOMED as a second Caribbean country. There's a whole lot of work to do. As I said, we have a strategic plan which we hope to finalize by the end of this fiscal year and have it funded and so on. I'll just say two quick things to wrap up. This is all about, SNOMED part, is all about, or mainly about, clinical documentation improvement, standardized, specific, and detailed, and universally translatable. Because remember, people move from Jamaica to Caribbean to Spanish-speaking country, etc. SNOMED is also translated to I don't know how many languages, Spanish, French, Portuguese, everything. So your data can be, in English with SNOMED concept ID 1, 2, 3, 4, 5, whatever it is. It's translatable into Spanish or whatever it is for wherever you go. Clinician engagement is a big part of it. That's what she was also saying. And people will be involved. We're not going to do this behind their back at any time. There was one last thing, but I think the age has caught up with me, so I'd better call it quits. So thank you very much for presenting so well, Rachel and Talia. Thank you for being so engaged in our discussion. And both of you, both online and in the room, and do have a very good rest of the conference today. Thank you.
Before we end the session, we would really want to thank firstly Ms. Cockett and Dr. Gervan for two very interesting and informative presentations. So let's give them a round of applause again. And so we want to just express our appreciation with some tokens. So at this time, we'll do so, beginning with Ms. Cockett. Dr. Gervan. And we also want to wish our appreciation, express it to Dr. Roof. And I must say that Dr. Roof has been an ardent supporter of this conference from day one. She's always here, and we do appreciate it. And so we want to thank her once again for her support. At this time, we will formally close this session.
Stress you out, because if you're stressed, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support group in the clinic. They teach the young mothers how to breastfeed properly.
and take care of the picnic. Then teach our family to,
I don't eat Friday when I go clinic.
And make sure you ask for the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and...
If you no want pop down and fenke, give me one mosquito and run with dengue. So no make water settle in open container. For them to read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, give me one mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. If they in at the table on the side or the back, you fi check out the servings. Just do the maths, not taking too much. Finger below the facts. Zoom in on the nutrition facts. If they in at the table on the side or the back, take note of the sodium, the sugars and the fats. 5% or less in the on the right track. You fi zoom in on the nutrition facts. If they in at the table on the side or the back, vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica.
Zoom in on the nutrition facts. If they in at the table on the side or the back, you fi check out the servings. Just do the maths, not taking too much. Finger below the facts. Zoom in on the nutrition facts. If they in at the table on the side or the back, take note of the sodium, the sugars and the fats. 5% or less in the on the right track. You fi zoom in on the nutrition facts. If they in at the table on the side or the back, vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica.
What you got? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there in the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are going to drop.
No, go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor. Me hear the matter about breastfeeding support with our clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to,
I don't eat Friday when I go clinic.
And make sure you ask for the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and...
If you no want pop down and fenke, give me one mosquito and run with dengue. So no make water settle in open container. For them to read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, give me one mosquito mosquito and run with dengue. A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. If they in at the table on the side or the back, you fi check out the servings. Just do the maths, not taking too much. Finger below the facts. Zoom in on the nutrition facts. If they in at the table on the side or the back, take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You fi zoom in on the nutrition facts. If they in at the table on the side or the back, vitamins, minerals and vitamin 20% and more that good for you. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica.
Zoom in on the nutrition facts. If they in at the table on the side or the back, you fi check out the servings. Just do the maths, not taking too much. Finger below the facts. Zoom in on the nutrition facts. If they in at the table on the side or the back, take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You fi zoom in on the nutrition facts. If they in at the table on the side or the back, vitamins, minerals and vitamin 20% and more that good for you. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica.
What you got? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
Me didn't even know. Me not rest. A peer problem with breastfeeding. People keep on telling me something give the baby bush tea and say it good for him. Then my friend them a tell me say if my breastfeed, my breast a go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support from the clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to,
I don't eat Friday when I go clinic.
And make sure you ask for the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and...
If you now want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them to read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you now want pop down and fenke, you fi burn mosquito and run with dengue. A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
So people remember to pay attention to the timekeeper. She'll be signaling to you. Yeah? Good morning, colleagues, to the fourth session of the National Health Research Conference for 2024. I am Dr. Richard Musazi, and I'm going to be guiding us through the next session of this wonderful and so far very stimulating conference. I work with the Health System Support and Monitoring Unit of the Ministry of Health and Wellness. And in this session, we are going to look at the factors associated with healthcare delivery. We are celebrating, of course, 15 years of research excellence, and we now examine research that can inform us about healthcare delivery. We have a total of 4 young and astute, very bright researchers. As per protocol, we have 2 presentations. Then we will take questions, and then we will have the other two presenters, followed by a question and answer session. So we're going to start off the first two sessions that have to do with health literacy and adherence. For the first session, Dr. Jazera Gomez is going to take us through that session. She is a Trini, a Trinidadian and Tobago national, and has been dedicated to professional medical life in Jamaica for the past 6 years. She's a graduate of the University of the West Indies, Mona, holds a master's degree in epidemiology from the Caribbean Institute for Health Research with distinction. Her interests include non-communicable diseases and biostatistics. Dr. Gomez is committed to improving public health outcomes in Jamaica through medical research. Our second presenter is going to be the sole gentleman of the four persons, and he's none other than Dr. Vikram Asnani. He is a public health physician and successfully attained a Bachelor of Medicine, Bachelor of Surgery degree with honors from the University of the West Indies in 2021. Dr. Asnani has keen interest in improving healthcare delivery to vulnerable populations. This inspired his decision to pursue a Master of Public Health, which he completed in 2024 with distinction again. He partakes in several public health activities such as community outreach programs with Jamaican AIDS Support for Life and collaborates with the Ministry of Health and Wellness HIV STI TB unit. So these two persons will be our first presenters, and I'll call on Dr. Gomez to give her presentation.
Good morning. Thank you very much for that introduction. First, I would like to thank the conference organizers for giving me the opportunity this morning to give this presentation titled Health Literacy and Blood Pressure Control in Jamaica, a cross-sectional analysis using the Jamaica Health and Lifestyle Survey 3. The healthcare system, as we know, is becoming increasingly complex, and in many communities, individuals are struggling to understand even the basics of their health information, their medications, and even the health advice that is being given to them at a simple doctor's visit. So this gap in understanding health information can lead to serious consequences, such as uncontrolled chronic diseases, preventable hospital visits, and poorer quality of life. Health literacy is a concept which emerged in the 20th century and has been extensively researched. It is defined as an individual's ability to read, evaluate, understand, and then act upon health information and services in order to make informed decisions about their health. And among patients with hypertension, studies have shown that there is a link between health literacy and blood pressure control, in that these patients who lack health literacy skills have significantly less about their disease, and they have an increased likelihood of having higher systolic blood pressure values. The prevalence of hypertension globally is increasing, and similarly in Jamaica, we have noted that there has been an increase in the prevalence of hypertension by as much as 11%, according to a series of nationally representative surveys, the Jamaica Health and Lifestyle Survey. This disease has a large global burden of cardiovascular disease and premature death, and according to the World Health Organization, this disease is responsible for 7.5 million deaths and 57 million disability-adjusted life years. There's a dearth of research investigating the relationship between blood pressure control and health literacy in the Caribbean, and to date, no local data exist. So the aim of this study was to determine whether blood pressure control differs among Jamaicans with hypertension based on their health literacy status, and then to evaluate the influence of socio-demographic and health-related factors on this relationship. The study design consisted of a secondary analysis of cross-sectional data from Jamaican residents aged 15 years and older who were diagnosed with hypertension, and we utilized the JHLS3 dataset. We used an interviewer-administered survey, which included a brief assessment of health literacy, a validated tool known as the Brief Health Literacy Screening Tool. In this 3-item questionnaire, we asked, how often do you have someone help you read medical information? How confident are you in filling out forms, medical forms? And finally, how often do you have problems learning about your medical condition because of difficulty understanding the material? The total JHLS3 cohort consisted of 2,807 Jamaicans sampled from 171 enumeration districts across all 14 parishes. But in our study, we utilized a subset of this cohort comprising of 1,933 hypertension cases. We defined a hypertension case according to the JNC7 criteria with a mean blood pressure greater than or equal to 140/90 millimeters of mercury, and those who self-reported hypertension as well as gave a history of using prescription medications were also included in our study population. The main outcome variable was binary in nature with a control group and an uncontrolled group. We defined blood pressure control with a systolic of less than 140 and a diastolic blood pressure of less than 90, whereas those who were uncontrolled were defined by a systolic of greater than or equal to 140 or a diastolic of greater than or equal to 90. The main explanatory variable was health literacy status, which we defined using the BHLS score. This final score was calculated based on a submitted score from the 3 items of the questionnaire and ranged from 3 to 15. We selected a cut point of 9, or the somewhat option on the Likert scale, to categorize patients in terms of either having adequate or inadequate health literacy. We additionally analyzed potential confounders, which included demographic indices, socioeconomic indices, and health-related measures as outlined. The statistical analysis involved Pearson's chi-squared test to compare categorical variables, and we performed both unweighted and weighted binary logistic regression to determine the association between health literacy and blood pressure control and the influence of the selected confounders. We subsequently performed goodness of fit tests to determine which model with the selected variables was the best fitting model and utilized a p-value of less than 0.05 as a level of statistical significance. Our results showed that among the hypertension population of 1,933 Jamaicans, there were 43% males and 57% females whose ages ranged between 15 to 100 years old. There was a mean age of 54 years. The prevalence of controlled blood pressure was only 20.1%, and there were significant sex differences noted. Females with blood pressure control comprised 26%, whereas only 13% of males had achieved blood pressure control. As it relates to health literacy status, the prevalence of adequate health literacy was 79% in Jamaica, and there was a female predominance. Conversely, the prevalence of inadequate health literacy was 21%, with males having more inadequate health literacy compared to females. This sex difference was statistically significant with a p-value of less than 0.001. As it relates to blood pressure control by health literacy status, the prevalence of controlled blood pressure among those with adequate health literacy was 21%, compared to a prevalence of controlled blood pressure of 17% among those with inadequate health literacy. And these differences were not statistically significant, with a p-value of 0.132. This table shows the bivariate analysis for the predictors of blood pressure control, and we found that inadequate health literacy was associated with a 21% reduction in the bivariate odds of blood pressure control. This association, however, was not statistically significant at 0.133, but within this model, both sex and age were significant predictors of blood pressure control. Females had 2 times higher odds of blood pressure control compared to males, and those aged 55 to 64 had significantly lower odds of blood pressure control compared to their younger counterparts. The final multivariable analysis revealed that, again, inadequate health literacy had lower odds of blood pressure control, and age and sex remained significant predictors in this model. In this final model, where we used health literacy, age, and sex, this had a Pearson's goodness of fit p-value of 0.479, which indicated that this final model most adequately fit the data. In conclusion, hypertensive individuals who have controlled blood pressure were found to be more health literate in Jamaica, and while our point estimate suggested an association between health literacy and blood pressure control, we did not achieve the conventional level of statistical significance. There were some limitations in this study. We utilized the BHLS tool, which is a simple and quite efficient tool. However, it is not as comprehensive as more robust tools, and it's also a subjective measure of health literacy, which has the subjectivity has its associated biases. Secondly, we used a standardized threshold for blood pressure control, and according to the JNC7 guidelines, patients who have concomitant cardiovascular conditions allow for a more lenient threshold of blood pressure control, which was not accounted for in this study. And finally, public health implications of this research is that both health promotion and education initiatives can improve and develop health literacy skills, and in effect, improve the management of chronic diseases such as hypertension. And we hope that this research can promote a health literacy research agenda for the development and implementation of health literacy policy, and this will be in keeping with the 2030 Sustainable Development Goals and the Global Agenda on Health Promotion. These are my references. I would like to acknowledge my supervisors, Dr. Nadia Bennett and Dr. Novi Younger Coleman, as well as co-authors and affiliated institutions. Thank you.
Thank you, Dr. Gomez, for that presentation. So we'll go straight to Dr. Vikram Asnani, who is going to discuss factors associated with adherence in ART therapy. Dr. Asnani?
Okay, good morning, everyone. My name is Dr. Vikram Asnani. I'm very excited to be here today to present the findings of my study entitled Factors Associated with Adherence to Antiretroviral Therapy in Adults Living with the Human Immunodeficiency Virus, or HIV, in Kingston and St. Andrew, a mixed methods approach. So HIV was discovered around 4 decades ago. And since then, there have been several advancements in our knowledge of how to manage the virus. Indeed, HIV is no longer seen as a fatal virus. Instead, it is now a chronic illness that can be managed successfully. And this is primarily due to the introduction of antiretroviral therapy, the goal of which is to attain sustained viral suppression, to maintain a person's immunological function, and to improve their overall quality of life. Now, Jamaica's progress in ending the HIV/AIDS epidemic, it lags behind global and regional progress. As at March 2023, of the estimated 30,000 persons living with HIV in Jamaica, 91% have been diagnosed, but only 54% of those diagnosed are retained on ART, and 78% of those on ART are virally suppressed. So we note that adherence to ART remains a challenge in attaining the 95-95-95 targets. So we know that persons with good ART adherence, they engage in more comprehensive health care, they have improved health outcomes as they maintain their viral suppression, thereby avoiding any AIDS-related opportunistic infections and death. Additionally, adherence is critical to prevent emergence of viral resistance to ART. The last ART adherence study in Jamaica was all the way back in 2008, and adherence at that time was between 55 and 59%, noting lower adherence in rural dwellers, persons feeling depressed, expressing food insecurity, stigma, or poor social support. Now, 15 years later, after much improvement in our HIV program in Jamaica, we found it necessary to investigate if there were any changes in adherence. As such, our study aimed to identify factors associated with adherence to ART in adults with HIV using both qualitative and quantitative approaches. The objective for the quantitative component was to determine ART adherence levels and associated factors using the Adherence to Refills and Medication Scale, or ARMS, and the qualitative component sought to gain deeper insights into these factors using in-depth interviews. A cross-sectional survey was conducted amongst 358 adults attending the 3 largest HIV treatment sites in Kingston, namely the Comprehensive Health Center, Windward Road Health Center, and the Center for HIV/AIDS Research and Education Services, or CHAIRS. We recruited adults with a HIV diagnosis of at least 3 months using a systematic random sampling technique. An interviewer-administered questionnaire collected sociodemographics, clinical and social history, and ART adherence using the ARMS. Good adherence was defined as a score of 13 and below on the scale that we used. Cronbach's alpha was also calculated for the scale. Furthermore, we did a quality of life assessment using the World Health Organization Quality of Life HIV Brief tool. Analysis was done using SPSS version 20. Descriptive statistics were used to describe sociodemographics and adherence levels. The Chi-square test of association examined the relationship between adherence and select categorical variables, and we also performed a logistic regression model to identify independent predictors of good adherence. In-depth interviews were also conducted amongst 11 purposively selected participants, 6 with poor adherence and 5 with good adherence. We now move on to our results. So of the 358 participants, 56% were female, and there was a mean age of 49.2 years with a standard deviation of 13.7. 2/3 of participants attended public HIV treatment sites and were employed. 94% of persons attended at least primary school. The prevalence of smoking and alcohol consumption in the sample were 27% and 36% respectively. Cronbach's alpha for the ARMS was 0.84, representing good overall internal consistency of the scale. The total median adherence score in the sample was 13.0 with an IQR of 4.0. We found that 57% of persons had good adherence, which as we defined as an ARMS score of 13 or lower. In our bivariate analysis, several patient-related factors were significant. Persons attending the private health facility, persons with shorter HIV diagnosis, non-smokers and non-alcohol consumers had higher proportions of persons with good adherence. Persons who found their life to be meaningful, who accepted their bodily appearance, felt accepted by persons knowledgeable of their HIV status, and expressed financial security also had good adherence. Persons who were satisfied with their sleep, their personal relationships, the support they get from their friends, and persons saying they never had feelings of depression or anxiety also had better adherence. In terms of illness-related factors, persons who are not at all fearful of the future due to their HIV diagnosis had better adherence. Moving to therapy-related factors, persons who had never stopped taking their ART because of side effects had better adherence as well. When examining health system-related factors, persons who were satisfied with how quickly they were able to fill their ART prescriptions, their access to health-related information, and their access to health services also had better adherence. Our logistic regression model showed that persons who found their lives to be meaningful and also felt accepted by persons knowledgeable of their HIV status were just above 2 times more likely to have good adherence. Our qualitative data, which we did with the in-depth interviews, it also provided richer insights into some of the barriers and enablers of ART adherence, further substantiating our quantitative data. Barriers to adherence included self-neglect, whether it be carelessness, negative life experiences such as episodes of depression, a lack of resources, whether financial, transportation, or food, fear of HIV/AIDS symptoms or death, stigma and discrimination, whether from loved ones, self-imposed, or even in healthcare settings, and therapy-related factors such as side effects. These were all barriers noted to ART adherence that were revealed from our in-depth interviews. A few enablers of adherence included religion and spirituality, positive health education and promotion, and supportive healthcare workers. So our study found 57% of participants to have good adherence. However, this is quite lower than the average adherence score of 73% noted in a meta-analysis including 160,000 persons with HIV in sub-Saharan Africa. It is also similar to the 2008 study that I mentioned earlier, where the adherence was between 55 and 59%. So despite all of this improvement in HIV service delivery in Jamaica, adherence remains a key barrier that needs to be addressed in our population. Service delivery needs to consider patient, therapy, illness, and health system-related factors that were implicated in this study. We recommend that our public health systems be strengthened. We must ensure that our HIV services are equitably accessible to persons. Our social workers, their role must be strengthened to ensure that they're addressing the financial vulnerabilities of those living with HIV. Our communities can be enhanced to include peer support groups and adherence clubs led by those with HIV, as this may minimize stigma and discrimination. And finally, routine psychosocial assessments and support are needed in these persons to identify if they're feeling depressed or anxious, as these were barriers to ART adherence. So the take-home message, are persons living with HIV, they must feel accepted by persons, they must feel like their lives are meaningful, as these were the important drivers of good adherence from our study. To close, I'd like to thank the National Health Fund for providing sponsorship towards this research. My co-authors, Drs. Morrison, Carter, Chizoba, Thompson, and Ms. Martin, as well as the health center staff members who assisted with this research. A special thank you to the HIV community for providing invaluable insights into this research. And lastly, the Master of Public Health team, Yui Mona, for guiding me throughout. These are my references, and I thank you.
Okay, thank you very much, Dr. Asnani. Very insightful information. So, question and answer session. We'll start off in-house. Any questions in-house? Indicate by raising your hand, please. Yes.
Still morning. Good morning. And thank you, Dr. Gomes and Dr. Asnani for two wonderful presentations in the context of health as we seek to close the gap with our Vision 2030, looking at providing whatever we can in terms of health care and different kind of modalities as it relates to HIV management and for our chronic disease with the blood pressure control. For my first question goes to Dr. Gomes, and I know you would have utilized a cross-sectional study, but my question to you is that, do you think if you had used like a longitudinal design, would you provide any additional insight into the relationship between health literacy and blood pressure control over time?
Are you hearing me? Yes. Okay, sorry about that. Thank you so much for that question. I agree. I think that if we had taken a longitudinal approach, it would have given us the opportunity to include many other risk factors as well that can be related to both health literacy and blood pressure control. And if we did take that approach, we may have also been able to use a much more comprehensive tool so that at the end of the study, we can determine which domains, there are many domains of health literacy, which one is actually being most problematic in our specific population.
Thank you. And for Dr. Asnani, now, you did both qualitative and quantitative parts of your study. As it relates to your qualitative, you did in-depth interviews, right? I just wanted to know, how were your participants selected for the in-depth interviews? I'm not sure if I missed it, right? And what criteria did you use to ensure that the sample size actually reflected the diversity of the population living with the HIV within that population that you studied?
Okay, so thank you so much for that question. So the first question is, how did we select our sample for the qualitative component? So we did purposively selection of these participants. So persons that, well, they were subject to the same inclusion and exclusion criteria as the quantitative. So at least 18 years of age, as we only did adults, persons who had their HIV diagnosis of at least 3 months, once they met that criteria and they were not acutely ill. In terms of the in-depth interviews, honestly, persons that we found would have been more willing to engage in further conversations and who we believed had more insight that they were willing to share beyond just the questionnaire, because the in-depth interviews were done right after the questionnaire. That is how we selected the participants.
Thank you so much.
And then there was a second part of the question?
Yeah, you can stop. That's
okay,
fine.
thank you.
Thank you.
Okay, thank you. Those were the in-house questions. Dr. Longe, you had a question? I thought your hand was raised. No?
Thank you for your excellent presentations. I was a little bit concerned when you started to present. I was thinking that the result will be very different after many years. Asani, yes, after many years of, so I was expecting that with the effort put in, I think the medication is free. Is the medication free? Yes. So I was expecting that it will give us a more robust, maybe 90%, but I was so disappointed.
I know,
so what can we do?
What can we do?
Yes.
So, well, first I must say, the 2008 study that was done compared to mine, we measured adherence differently. So even though we compared the percentages, adherence was measured differently there. But I agree, we're still not where we want to be today, right? As you said, despite much improvement in our service delivery. So, as was highlighted in the study, we realized that there are so many psychosocial issues that are posing barriers to good adherence, which we need to address. So as you say, the medications are free to the community now. So for the most part, purchasing the medication should not be an issue. Of course, there are other issues like food insecurity. A lot of persons, they feel they need to have a full meal before they take their medications. And if they can't afford the meal, they're not going to take the medication. So once again, pointing to those psychosocial issues, persons are not understanding. And is it because persons are not explaining to the patients what exactly is expected of them? Is it that we need more HIV treatment sites around the island? I know that there has been a boost. We're doing assessments of many different health facilities to equip them with the facilities to manage HIV-positive patients, right? So just strengthening our public health systems to ensure the services are equitable, ensuring that psychological outcomes in these persons are optimized. I believe these are some of the things that could really help and boost our adherence, because ultimately, Being more adherent will improve their quality of life. So it's a win-win situation for both sides.
Okay, thank you. And I would also like to add generally, when persons start to feel a little better, they tend to put away the medication. So we still have to let them know that it's not the fact that you're getting a little better that you're off the hook. So we have to also present that at the point where you're presenting the medication, okay?
Definitely agreed. Thank you.
Thank you.
Okay, that was it for the in-house questions. Online, any questions? Yes, go on.
Dr. Asnani, is there a pre-assessment to understand the behavior before and after the ART to see where the issue would be behaviorally with compliance?
I'm sorry, can you repeat that?
Is there a pre-assessment to understand the behavior before and after the ART to see where the issue could be behaviorally with compliance?
As in, you're asking if we did a pre-assessment before they started their medications and after? That's what they're asking? Okay, so no, our study only included persons that were currently on their medication for varying periods of time, at least 3 months. So we didn't do an assessment to say what were their behaviors before they started their medications versus after. That was not done. But that could have been useful as well to possibly elucidate more barriers to adherence. But that was not done.
Thank you.
Thank you.
That's it for the online question. Yes? Okay. All right, so we'll go straight ahead to our next two speakers. Two very also young and bright ladies. First of all, we're going to hear from Dr. Brimer. Dr. Onome Brimer holds a Bachelor of Sciences in Biomedical Sciences from King's College and completed her medical training at the University of the West Indies, Mona. She is interested in the role of epidemiology in improving clinical outcomes. She has a background in primary care and research from working with 54Gene, which was a leading African genomic firm. Dr. Brimer likes traveling, exploring diverse cuisines, and enjoying the beach. So we're also going to hear from Dr. Kelly Fletcher, a consultant anesthetist at the University of the West Indies, University Hospital of the West Indies. She brings over a decade of experience in the field of anesthesia. After recently completing a fellowship in critical care at the University of the West Indies, she is dedicated to advancing patient care in anesthesia and critical care environments. Dr. Fletcher is passionate about integrating innovative practices and collaborating with multidisciplinary teams to enhance surgical and intensive care outcomes, as well as patient safety. So Dr. Brimer will be talking to us about the use of hydroxyurea, and Dr. Fletcher will be talking to us about ambulance services. Dr. Onome Brimer, over to you.
Thank you very much. And thank you to the conference organizers for this opportunity. Good afternoon, everyone. Good morning. My name is Dr. Onome Brimer, like was mentioned, and I will be presenting on the barriers to hydroxyurea use in parents or caregivers and children with sickle cell disease in Jamaica. I'd like to start off by thanking my supervisors, Professor Monica Asnani and Ms. Guthrie Dixon. So, sickle cell. Sickle cell disease is a group of inherited blood disorders that is caused by a defect in the hemoglobin gene, which affects the shape of red blood cells. Now you end up with cells that are less flexible, cells that stick together and also stick to the blood vessel wall, and the cells also have a shorter lifespan. Now this results in blockage of the blood vessels, and also the cells break down at a much more rapid rate than the normal blood cells. Now, because of the properties of these cells, you have some very serious and debilitating complications. These complications can be acute, like in the case of vaso-occlusive crisis, or these complications can be chronic, such as in the case of stroke, or in the case of acute chest syndrome, which can actually be life-threatening, and things like pulmonary embolism as well. Now, because of these very serious and debilitating complications, hydroxyurea is a medication that has been approved for the use in the management of sickle cell disease for almost 3 decades. Now, hydroxyurea, although it acts in a multifaceted manner, it primarily improves sickle cell by increasing the compound called fetal hemoglobin. Now, fetal hemoglobin, as the name suggests, is the primary form of hemoglobin in a gestating fetus. And when you have higher levels of fetal hemoglobin, you have a reduced percentage of the sickle red blood cells, the sickling process, and also the associated complications. Now, as you can see here, we have an image showing a blood film, or an image of a blood film before hydroxyurea use and after hydroxyurea use. And we can see there lots of lovely rounded red blood cells after hydroxyurea use and less of the sickle red blood cells. Now, why is this important and why do we care about this? Now, hydroxyurea has been shown to improve the quality of life of the patients worldwide, and it does so by improving things like recurrent severe acute painful events, acute chest syndrome. It causes a reduced need for hospitalization, and this dramatically improves the quality of life. This has been shown by cohort studies, this has been shown by cross-sectional studies and longitudinal studies for over the last 2 decades. And although hydroxyurea is an important drug in the management of sickle cell disease, data actually shows that it is underutilized in sickle cell disease management. Now, preliminary data from the sickle cell unit has shown that hydroxyurea is also suboptimally used in Jamaica as well. Now, why is this important, and what did we do about this? So we asked ourselves, what are the barriers to the use of hydroxyurea in parents and caregivers of children with sickle cell disease in Jamaica? Excuse me. Because it is necessary to identify these barriers to hydroxyurea uptake in the regional context in order to address them. So the aim of the study was to identify and better understand the factors that discourage and hinder the use of hydroxyurea in caregivers and parents of children with sickle cell disease in Jamaica. What were our objectives? So the first objective was to describe the prevalence and the patterns of hydroxyurea use among children and adolescents with sickle cell disease in Jamaica. The second objective was to identify the barriers to hydroxyurea uptake in parents and caregivers of these children with sickle cell disease, while exploring the cultural, social, and the economic factors that influence the parents' decisions. How did we go about doing this? We used data from a study which is currently ongoing at the sickle cell unit, and this study is being done on general access to care in sickle cell disease. This is a cross-sectional study, and it is interviewer administered. The inclusion criteria for my study was survey responses from parents and caregivers with children and adolescents who were less than 18 years old and diagnosed with sickle cell. And 171 survey responses met this criteria at the time of data collection. The ethical approvals were granted, and all informed consent was collected from the parents and caregivers. The outcome variables of the study. The primary outcome variable of the study was ever use of hydroxyurea, meaning had these children ever used hydroxyurea at any point in their lives, while the secondary was if they were currently using hydroxyurea. The explanatory variables were created using 19 questions from the primary survey, which captured the widest socio-demographic characteristics of the caregivers. For example, a question would say, is hydroxyurea easily available in all the pharmacies? And the parents would answer yes or no. The data was analyzed using version 18 of Status software, and statistical significance was determined by a p-value of less than 0.05. Fisher's exact test was used to determine bivariate associations, and logistic regression models were used to assess associations between barriers and the use of hydroxyurea ever. Now, what did we find? Among the 171 surveys reviewed, we found that the age range of the caregivers were 20 to 70. We found that the 36 to 50-year-olds were the most numerous. We found that mothers were the highest proportion of the caregivers, unsurprisingly. We also found that the majority of the caregivers had attained a secondary school level education. We found that 50% of the caregivers actually lived in an urban area. And we found that, So now looking at the distribution of the hydroxyurea use as reported by the participants. So we can see here that among the participants, 60% of them stated that their children had actually never used hydroxyurea, while 40% had used hydroxyurea. And among those who had used hydroxyurea, 96% of them were still using it. And it was important to note that 100% of them stated that it was effective for those who had actually started using hydroxyurea. Now, amongst those who had received education and counseling from hydroxyurea, this was 59% of the caregivers, and 36% had never actually received any education and counseling for hydroxyurea use. And among those who had actually been counseled and educated, and by that, it really just meant that a doctor or a nurse had spoken to them about the need for their child to actually commence hydroxyurea use, we saw that 69% of the population had actually initiated hydroxyurea use. Now, we had performed simple and multivariable regression models of the problems, and here we are presenting the adjusted odds ratio for the multivariable regression analysis. And here we can see that amongst those who felt knowledgeable about hydroxyurea, their children had a 5 times higher odds of using hydroxyurea. And amongst those who, interestingly enough, didn't find hydroxyurea to be available, they actually had a 96% times lower odds of using hydroxyurea. And then finally, amongst those who were not interested in taking another medication, we found that those who actually did not have a problem with taking medication had a 24 times higher odds of using hydroxyurea. So we found that the 2 barriers to hydroxyurea use were a perceived lack of knowledge about hydroxyurea and a reluctance for their child to take any additional medication to what they were currently taking. Now, why is this important? So among the parents who had been educated and counseled about their child taking hydroxyurea, 31% did not initiate use, and we find that this data is higher than data that comes from other parts of the world. And the caregivers as well who perceived their knowledge of hydroxyurea to be more adequate were more likely to have children who had ever used hydroxyurea. Now, those who were open to their children taking an additional medication were also more likely to have children who had ever used hydroxyurea. And then availability, although it was identified as a challenge by up to 32% of the participants, this actually did not show up to be a barrier in the study. And study participants who actually had been on hydroxyurea may have reported challenges with availability. However, it may not have been a barrier because we find that it's possible that those who have not used hydroxyurea may not actually know what the challenges are facing accessing hydroxyurea. So in conclusion, we found that caregivers who were better informed about hydroxyurea were more likely to have children who used hydroxyurea than those who were not. And of course, we know that medical professionals play an important role in the education of caregivers. So it's very important that we have standardized education and training of medical professionals, which is actually required for accurate information about hydroxyurea to be disseminated. And then finally, it's important to address any issues around availability because we do have data that shows that the regular use of hydroxyurea is affected by availability issues in the pharmacies, and this is as a result of interruptions in the hydroxyurea supply chain. So it's important to address where it's coming from, how it's getting to the island, and where it's available. And of course, further research on hydroxyurea in the management of sickle cell disease in Jamaican population is required. Thank you for listening, and these are my references.
Thank you, Dr. Bremer. So we'll now listen to Dr. Fletcher. Please welcome Dr. Fletcher.
morning, and thanks to the organizers for allowing me to present today. So my study is entitled An Urgent Need for... Can we change the screen? I can't see my presentation. No, I know what to do in terms of moving forward, but I can't see. I'm not seeing the presentation. All right, thank you very much. So, an urgent need for regulation of ambulance services to improve transport of the critically ill in Jamaica. So just some background information. Ambulance services are a basic requirement for any healthcare system, and transfer of the critically ill may occur for a number of reasons. This can include advanced care, need for investigations, and locally, critical care and specialty services are not available in all parishes, such as cardiothoracic surgery, neurosurgery. Transfers must be rapid and safe, and so standards and legislation are necessary to ensure safety is maintained. So the objective of our study was to determine current practices of ambulance services in the transfer of the critically ill, as well as current government standards for transport. And ethics approval was received from the University of the West Indies Ethics Committee. The study was a cross-sectional study, and the study population we sought were all public and private ambulance services, where private ambulance services were obtained from the Yellow Pages, and pre-hospital emergency medical services, a division of the Ministry of Health and Wellness, was used to determine the public ambulances. Data collection was via an interviewer-administered questionnaire, and the target population here were the managers of each ambulance service or a surrogate designated by them. Data was collected on years of operation, staff, equipment, and number of transfers. The responses were compared with recommended guidelines as provided by the Association of Critical Care Transport 2016. So the results. 27 services were identified, 10 private and 17 public. 7 private participated in the study and 8 public, for a total of 15. Generally, 105 ambulances were in operation at the time, with 176 EMTs and paramedics. Most had greater than 20 years of operation, with a median of 3 responders per call. All ambulance services were asked about accreditation, and most public services indicated supervision by the Ministry of Health and Wellness. None of the services questioned were able to indicate any specific criteria or documentation to be accredited as an ambulance service. Monitoring and equipment. Data were collected on basic monitoring and equipment. Most had an oxygen cylinder, for example, but only 60% could monitor oxygen saturation. This is overall. Some of the public ambulances reported unreliable electrical supply for monitoring. So this is just a table to show significant findings that we had in the study in terms of monitors. So, for example, pulse oximetry was more common in private ambulances as compared with public. Same for glucometer and non-invasive or automated blood pressure monitoring. Equipment for treatment. IV fluids were only available in 53% of ambulances. 80% of ambulances, or ambulance services rather, had regular oxygen masks. Emergency drugs were only available in 20% of ambulances. And here's a table highlighting adrenaline, which is an emergency drug, which was only available in 20% of ambulances. Staff. 30% overall had an EMT or paramedic employed, and only 1 critical care registered nurse was identified. Basic life support trained staff were at most of these services. 50% had staff who were advanced cardiac life support trained. So just to highlight again, emergency medical technicians or paramedics were only available at 33% of ambulance services. So just to move on to the discussion. So vehicle evaluation by an overseeing body is essential, both at the onset of the ambulance service and over time. And in the absence of local guidelines, international guidelines have to be used to assess. So most had an oxygen cylinder, as I mentioned before, but that would be 93%, but only 60% had a pulse oximeter. And in a study done in Canada, in spite of oxygen, 82% of critically ill patients remained hypoxemic. There was also no defined oxygen capacity at any service. Blood pressure monitoring was available in 53% of services. However, there's a great propensity for change in critical care patients. Some may require vasopressors, and so they need frequent blood pressure monitoring. ECG monitoring was only available with 13% of these services, and in a study that was done in the US, there was a shorter door-to-balloon time with pre-hospital ECG in patients who had ST segment elevation myocardial infarctions. Several, especially in the public system, lacked reliable electrical supply and battery backup, which would affect use of suction and monitors. As I mentioned, critical care patient status is dynamic, especially the respiratory and the cardiovascular system, and so you must have the ability to treat these patients in transit. IV fluids are essential, but we're missing in 40% overall. IV cannulas were missing in 47%, and although patients, once they leave another facility, they are likely to have an IV access, you have to consider that there may be dislodgement during transfer. Absence of drugs was greatly attributed by providers to Ministry of Health and Wellness disallowance, with only 20% having adrenaline. Airway equipment was also often missing, with private ambulances having better stock. So internationally, the guidelines recommend 2 responders per call with a minimum of 1 emergency medical technician, and continuing medical education is mandatory. Locally, EMT numbers are low, and so not all transfers will have one. The paramedic that we identified, single, was mostly in an administrative role, and there was no mandate for continuing medical education. The emergency medical services development in Jamaica, there was a bill that was drafted in 2008. It was published in the West Indian Medical Journal. It currently remains unfinished and unpassed, and legislation is important for the development of pre-hospital emergency medical services. And currently there's little oversight or review. So this was an article that was published in the Jamaica Gleno. Help or hurt, unregulated ambulance services, uncertified emergency technicians could be putting public in danger. And it detailed how after initial institution of ambulance services, there is no review, and highlighted the fact that legislation is missing. So Jamaica is underserved by public ambulances, with a heavy reliance on private ambulances and private passenger vehicles. And this is quite cost prohibitive, as you can imagine. Oops. So there is a need for local guidelines. Equipment is expensive, and the list is expansive with international guidelines. And although we may not be able to afford all, you need to have regulation. So we suggested stocking ambulances for emergencies that are common to regions, such as road traffic accidents and trauma. And early assistance can decrease costs later on. In a report that was published called Cost of Care, commissioned by the JN Foundation and the National Health Fund, it was found that road traffic accidents, trauma, self-inflicted injuries was costing Jamaica $12.6 billion. Could it be that if we had assisted these patients earlier, we could decrease cost? Don't know. So further studies are suggested to indicate same. And these are my references. Thank you very much.
Okay, thank you, Dr. Fletcher, for another very informative presentation. So, as per protocol, we'll start with questions for Drs. Brimer and Fletcher. In-house questions, indicate by raising your hand, please. Yes, one in-house question coming up. Yes.
Yes, good morning, everyone, and thanks for 2 excellent presentations. Dr. Fletcher, your presentation was very concerning. I just wanted to find out your method of selecting the ambulances, and also your sample size selection. What was the criteria?
So you asked about how we decided on the sample size?
Right.
Right.
How many ambulances and what was your criteria?
So our target was to get all the ambulance services in Jamaica. And so we used the yellow pages to determine the private ambulance services available. And we went to the Ministry of Health, pre-hospital emergency medical services, and asked, and were given a list of ambulances there, both connected to hospitals and those associated with fire brigades, for example. However, only 15 agreed to participate in the study, and that's how we ended up with that sample size.
Okay, so it was convenient. So you had a large non-response rate?
Yes.
Okay.
Mm-hmm.
Another question?
Thank you for your presentation. A quick question. Because there are no, is it possible to use private vehicles in an emergency case? For you to, yes.
Private passenger vehicles?
Yes.
It is, but if you have a patient who is critically ill, they need to be managed by a competent person.
Yes.
And so putting them in a taxi or so, you won't be able to monitor them. You won't be able to treat them if they have any issues. And so it's really not ideal. And so we need to develop our public ambulance system.
Okay, thank you. Were you aware of the case that happened at the airport?
Yes, I did read
What
on
do you
that
say
case.
about that?
I wouldn't want to give personal opinion on that kind of thing associated with my presentation. All I will say is that this is something that needs to be looked at. Very critical. Yeah, it needs to be looked at, and we need to sort it out.
Okay. Thank you.
Yes, another question?
Dr. Fletcher?
Fletcher, yeah.
Dr. Fletcher,
yes.
You said something about the bill started in Parliament, but it's not complete, something like that?
Right, so that was in 2008.
Right. So, with regard to ambulance service in Jamaica, we don't have any standards, any bills, any laws?
Right, so the permanent secretary in that article had said that it was started, as I said, and published in the West Indian Medical Journal, but in terms of further development of legislation, it never happened.
Thank you. Good presentation.
Okay. The next question is for Dr. Onome Brahma. Yes. A quick question. I wanted to find out why you were presenting the hydroxyurea. What is it?
It's a medication that is used in the management of sickle cell disease. So it helps to...
Is it liquid? Is it...
So you have liquid formulations and you also have tablets as well.
Okay. Because I was concerned why they use, where you say parents said, they don't want their children to be on several medications. So I wanted to know in what form, if that would be a challenge, So that is why. But another question, you said, at the end of your presentation, you talk about non-availability. So if it is so useful, because I saw the picture with the very round circular red blood cells, that look good. And that could reduce a lot of the crisis. So why can't we, therefore, invest in ensuring that this medication is readily available if it is that good?
Yes, it's very important. It is a good medication, and it really does have a lot of trials and studies that have shown how effective it is. While it is available, I think there are two issues. One is the stigma associated with it, because it was formerly used really as a chemotherapeutic agent, so there is some stigma in the community around that. However, in terms of the availability, some of the participants will talk about availability in their area. So I think it's definitely important to ensure that it's available widespread on the island so that people can easily access it.
Okay. All right. Thank you.
Thank you.
For the in-house questions, so we go online. Go ahead.
Dr. Bremer, following on Dr. Alonge's question, you're being asked, hydroxyurea is available through the NHF, so is there still a challenge accessing the same even though it is free to the clients?
So there wouldn't be a challenge accessing it on the NHF, but what we do find is that some people don't know it's available on the NHF. So that is some education that even during the course of data collection we had to do. So there's definitely room for improving that education there. So once you do have an NHF card, you're able to access hydroxyurea. So that's something that was worked on recently. So it's definitely a great stride for hydroxyurea. So there is no challenge accessing it on the NHF once it's available on the island.
Okay, again, Dr. Bremer, you made a comparison of a 31% prevalence estimate from your study with a 22% estimate from the literature and declared the former to be higher. Were you able to assess the difference between these estimates using a confidence interval comparison or any formal statistical test? And was the education about HU mentioned in your study standardized across patients and caregivers? If it was not, how could this be influencing your results?
Okay, thank you for the question. And I'll answer the first one. So we didn't do any, or I didn't do any statistical tests to compare the two. However, I did look at the questions that were asked in that study and compared to the questions that we asked in our study and was able to just make a hypothesis, should I say. And could I get the second question, please? Or the second part of the question?
Were you able to assess the difference between, oh, you said you didn't, okay, let me say the second part again. Were you able to assess the difference between these estimates using the confidence interval comparisons or any formal statistical test? And was the education that you mentioned in your study standardized across patients or caregivers? If it was not, how could it be influencing your results?
Thank you. So in terms of the education, it's not standardized across parents and caregivers, but we can see the questions that you would ask patients in terms of how they had been educated. It definitely could influence the results because depending on the type of information that the patient receives, it can influence, one, what they actually take from the particular consultation, and two, how they perceive that information. So that would also be something to look at in terms of what standardized education looks like when you are educating on hydroxyurea from a medical professional.
Thank you.
Okay, so that rounds it up for the online questions and the fourth session for the presentation. Give another round of applause to our presenters. Okay, Dr. Grant.
You don't have to go very far, Dr. Musasi. We want to thank Dr. Musasi for leading us in this session. So we thank him for his moderation. And we also want to thank our presenters for excellent presentations. And that brings this session to a close.
What you got? I feel stressed out. 2 months from my baby and I have a problem with breastfeeding. The baby not get enough milk like when I'm in at the hospital.
So why you never tell me?
I didn't even know. I not rest. I have a problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are going to drop.
No, go so. At 5 I wouldn't me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you're stressed, you're not going to produce enough milk. I better ask your nurse or your doctor.
We hear them talk about breastfeeding support with our clinic. They teach the young mothers
how to breastfeed properly and take care of the picnic. Then teach our family to,
I'm going to eat Friday when I go clinic.
And make sure you ask for the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Welfare.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, you fi burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop fret.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table on the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats by percent or less in the on the right track. You fi zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It there in the table on the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats by percent or less in the on the right track. You fi zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What, dear girl?
I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor. Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to,
I'm going to eat Friday when I go clinic.
And make sure you ask for the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Welfare.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke,
message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax.
Good afternoon again, ladies and gentlemen, and welcome to session 5 in our scientific session. This session will be looking at violence, injuries, and substance. I'm Dr. Charmaine McNaught, and I'm pleased to lead this most important session as we look at some very important topics. We are celebrating 15 years of research excellence of the National Health Council and Research and Conference, and we now enter into high gear with 4 research presentations in this session. We will have 2 presenters, then we will take questions, and then we'll have the other 2 presenters followed by our questions and answers. Our first 2 presenters, Dr. Cynthia Pitter is a nurse and midwife and gender specialist with a PhD in Gender and Development Studies from the UWI. She lectures and coordinates the postgrad nursing program at the U.S. School of Nursing, Mona. She's a researcher, trainer of trainer, and has published on areas such as women's health, GBV, respectful maternity care, fatherhood, as well as competency-based education for midwives. She's also on a mission to use the human rights framework to inspire nursing and midwifery students to safeguard, respect, and promote people's health rights in all spaces. Today, she will share some of her findings from her PhD work. Our second presenter, Ms. Michaela Jackson, is a recent graduate of the University of the West Indies with a BSc in psychology and criminology. She has also volunteered with young children at the primary level, which fostered her passion for child development and mental health. Her research today will examine patterns in youth violence and healthcare. Her long-term career goal is to become a clinical psychologist with a focus on neurodivergent disorders and development, using her work to enhance the understanding and care of children and adolescents. Let's make our first 2 presenters welcome. We start with Dr. Pitter.
Thank you, Doc. Good afternoon, everyone. I feel very honored, and I must thank the organizers for giving me this opportunity to share some of my findings, part of my studies. I bring you greetings from the UWI School of Nursing. Thank you. Challenges and opportunities for midwives to reduce gender-based violence, experiences from 2 hospitals in the Kingston metropolitan area, Jamaica, gave me the opportunity to bring visibility to pregnant women who are experiencing gender-based violence and to the midwives, their caregiver, the opportunities that could be presented for them to intervene. So I'll be giving you some overview of my background, literature review, research methodology, my findings and discussion. Gender-based violence is a feminized pandemic that 1 in 3 women in partnered relationship will experience, oftentimes by someone that they are in love with or were in love with. It is rooted in gender inequalities, patriarchal ideologies, and institutional practices. We have many conventions, for example, the UNFPA International Convention on Population of Development Program of Action that we can use to improve women's social, economic, political, and health status. We also have the UN Sustainable Development Goals, especially number 1 that speaks to poverty reduction, number 2 that promotes maternal health, which includes sexual and reproductive health, SDG 5, gender inequality, and of course number 16 that speaks to accountable institution. Pregnancy can be a trigger, and it also can increase women being exposed. All types of GBV are likely to increase in severity during pregnancy. Young women find that young women are often exposed. Unintended pregnancy is an outcome of existing abusive relationship, and of poor outcomes are associated with domestic violence and family violence. The long-term effect on pregnancy has been recorded. However, pregnancy symbolizes the woman's autonomy, control over her body to do something about it. There are several promising interventions. Pregnancy and early childhood are opportune times for early intervention, and maternity care remains an untapped area that we can use to protect the women and the next generation. Midwives, on the other hand, are prepared to care for pregnant women and the next generation. But very often, the status of midwife also reflects the status of women and the value placed on women in society. Midwives, they themselves are susceptible to intimate partner violence, and midwives believe that GBV is in their remit for them to intervene. The opportunity that presents is for us to screen. WHO does not support generalized screening, but what they will support is for intervention at the antenatal care for women who are pregnant. There are many tools that WHO recommend, one of which is abuse assessment screen, which was also validated by our very own Dr. McQueenie Duhaney here in Jamaica that we can use. Jamaica has recognized that gender-based violence is a crime, it's a human rights issue, it is a social issue, and from my perspective, our perspective, it is a public health issue. So Jamaica has ratified many conventions. There is institutional response from the Bureau of Gender Affairs, example, and we have done 2 surveys, one in 2008 and one in 2016. The Ministry of Health, in reviewing what the Ministry of Health provides, that the policies that guide antenatal care, that is lacking. I can hardly see. The management of interpersonal violence, there is no a manual from that. That wasn't there before when I started. And of course, our midwifery curriculum is upgrading. So there is need for a roadmap to guide us. So the purpose of my study was to identify risk factors associated with gender-based violence in pregnancy, build capacity among midwives to screen for gender-based violence. My research question and objectives surrounded these concepts: prevalence, etc., of pregnant women, as you can see from midwives, and of course I did an evaluation. So my study was a multi-phase descriptive cross-sectional study, which the qualitative section looks at retired midwives, active midwives, and quantitative pregnant women. Using a participatory action research that we did, the phase 1, we did an exploratory study, then we did intervention, and then we evaluate. So the population of pregnant women came from the University Hospital and the Victoria Jubilee Hospital. Across both phases, 554 women were completed the questionnaire. They were systematically, randomly chosen. Data was analyzed in SPSS and also in vivo for open question, and it was pre-tested at Spanish Town Hospital. The midwives were registered midwives and active midwives. They were purposely selected, and they were interviewed in a focus group discussion. In my intervention include me being trained to increase my knowledge, which I was trained by WHO. In Switzerland, I also did a workshop. I did health promotion activity in the clinics. Also, we did a pilot of the screening protocol. Nursing Council came on board, and we did some advocacy. And these are some pictures of some of the interventions that we did. And this was a poster that was presented all over the institutions. So my prevalence that I've identified was a 36% across both phases of women who said that in this pregnancy, they are experiencing gender-based violence. There was a lifetime, and this is in keeping with the literature, and there was a lifetime GB prevalence of 79% in phase 1 and 65% in phase 3. And I'm not seeing those figures, but I want to draw to your attention that the 4 types of violence. So what I find, and I kind of summarize it, that women who are young, who are single, who ended their education at primary level, working outside of the home, those who have a history of abuse, poor social support, those with unplanned pregnancy, those with multiple pregnancy, those in relationship less than 5 hours were exposed. In terms of their coping mechanism, a lot of them turned to the pastor instead of the healthcare providers. Across both phases came up. They want to maintain their relationship for their family. They don't want to walk away. They blame themselves. The legal strategy, they are thinking of taking the person to court. They're going to rely on their family. They want to go back to school. And of course, they believe in their faith. Some have a sense of helplessness. There was denial. Some accepted the abuse. Some wanted to be more self-reliant. And there was one particular woman who was concerned about the DNA. Within our Jamaican context, he's not the father, so she wanted to do the DNA. And another one was concerned about HIV infection. So a high level of awareness among the retired midwife, even though they weren't formally trained. One RN felt that if she had gotten the support from her supervisor, she could have done more. And what they usually practice is to inform the obstetrician for physical and emotional problems. And it was a registered midwife who reported that they advocated for a medical social worker to be employed to the Victoria Jubilee Hospital. And of course, you see their recommendations. From the findings of the active midwives, there are themes that presented itself. Midwives, they too have knowledge. They lack professional preparedness. Midwives were exposed, and midwives were concerned about their safety, even though I didn't ask them about that. In phase 3, their knowledge has increased after the intervention, and there was potential harm of GB. They recognize that there's potential harm on GB, and the interplay of violence, lack of resources to address it in the clinic. And when you look at the comparison data, you can see that there is knowledge there. So what does the midwives have to say? Some women, they believe that some women suffer from depression, etc. They feel that their practice, if they're trained, they could do more. And those names are pseudonyms. They are actually Disney princesses, symbolizing that also princesses are being abused. So the impact on the intervention, that the pregnant women were more self-reliant, increased awareness, more protective of their baby, increased self-seeking behavior, and increased expectation of the clinic to address gender-based violence. The midwives, they come in screening in the clinic, increase knowledge about GB, and observe. My time is up. And so there is high prevalence, and it's in keeping with the international findings. It's not a stereotype, but there is implication for pregnancy outcomes. All right, and I thank you for listening, and sorry, And these some of my references, and I just want to thank all these persons. Thank you for listening.
Good afternoon, and thank you for having me. I am Michaela Jackson, and my presentation today will be based on the preliminary findings from the Bustamante Hospital on the topic of hospital admissions of 1 to 16-year-olds in Jamaica due to intentional interpersonal assault. So this is a part of a larger ongoing study being conducted at the University Hospital of the West Indies, as well as the Bustamante Children's Hospital, led by clinical psychologist Dr. Audrey Pottinger, 2 associate psychologists, and some students in training. So we set out to look at violence against children and examine its physical, mental, and social impacts. Furthermore, UNICEF suggested that the COVID-19 pandemic seems to have increased the instances of violence against children due to its social and economic aftermath. Therefore, we are also examining the prevalence rate of hospitalizations pre- and post-COVID over the period of 2015 to 2024. So this study is of significance primarily because, 1, 3 out of every 4 children have experienced some form of violence in their lifetime, with sexual assault primarily between the ages of 10 to 17 years and physical assault, including fights, between 13 to 15 years. Secondly, previous studies primarily focus on community-based violence and not necessarily hospitalization rates, because of violence against children. And thirdly, few studies explore the experience from the viewpoint of hospital social workers who are key in thoroughly assessing the social and even mental impacts of violence against children. Bustamante is the leading pediatric hospital in the Anglophone Caribbean, seeing children up to age 12, whereas the university hospital sees children up to age 16. Based on hospital records for the study period, Bustamante has seen over 10,000 cases with 766 meeting study criteria, while the university hospital has seen over 3,000 with 69 meeting study criteria. Therefore, our total sample size for this study is 835. However, for this presentation, we are looking at 118 of those cases, 64 pre-COVID cases between 2015 to 2016, and 54 post-COVID cases between 2020 to 2021. So at both hospitals, we'll be collecting data retrospectively through hospital medical records and social work case notes. However, at the university hospital, we will also having a prospective component at 5 adolescents admitted between 2024 to 2025 to thoroughly assess the mental health impacts as well as these children's perception of trauma-informed care while they are in hospital. For this presentation, the aim is to report on patterns of demographic and social association, increase awareness of the risk factors, and call attention to hospital rates for violence against children. After receiving ethical approval, a data retrieval list was created, including demographics, clinical presentation, as well as social factors. So due to the sensitive nature of the study, all identifying information was not collected, and research assistants were trained in confidentiality, signed non-disclosure agreements, and were also only allowed to collect data under proper supervision. To analyze the data, SPSS 23 was used with a statistical significance of 0.05. So for our sample, we found that almost 50% of the children were males, while almost 45% were females, and an alarming 79% of these victims were under the age of 8 years old. We looked at 2 types of violence, physical and sexual, with 57% of the sample experiencing physical assaults, primarily males, and 43% experiencing sexual violence, with females accounting for 3 times more of these cases than males. As it relates to their living situations and family types, 53% of the sample was from single yard spaces, so meaning their homes only, while 33% were from shared yard spaces, such as tenement yards or just houses with multiple people. Sorry. We also found that 60% of the sample were from single-parent households, 15% were from nuclear families, and 25% were from extended families. Children in extended families experience more sexual violence than physical, whereas nuclear families had 3 times more physical violence than sexual violence, and single-parent households had a relatively similar rate of sexual to physical violence. For the perpetrators, we found that there were more male than female perpetrators with a 2.5 to 1 ratio. For physical assaults, the males were primarily parents, guardians, and step-parents, whereas for sexual assaults, the males were primarily siblings and cousins. Almost 50% of the weapons used to carry out these acts were blunt force objects such as brooms and pipes, 21% were fists and hands, and 19% was penises. Knives, guns, and chemicals accounted for the remaining weapons. For the pre- and post-COVID admissions, we found that most of the children pre-COVID were admitted for sexual violence. However, post-COVID had more similarities in admissions for physical to sexual violence. The sample thus far had 11 repeated admissions with a 3-to-1 ratio post to pre-COVID, with 8 repeated admissions post-COVID and 3 pre-COVID repeated admissions. So based on our results thus far, we have noted that there is an age and gender vulnerability among our children, as those under 8 years seem to be more at risk, and there are gendered patterns in the violence, with males being more prone to physical violence and females more at risk of sexual violence. Also, male relatives being the main perpetrators of both physical and sexual violence supports existing research of the familial nature of child abuse. The findings also suggest that the pandemic could indeed be linked to an increase in violence for a subset of the vulnerable population based on the rate of repeated admissions observed before and after COVID. Additionally, we found that specific social factors such as the family types and living situations may be putting some children more at risk of experiencing certain types of trauma. As the study progresses, we'll be better able to identify the full social profile of these vulnerable children. So our study is not without limitations. 2 of our primary limitations were incomplete or missing data in the chart reviews and medical records could affect the comprehensiveness of the findings thus far, and an inability to include hospitals outside of the KSA could also affect the full generalizability. So to conclude, our key takeaways: children under 8 seem to be the primary victims, male relatives tend to be the primary perpetrators of these assaults, and there could be a link between the COVID-19 pandemic and an increase in violence against children. As the study progresses, we'll be better able to fully determine this link and give a proper overview of who these children are and how we can properly help them. The prospective component of our study will help to provide deeper insights into the psychological and social impact of assault against children, as well as the effectiveness of the care that we provide. So our call to action is that these findings can inform policymakers and healthcare providers about the urgent need for targeted prevention programs and family-centered interventions to help mitigate violence against children in Jamaica. Thank you very much for listening.
And thank you to our first 2 presenters. Let's give them another round of applause. All right, some very disturbing findings. As we delve into our questions and answers session, let me first find out if we have any in-house questions for presenters. You may indicate by showing of hand if there are any questions. Yes, you may go ahead, Dr. Longe. Oh.
Hi, thank you so much for the presentations. I just had one question for Ms. Jackson. Maybe I wasn't quite clear, but the sample size of for the full study, you did a subsample.
Yes.
Okay, and what was the sample size for their subsample? Look at it, son.
Okay.
Right. Okay, so I was just clarifying. So the full cohort what was the total sample size?
Our full study size is 835.
835,
Correct.
and you use 118.
18.
Do you think that might have had any effect on your results? Because you said it didn't quite achieve statistical significance. Do you think the smaller sample size affected your outcome?
Yeah, the smaller sample size could have possibly impacted the overall outcome of our results. However, before presenting, we vetted with some of the social workers to be like, okay, what have you been seeing over the years before we fully analyze? So what we have presented is both from the 118 and information from the social workers themselves based on prevalence rate that they have seen over the years that they've been working at Bustamante.
So that's you utilize the anecdotal data?
No, the anecdotal data was not presented. However, when we were assessing, we wanted to see if what they are saying is what we are seeing in the information thus far.
But so you're seeing trends, but
Yes.
it hasn't achieved it. So that's what I wanted to clarify.
Yes.
If the sample size was one of the factors that you have to take in.
Yes, that is one of the factors.
Thank you so much, both presenters. Very good presentations. Lady Peter, Dr. Peter, I know you ran out of time. And I just wanted to share at least share any limitations that you had in terms of advancing this study.
All right. All right, thank you for that, Mrs. Nelson. All right, so because it's a cross-sectional study, I was unable to trace the women throughout their pregnancy to establish causability. So in the first phase, the women would have, some of them would have given birth at the Victoria Jubilee and also at UWI. They're not necessarily in the environment. They could have been all over the island. So that was an issue. The participant from UWI and Victoria Jubilee, we only did those two institutions, so we were unable to generalize when it comes to pregnant women and midwives throughout the island. And relying on the midwives' memory, the retired midwives, that could have affected their recall also.
Thank you. Thank you.
You're welcome.
Here's another question.
Go ahead.
You are hearing me? Yes. Okay. Thanks again, and very insightful presentations, both very much so. I'm curious, Dr. Peter, amongst the women, whilst we were conducting the assessment, I wondered if any of the participants would have had their partner with them, and if there was consideration to maybe gather some data from the partner at the time as well, and more to contextualize the situation. I do recognize that it's possibly a bit risky. I'm also very concerned in terms of our professionals actually stating their concern for their safety. And I wondered if any thought had gone into it, because it's a very, very, very valid reason. It's quite significant, and I'm not sure that we actually have done anything about that. Generally speaking, fear amongst our healthcare workers is a problem, and this in particular, I can see where the risk will be higher. And so I wondered what considerations may have been taken in terms of what we can do as a plan of action, because I do believe that whilst we are recognizing fairly high numbers, I submit that it's a gross underestimation as to what the real situation is.
Yes, you're correct. In terms of if the partners were present when they were interviewed, no. The partners were never present while they were interviewed.
No. So are they there? Would any of them have been accompanied? And we chose not to. Obviously, we would have interviewed them more discreetly. I just wondered
Yes,
if
they were interviewed discreetly in the clinic. In terms of safety, yes, the midwives will intervene, and yes, they're concerned. But just like with any situation at the hospital or the institution, how they would manage it, they were just expressing their fear. There was never any actual record or report of them being violated. They were just expressing their fear.
Is this an opportunity that we can probably use to signal, certainly from an HR perspective, possibly maybe to ensure that we render available to the staff means of providing support to our staff members? Persons can access care, the services, if they are probably generally advertised and encouraged, because it would, I believe the staff members are in fact feeling very uneasy, very uneasy while at work, and it's unfortunate if we are not providing support for staff to encourage them to continue to reach out to our victims and so connect them to support.
Yeah, it's the research. I would want to think that it's ongoing. I would want to go back, especially like you recommend to interview men to hear their objectives. One of my vision is to have a father's clinic where we can address some of these things and just to help them in terms of how to assist the women in navigating pregnancy and so on. But safety, yes, is a concern. Thank you.
Okay, do we have any more? Yeah, go ahead.
Presentation, Dr. Peters. I was just going to ask you a question, but some of it has come out that gender-based violence is not just women alone, that there are men too being at risk. So it will be okay now, since you have shared that aspect, that we include the men and the boys, okay?
Definitely.
All right, then for the other, Ms. Jackson, yes. When you were listing, you said the fist was used as a tool of creating violence. That's Why did you increase penises as part of that? Is that a tool of violence?
When being used in a harmful manner, we would consider it a tool because they are penetrating these children against their will, so it would be a tool in that sense.
Thank you. You know why I ask you that question? So when we are educating the people, we have to let them know that this is not the reason why God gave you this organ. It is for you to release your waste and to procreate. No, we have to teach them.
Yes, we do.
If we don't teach, if we just laugh it away, I'm serious and I'm really sad about it.
Yeah.
It is so disheartening to see that children are being abused and everybody just think it's not funny.
That's correct.
It's so sad. So we really need to educate the public. We need to educate the men, the women, everybody.
Yes.
The use of the body part overall
is not for violence.
May God have mercy. I'm sad.
Okay, thank you very much for your in-house questions. Do we have any from our online audience?
For Dr. Pito, how is the intervention able to address legal intervention and geographical replacement of pregnant mother mothers using private and public partnerships, example, the church?
I wouldn't be able to give a clear answer, but you know that gender-based violence has many facets. It's multifaceted, and there are many approaches. Even listening to my colleague's presentation, it reinforced that there is a need for it to start the education in the home before the woman gives birth, you know. So, and it also calls for the Ministry of Health to give a roadmap, a pathway of care in terms of gender-based violence to help the clinician, not just in public health, but also in private setting. So yes, you'll find that the well-to-do women would not necessarily go to the public space to get intervention. So all healthcare workers at the University of the West Indies, through the UN Spotlight Initiative, there was inclusion in the preclinical studies for both nurses and medical students, because we would have recognized that there is need for all clinicians, including all healthcare providers, the social worker, etc. At the university hospital, what the social worker said to me is that a woman comes with emotional or neglect. There's no really intervention more than you would counsel the person. So you wouldn't necessarily send to the social worker persons who are having those things, but they said for sexual assault and physical assault, they will intervene. So there is need for open dialogue, and there is need for health policies to guide all clinicians that are involved throughout.
Okay. Do we have any more questions from our online audience? Okay. All right, thank you very much. This is the end of this session with our first two presenters. I will now introduce our next two presenters. Firstly, Dr. Karima Barton is a native of the Republic of Trinidad and Tobago. In 2010, she moved to Jamaica to pursue medicine at the MBBS program. Dr. Barton had her heart set on helping those with psychiatric conditions and wanted further exposure in that area on completion of her MBBS program. As a senior house officer, she worked at the Savannah Lamar Public General Hospital, treating patients not only for medical conditions, but also psychiatric conditions as well. Dr. Barton completed her degree of medicine, DM psychiatry program in 2023, and she's now a psychiatrist at the Bellevue Hospital. Our second presenter, Dr. Kunal Lalwani, is a lecturer at the Department of Community Health and Psychiatry at the University of the West Indies, Mono, and as a psychiatrist at the University Hospital of the West Indies. He currently studies his postgraduate diplomas in geriatric medicine and psychiatry from the Royal College of Physicians of Ireland and the Royal College of Psychiatrists in the UK, respectively. Dr. Lalwani has a vested interest in research, having participated in this conference twice previously, and has published 8 peer-reviewed articles in several international journals. He has 15 years of experience working in psychiatry in St. Anne and Kingston, and is highly interested in substance use disorder, care of older adults, and public policy. We now welcome both Drs. Barton and Lalwani. First presenter being Dr. Barton. Welcome them to the podium.
Good morning, everyone, and thank you for that introduction. So, my research focused on examining recent trends in fatal suicide attempts in Jamaica. Some may ask, why was this study done? Suicide is a crucial public health problem globally. It's in the top 10 causes of death in the United States, and it has an impact not just on the individuals themselves, but also on the wider society. One of the aims of this study was to promote suicide prevention. In Jamaica, there is a paucity of suicide information. So this research aimed to add to the existing body of work in Jamaica and the wider Caribbean. The last documented research on suicide in Jamaica was for the period 2002 to 2010. So this research focused on the period 2010 to 2019 and analyzed temporal variations in suicide rates, socio-demographic profiles, and the method of fatal suicide attempts. Just a bit of global literature: over 700,000 individuals die by suicide globally every year. The majority of these persons come from low-income and middle-income countries. The rate is 2 times higher with respect to men than for women. The majority of persons are noted to be less than 50 years old. The highest suicide rates occur in the Eastern European countries. And as mentioned, there's a lot of data lacking because a lot of countries actually don't have methods of collecting and reporting data. So the socio-demographic factors explored in this research are noted on the screen. In addition, one of the objectives was to assess the age-adjusted rates as well. So this was a cross-sectional study. The JCF were gracious enough to provide the statistical data regarding suicide from their statistics and information database for the period January 2010 to December 2019. Univariate analysis, bivariate analysis, and multivariate analysis were done to ascertain the prevalence of suicide and to evaluate the relationship with the socio-demographic characteristics, method of suicide, and the seasonal variation. The statistical significance was noted at a p-value of less than 0.05, and the age-adjusted rates were generated using the 2011 census population of Jamaica as the standard. So I'll just highlight some significant results. The mean annual age-adjusted incidence of males was a little over 3 per 100,000, and for females was less than 0.5 per 100,000. Historically, we would know some men were told to be maybe strong when they were growing up, or not to cry, or not to show any emotions, whereas our young girls are known as emotional or are expected to share their feelings. And this may account for some barriers for men to seek mental health. And this would then account for the incidence of males being higher than females, as noted in the research. The mean annual age-adjusted incidence for the total population was actually 1.8 per 100,000. Additionally, this chart shows the age-adjusted suicide rate. So as I mentioned, as you can see, the incidence of males was consistently higher than females, and the ratio male to female was approximately 9:1. So this chart shows the mean suicide age trend for the period as noted. In 2010, the average age of fatal suicide attempts was 33.29, compared to 2019, which was 43.67. Now, when evaluating this 10-year difference in age over that 10-year period, it can be theorized that perhaps those who died by suicide in 2019 were exposed to the same shared experiences or stressors compared to those individuals who died by suicide 10 years prior, as it would have been from the same era referred to as Generation X. So some historical events in Jamaica that occurred that maybe some of the stressors mentioned could be the 2010 Tivoli incursion, or perhaps natural disasters such as Hurricane Gilbert or Hurricane Ivan, or the disastrous economic downturn. Most individuals were noted to be between the ages of 18 and 35, and that's our young adult population, which would mean that we would lose a lot of our active workforce, we would lose productivity, and this can have both social and economic ramifications. Most persons were noted to live in rural areas, as noted. Most were employed and worked as trade workers and farmers. Hanging was noted to be the most frequent method of suicide for both men and women, followed by firearms. And just to note, only men use the firearms. This chart shows that the most fatal suicide attempts were reported in the spring, followed by summer. Recent literature also showed significant association with the spring season, so there's an opportunity there to assess bioclimatic factors. This map of Jamaica is highlighted to show the parishes St. Catherine, St. Andrew, and Kingston. And the reason this was done is because those parishes recorded the highest percentage of fatal suicide attempts, while Hanover had the least. So just some take-home points or some key points to note. Suicide rates in Jamaica are still among the lowest rates worldwide, which is very commendable for Jamaica and shows that Jamaica is on the right path. However, one suicide is one too many, and this should not be taken lightly. Some factors that may account for lower rates in Jamaica include residents in the medicine program getting intensive psychiatric training, which would include assessing for suicide risk, the fact that most hospitals offer emergency psychiatric care, there's a lower threshold to admit individuals regarding suicidal ideation, thereby reducing the risk of suicide attempts. We also have our mental health team, which would offer services in rural areas. They would do home visits and they would do crisis visits as well. And I must mention the 24-hour toll-free mental health and suicide prevention helpline, and those factors may account for the lower rates. Some of these were mentioned before. So in terms of the most common method, it would have been hanging followed by firearms. More males committed suicide compared to females. There were higher rates of suicide among adults 18 to 35 years old. More cases occurred in rural areas and among employed persons, and there was a higher frequency of death in the spring versus warm season. So there are a few recommendations, but I'll just highlight a few. So as I mentioned, the target seasons were summer and spring, so there can be perhaps programs or drives, particularly in those seasons, to broadcast the government's suicide interventions. And this can be an opportunity as well to capture some demographics. In terms of the firearms being the second most used method of suicide, rigorous psychological testing for individuals applying for the armed forces or personal firearms would be beneficial. To add to the paucity of data on suicide in Jamaica and worldwide, an improvement in the database to record suicide data will be very beneficial. Easier access to healthcare services at all stages of life as well, of course, would be very beneficial. Mandatory screening of all patients in the healthcare system, despite what they present for, would detect those at risk and at imminent risk. And counselors assigned to each government agency would also be beneficial, as well as having a policy that private workplaces as well should have counselors available, could be a part of their employee-assisted programs. So I'd just like to acknowledge my co-authors, one of which is Dr. Lalwani, who's here today on stage, and my family. Thank you very much.
Okay, wonderful. Good afternoon, everyone. Dr. Magnet, thank you for your kind introduction. I'd like to welcome everyone here, as well as those persons in the virtual space. Wonderful presentation by Dr. Barton. I must say, I think this is a relevant topic, certainly within recent times. And my presentation will seek to build on what Dr. Barton has already shared with us. And it focuses on the factors associated with violent fatal suicide attempts in Jamaica. So you would have previously heard that the best treatment for suicide is preventing suicide. And certainly understanding the differentiation between the lethality of a violent method versus a non-violent method can be critical to preventative efforts. And for good reason. Violent methods are associated with a higher attempt and lethality. What this means, in the event that a person survives, they are more likely to reattempt and to use higher lethal means. 2, the violent method is associated with more significant medical harm. Should you survive, the road to recovery is long and arduous. And 3, the violent method is associated most certainly with the increased risk of death. And so, why did we do this study? I'd like to highlight the 4 points that I've defined as the 4 P's of prevention. 1, we seek to prevent by constructing the profile. The international literature will show that violent methods are more associated with male, who are less impulsive, who are older, whereas the non-violent method are more associated with female, who are younger and who are more impulsive. This research can show and creating a constructed profile that may help to guide preventative efforts. 2, we seek to prevent by changing the perception that the lethal method is quick, simple, and painless. Certainly in the aftermath for the family and the loved ones, it is unlikely to be painless and simple, as well as for those who recover, it is unlikely to be a painless journey of rehabilitation. 3, we seek to prevent by shifting to the preferred language. Numerous literature tells you in any walk of life, how you speak, the words you use, can either elevate stigma or reduce stigma. And so we hope to sensitize the public in guiding to a shift from a problematic language to a more acceptable language. And 4, we seek to prevent by adding to the paucity of data. More data means more research, means more opportunity to create intervention. And so our objectives: to compare the methods of violent and non-violent fatal suicide attempts between the male and female populations, to examine the factors associated with violent methods of suicide. Thankfully, the Jamaica Constabulary Force maintains a comprehensive database of individuals who died by suicide, and to date, this is the largest national database. We are grateful to the JCF for the permission to conduct a secondary analysis of fatal suicide attempt for the decade 2010 to 2019. 8 methods were classified as either violent or non-violent in accordance with international suicide literature. And this represents the first study of its kind here in Jamaica and the Caribbean that we hope will catalyze more local research and regional research. Our analysis identified 5 variables, again, that had been recategorized in accordance with the international suicide literature. Our predictive model was subjected to stringent measures to ensure accuracy in predicting those persons who used the violent method versus those who did not. Those 5 variables were age, in which persons 18 years and older were defined as an adult, and those 17 and younger were considered non-adult. Gender for male and female, geographical location for urban and rural, in which the community that the person lived in at the time of demise. Employment status, employed versus not employed. And not employed include persons who did not have a job, but also persons who were retired and who were students. And lastly, seasonal variation, where the months of May to October were considered the warm season, and November to April was considered the cold season. And so what did our results show? I want you to take a look at the table. Violent methods were hanging, the use of firearms, jumping from a height, self-inflicted stabbing, self-immolation, which is dousing oneself in fire, electrocution, and the non-violent methods were poison and drowning. 3 findings pop. 1, that hanging was the preferred method for both the male and the female population. 2, that the second most lethal was firearm, and this was exclusively by men. And 3, that non-violent methods were more likely in females than males, with 15% versus 11% in males. Sorry. Our analysis also highlighted 3 significant predictors of utilizing a violent method of suicide. 1, that the adult was 12 times more likely to utilize a violent method, that persons who were employed were 17 times less likely to use a violent method, as well as those persons living in the rural areas were 3 times less likely to use a violent method. And so what this tells us in terms of our profile is that the violent method was more likely among adults who were unemployed who lived in urban settings. So in discussing these results, I want you to remember 4 things. You would have heard Dr. Barton say most who died by suicide lived in rural areas and were employed. However, violent fatal suicide attempt is more likely in urban areas and unemployed individuals. Hence, preventive efforts can be guided by recognizing this high profile of suicide attempters that utilize a violent means. 2, hanging is the predominant violent method for both the male and the female. But is it really painless and simple? Preventative efforts can target this perception or lack thereof, especially among those who are contemplating a violent method of suicide, in targeting messages at the strong emotion that would be felt by the family members on finding the body of a loved one who has hanged themselves, as well as the appearance of the body in death. 3, more reliable research is needed. Over the past 3 years, I've had numerous conversations with my colleagues at Bellevue, Kingston Public, Spanish Town, Cornwall Regional, St. Anne's Bay Hospital, and the consensus is unanimous. Not 1 week passes where multiple persons do not present to the emergency room with an imminent risk of suicide. And so while we are grateful to be able to analyze this data, we would be remiss in not looking at the data of persons who attempt, especially when they present to the emergency room. And so we recognize that a central population database is warranted, especially as we undergo a digital transformation. And so there could be an interconnectedness between all these hospitals that offer emergency psychiatric care. And 4, I want you to take a look at this slide. This is a slide from the International Association for Suicide Prevention, which highlighted that certain language can be problematic when discussing suicide. You would have noticed the language used in both Dr. Barton and my presentation to use words like fatal suicide attempt, died by suicide, instead of successful or unsuccessful, victims of suicide. There's a reason for that. Any literature that we have read about in reducing stigma and reduction endorses that as a critical preventative strategy. And so we hope to sensitize the public to utilizing this less stigmatizing language. My final thought. The time between contemplating suicide and the attempt is often less than 5 minutes for many individuals. I consider this a critical time period. If our preventative efforts are successful, and in this time patients are thinking about the aftermath, the emotional aftermath for their loved ones, or perhaps they're questioning whether the method is truly easy and simple, then guess what? They're not contemplating suicide and they act in that particular time period. And that, my friend, could be life-saving. My gratitude to Dr. Barton, my friend Graydon Fraser, who's an excellent statistician, Professor Wendell Abel, and Dr. Clayton Sewell, who are also part of this research. My special mention to the Jamaica Constabulary Force. You have my utmost respects in sharing the data that allowed us to conduct this research. Thank you.
Thanks to Doctors Barton and Lalwani for sharing those jolting data. And I'm sure we'll have some questions from our in-house audience. You may indicate by your showing of hands.
Thanks. Thanks to the 2 presenters. Very excellent presentation this afternoon. Dr. Barton, ladies before gentlemen, and you did start first. I just wanted to find out, were there any differences in the weapons used? You were examining trends in fatal suicide attempts. Were there any differences in the weapons used in 2010 compared to 2019?
Okay.
So no, there was no real difference comparing 2010 to 2019.
Okay, so it was still the maze, it was still hanging, those
Yes.
were the, and it was still in the rural population.
Yes.
So all those trends were the same.
Yes, they remain consistent.
Oh, okay. All right, thank you. And Dr. Lalwani, my question, your presentation highlighted some real factors. How do you think you could use your data to influence or make any suggestions for policy decisions in the ministry?
How can I use my status?
Apart from that.
Oh. Well, this is a good question. To be quite honest, this is actually an inaugural research into a topic like this, certainly here in Jamaica and definitely in the Caribbean. But when you think about suicide, in particular violent suicide versus non-violent suicide, you would have seen that the majority of persons would have preferred a violent method. And so what is our public education message going to be? Because if you consider that the act of hanging, it is associated with a very poor course in terms of mortality and morbidity. Many of these persons are not necessarily going to survive just based on the act itself. And so you recognize the opportunity for public messaging that would be geared towards prevention. I highlighted a few of them. One, we need more data. A lot of the data that we are collecting happens in persons who have already passed on. But there's an abundance of data for us to cultivate and collect when we have persons coming to the emergency room, or persons of vulnerable groups such as the LGBT community, or women who are victims of domestic violence, for example. This is data that we need to examine. Also, a lot of times, even for myself and Dr. Barton, when we were looking at this research, the language that we used in our research were in keeping with international standards. But let me ask persons here, how many persons realize that that language was in existence? And that's something that I feel goes a long way to reducing stigma and discrimination. In fact, any language that is now sensitized can either elevate stigma or reduce it. And when I saw this particular language guidelines, both myself and Karima were happy about it, but we were also concerned that this was not something that had been shared to many other persons, certainly in the public sphere. And so these are some of the strategies I think that we need to consider. Hopefully with the opportunity to do more research, because the data set that the constabulary force has shared with us will allow us to now look at other aspects, included perhaps looking at suicide trends between young, middle, and older age adults. There's an opportunity to reclassify the data to look at factors like domestic violence and mental illness. And so there may be an opportunity here for us to really push and drive a comprehensive prevention effort.
Okay, thank you for that. So you mentioned one other thing that I was going to ask about. What are some of the risk factors that you can think of, or you could probably hypothesize, that may be contributing to the use of more violent methods for suicide?
So, you know, for most academics, we don't really want to make assumptions, but...
Hypothesis.
That's a good word, too. But, you know, one of the things that the international literature did show us is that persons who were found to be, who had more of an aggressive type of personality trait, were persons who were also more likely to utilize a violent method. And the reason why we did not examine that in our studies, because we did not have data that could definitively state that. But there's a trough of international literature that looks at that particular personality sort of trait as a predictor of violent suicide methods. And I think that's probably one of the areas that I suppose we hypothesize that we can look at. I'm pretty sure persons would have been aware of Professor Hickling's work and Dr. Walcott's work in the past, looking at personality disorders. They've published quite extensively, especially here in Jamaica. So maybe there is an opportunity to explore that as a possible risk factor as well.
Thank you. Dr. Barton, just back to you. One of the results that you presented was that the trends show that now older men were committing fatal suicides more than younger men compared to 2010 and 2019. Yes? Yes. Okay, the Health and Lifestyle Survey, the last one, showed that more, and this was an observation, part of the results, that more older men were depressed. Do you think there's any association between what you found and the results from the Health and Lifestyle, where there was a higher prevalence of depression in that age group? The age group that you mentioned, I think, mean was 43?
Okay, so in regards to the data that we received from JCF, some of them actually included some additional information and would have stated that some persons indeed had a diagnosis of depression. I cannot definitively answer, though, because there was a lot of missing data. But I do think that that could have been a factor associated as well.
Just one quick question, please. The preferred language that you have, the constabulary force, are they aware of this preferred language? Because we listen to them make some reports and, the language that is problematic are being used. You agree with me, Dr. Barton? Yes, I hear it too. So I'm wondering, are they aware? Do we share this information with them to bring about using the right language when communicating this type of information? And another thing which will be a thought for everybody, is it possible to go online and Google the method of committing suicide? Can you find any information? Yes, you can. Yeah. So why is that information there? So it's a case that we have to look beyond ourselves, because the children are sent online, everybody is sent online, so they can Google anything and they can find out anything. So there's supposed to be something just more than you and me sitting in this nice room and looking at the data. It has to go beyond this space. Thank you.
All right, do we have any questions from our online audience?
So, Lalwani, would you consider interviewing family members of those who committed suicide, readdressing pre-existing mental health issues and other chronic diseases? To what extent would family members reflect on or corroborate your conceptualized violent versus non-violent methods of suicide?
Okay, I'm going to address that question, but you'll fill in the gaps for me. I think you mentioned about the impact of getting the collateral information from the family. Well, of course, certainly, most persons that in psychiatry, certainly when we're thinking about history taking, we want the collateral information from the close family members, especially since a lot of persons may feel sensitive about admitting towards suicidal ideation. Of course, one of the most important things that Dr. Barton had mentioned is that if you utilize a screening tool, for example, something that is validated like the Ask Suicide questionnaire. I'm sharing this information with you guys because it's something that we at the university are currently looking at as a collaborative study with our emergency room staff. And the reason for that is because the Ask Suicide questionnaire is a validated tool that takes less than 20 seconds to complete. It is 90% specific and sensitive, and it can be used in children as young as 8 years old. And it has been validated in over 30 or 40 states, in most emergency rooms in the US. But over here, as Dr. Barton mentioned, if we were able to utilize this type of a screening tool, you would be able to discern between those persons who had a high imminent risk, which can then initiate a protocol to some level of treatment and management. So, yes, we endorse that you would benefit from information from the family, but we also have to look at our practices in terms of best practice approach, which we hope to, over time endorse here in our health facilities. I hope that answers the question, if I've not missed out anything else.
That's it for the online. All right, Dr. Muzazi, you had a question?
Yes. Doc, following up from what you just mentioned, I recognize the importance of data. So 3 points. One, in the suicide numbers that JCF has access to currently, are they able to identify those who were a successful attempt? So they would have tried before and failed. One. Secondly, I think somebody on the table there talked about the cultural nuances. Now, when you really think about it, hanging is not an easy exercise for somebody to perform. Okay? Intuitively. Now, I've read certain literature that, for instance, in Guyana, which is or used to be one of the suicide capitals of the world, suicide countries, the mode of suicide was poisoning. Now, again, it speaks to, I guess, the cultural nuances in Jamaica. The point is, why is hanging chosen over presumably easier methods? I mean, leave aside firearms, poisoning and other, methods.
Well, great question. There's a lot of literature that looks at culture and suicide, religion and suicide. But let me address the first question. Unfortunately, this data were persons who had a fatal suicide attempt. They died by suicide. So at no point did the data have any information regarding attempts, which is one of the reasons why when you think about doing analysis on this type of data, it's really a psychological autopsy, meaning you would have to go back and take a history and identify the risk factors from that person's family members or community or so on. But that's where the opportunity now arises for us to look to data collection, where persons who are attempting can be very instrumental in giving us information that could create these preventative efforts for persons who are still living with us. So that is the first answer to the first question. The second question with regards to culture, again, if you think about culture and suicide, and I can sit here and talk about it, especially as a man from an Indian culture, and when you expect, like even in some of our teachings, we used to look at how, for example, suicide might have a different cultural context in India, where when a man passed away, the wife would sit on the fire in self-immolation, and it was considered a mark of honor that you would be reunited with your husband in the next life, or reincarnated with your husband in the next life. And that was a practice that was called sati. It's probably not as much practice, but there are still some persons, I suppose, in the rural aspects of India that might do that. But if you go to Japan, for example, the art of seppuku, where the persons, in order to maintain the honor of their home, will commit suicide by a self-stab. Now, you compare that to the culture here, perhaps predominantly in more Christian societies, where you're told that if you contemplate or you do this, your afterlife is there. So you start to recognize how culture plays a role in suicide and suicide literature. And certainly from what you mentioned in Guyana and in places like Trinidad, where there's a heavy presence of I suppose, an Indian or Asian influence, for example, you will find that persons tend to use more poisoning than hanging that we see commonly here. You know, I think hanging, and maybe Dr. Barton would agree with me, I think the reason why, as you mentioned, it's a very technical exercise because perhaps 20 to 30% are unsuccessful because of how you conduct it. But I really believe it's just a matter of access and means to access, because persons can utilize any sort of object or item that would create a noose to conduct the act. And we're talking about things like rope, sheets, bed linen, shirts that are tied knot to knot. It's just a matter of access in that sort of sense. So while we appreciate cultural context, we also must understand that maybe the access plays a big role based on the territories, and that could probably be an explanation for what Dr. Barton and myself had seen in this particular research. Great question, by the way. I hope I didn't wax and wane too much, you know. Okay.
Okay, so...
That's it. Thank you.
All right. So, thank you very much for a very robust discussion. We will now take a break, and we will go off for lunch. We will break for 45 minutes, and we all return here at 2:15. All right? Good.
Problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
Me didn't even know. Me not rest. A peer problem with breastfeeding. People keep on at some for give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not gonna produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to, you know.
I'm going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Welfare.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, if you burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table on the side or the back. If you check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats. 5% or less in the on the right track. You for zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You for zoom in. Check the nutrition facts. You for zoom in. Check the nutrition facts. You for zoom in. Check
Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It there in the table by the side or the back. You fi check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table by the side or the back. Take note of the sodium, the sugars and the fats by percentile. Listen up on the right track. You fi zoom in on the nutrition facts. It there in the table by the side or the back. Vitamins, minerals and vitamin 2, 20% and more. That good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl?
I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in the hospital.
So why you never tell me?
Me didn't even know. Me not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them a tell me say if I breastfeed, my breast a go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to,
I'm going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
If you now want pop down and fenke, you fi burn mosquito and run with dengue. So no make water circle in open container. For them we read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you now want pop down and fenke, you fi burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table by the side or the back. You fi check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table by the side or the back. Take note of the sodium, the sugars and the fats by percentile. Listen up on the right track. You fi zoom in on the nutrition facts. It there in the table by the side or the back. Vitamins, minerals and vitamin 2, 20% and more. That good for you. You fi zoom in.
Check.
The nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It there in the table by the side or the back. You fi check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table by the side or the back. Take note of the sodium, the sugars and the fats by percentile. Listen up on the right track. You fi zoom in on the nutrition facts. It there in the table by the side or the back. Vitamins, minerals and vitamin 2, 20% and more. That good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
6.
What you girl?
I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not gonna produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to, you know.
I'm gonna eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Welfare.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, you fi burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you.
Your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table on the side or the back. You fi check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You fi zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It there in the table on the side or the back. You fi check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You fi zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not gonna produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to, you know.
I'm gonna eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Welfare.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, you fi burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop fret.
Fam, help us protect you.
Your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table on the side or the back. If you check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Listen up on the right track. You for zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You for zoom in. Check the nutrition facts. You for zoom in. Check the nutrition facts. You for zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You for zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It there in the table on the side or the back. If you check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Listen up on the right track. You for zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You for zoom in. Check the nutrition facts. You for zoom in. Check the nutrition facts. You for zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You for zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not gonna produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to,
I'm going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Welfare.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, if you burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you.
Your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table on the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats. 5% or less in the on the right track. You fi zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It there in the table on the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats. 5% or less in the on the right track. You fi zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor. Me hear the matter about breastfeeding support with the clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to,
I'm going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, you fi burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you.
Your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table on the side or the back. You fi check out the serving. taking too much, finger below the facts. So me on the nutrition facts. It they in the table, on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You feel zoom in on the nutrition facts. It they in the table, on the side or the back. Vitamins, minerals and vitamin 20% and more that good for you. You feel zoom in. Check the nutrition facts. You feel zoom in. Check the nutrition facts. You feel zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You feel zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It they in the table, on the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It they in the table, on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You fi zoom in on the nutrition facts. It they in the table, on the side or the back. Vitamins, minerals and vitamin 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them a tell me say if I breastfeed, my breast a go drop.
No go so. A 5 I want me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support with our clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to, you know.
They're going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water cycle in open container. For them we read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, you fi burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you.
Your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It they in the table, on the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It they in the table, on the side or the back. Take note of the sodium, the sugars and the fats by percentile. Let's end up on the right track. You fi zoom in on the nutrition facts. It they in the table, on the side or the back. Vitamins, minerals and vitamin 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It they in the table, on the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It they in the table, on the side or the back. Take note of the sodium, the sugars and the You feel zoom in on the nutrition facts. It there in the table, on the side or the back. Vitamins, minerals, and vitamin 20% and more that good for you. You feel zoom in, check the nutrition facts. You feel zoom in, check the nutrition facts. You feel zoom in, check the nutrition facts. Less sugar, less salt intake, and less fat. You feel zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm at the hospital.
So why you never tell me?
Me didn't even know. Me not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are gonna drop.
No go so. A 5 hour me breastfeed. And none of my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. They teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to, you know.
They're going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
If you now want pop down and fenke, you feel burn mosquito and run with dengue. So now make water cycle in open container. For them to read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you now want pop down and fenke, you feel burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table, on the side or the back. You fi check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table, on the side or the back. Take note of the sodium, the sugars and the fats by percent. Unless you're on the right track. You fi zoom in on the nutrition facts. It there in the table, on the side or the back. Vitamins, minerals and vitamin 20% and more that good for you. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It there in the table, on the side or the back. You fi check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table, on the side or the back. Take note of the sodium, the sugars and the fats by percent. Unless you're on the right track. You fi zoom in on the nutrition facts. It there in the table, on the side or the back. Vitamins, minerals and vitamin 20% and more that good for you. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm at the hospital.
So why you never tell me?
Me didn't even know. Me not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are gonna drop.
No go so. A 5 hour me breastfeed. And none of my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to, you know.
I'm going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Welfare.
If you no want pop down and fenke, you feel burn mosquito and run with dengue. So no make water circle in open container. For them to read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, you feel burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table on the side or the back. If you check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats by percent. Unless you're on the right track. You feel zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You feel zoom in. Facts. You feel zoom in. Check the nutrition facts. You feel zoom in. Check the nutrition facts. Less sugar, less salt, intake and less fat. You feel zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the National.
Zoom in on the nutrition facts. It there in the table on the side or the back. If you check out the servings, just do the maths. Not taking too much, figure below the facts. Zoom in on the nutrition facts. It there in the table on the side or the back. Take note of the sodium, the sugars and the fats by percent. Unless you're on the right track. You feel zoom in on the nutrition facts. It there in the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You feel zoom in. Check the nutrition facts. You feel zoom in. Check the nutrition facts. You feel zoom in. Check the nutrition facts. Less sugar, less salt, intake and less fat. You feel zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the National.
What, you girl?
I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are gonna drop.
No go so. A 5 hour me breastfeed. And none of my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to, you know.
I'm going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Welfare.
If you no want pop down and fenke, you feel burn mosquito and run with with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you don't want pop down and fenke. If you burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you.
Your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It the in the table by the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It the in the table by the side or the back. Take note of the sodium, the sugars and the fats. 5% or less in the on the right track. You fi zoom in on the nutrition facts. It the in the table by the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It the in the table by the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It the in the table by the side or the back. Take note of the sodium, the sugars and the fats. 5% or less in the on the right track. You fi zoom in on the nutrition facts. It the in the table by the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are go drop.
No go so. A 5 hour me breastfeed. I know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor.
Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to,
I'm going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water settle in open container. For them we read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, if you burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners,
been held in your hands from the moment that I wake up until I lay my head. Oh, I will sing of the goodness of God. All my life you have been faithful. All my life you have been so, so good. Every breath that I am able, I will sing of the goodness of God. I love your voice. You have led me through the fire, and in darkest night, you were close like no other. I've known you as a father, I've known you as a friend, and I have lived in the goodness of God. Oh, all my
6, and looking at substance abuse. I am Dr. Charmaine Mignot, and I'm pleased to be back with you to examine studies related to substance abuse. We have 2 presenters for this session. Our first presenter is Dr. Joseph Thomas, a final year resident in psychiatry program at the UM Mona, where he also earned a Bachelor of Medicine and Bachelor of Surgery MBBS degree in 2018. As a medical student, he was the national representative of the Jamaica Medical Students Association's Standing Committee on Human Rights and Peace. With his leadership, the group won the Project of the Year for their community mentorship program in 2015. Dr. Thomas is married and enjoys training for and competing in triathlons during his spare time. We also have with us again Dr. Kunal Lalwani, who is a lecturer at the Department of Community Health and Psychiatry, University of the West Indies, Mona, and as a psychiatrist at the University Hospital of the West Indies. He currently studies for his postgrad diploma in geriatric medicine and psychiatry from the Royal College of Physicians of Ireland and the Royal College of Physicians in the UK, respectively. Dr. Lalwani has a vested interest in research, having participated in this conference twice previously, and has published 8 peer-reviewed articles in several international journals. He has 15 years of experience working in psychiatry in St. Anne and Kingston, and is highly interested in substance use disorder, care of older adults, and public policy. So we'll begin with Dr. Thomas, followed by Dr. Lalwani. Please make them welcome to the podium.
Good afternoon, everyone. As said, my name is Dr. Joseph Thomas. Thank you also to the Ministry of Health and Wellness for having me present. And let me set the presentation. Oh, there we go. All right, so today I'll be presenting on the prevalence of depression and its relationship with substance use and internet gaming addiction in a Jamaican high school. This study was conducted earlier this year with myself, and another co-author was Dr. Delahaye. So this is the overview. We're going to be going through the study, looking at the introduction, the methodology, different results, a discussion, a conclusion, and looking at recommendations. So as you know, as you can remember, during the COVID pandemic was a very difficult time for all of us, right? You can think back to the times when you're locked at home, not being able to go out for periods of time. And there's also stress associated with the pandemic. And this stress not only happened with us as adults, but also with our adolescents. And so what we wanted to do in this study was to really look at the prevalence of depression and its relationship with the substance use and also internet gaming addiction, which was conducted in a Jamaican high school after the COVID pandemic. So this was done doing a cross-sectional study, looking at from grade 7 to grade 13, and we did an online questionnaire using the computer school lab. The questionnaire comprised of different demographic questions, and also we used screening tools, standardized screening tools such as the Patient Healthcare Questionnaire 9, CRAFT 2+N, which is for substance use, and also the gaming addiction scale for adolescents, which is for gaming. And so what we did was we looked at the relationship between the demographics, the depressive symptoms, and also the other symptoms that we had just mentioned. So what we got was that we had a total of approximately 350 students responding to the study with a mean age of approximately 50, which is 14.8, and a slightly increased amount of females at 54%. And what we found was very interesting. If you can look on the graph, you see that the blue piece represents no depression, right, which is roughly 20%. So what that means was 8% of our respondents said that they had some levels of depression, from mild to severe depression. right? From moderate to severe depression, we had approximately 50% admitting or responding to levels of depression, moderate to severe depression. And why that is important for us as well is that we in psychiatry, we treat patients with medication, pharmacological therapy for persons who admit to moderate to severe depression. And so it's very interesting results. We also looked at the alcohol use distribution. So what we found was that as the depression severity increased, so did the alcohol use within those categories. And in looking at internet gaming addiction, approximately 10% of those who responded admitted to have an internet gaming addiction. And what's also very interesting is that 97% of the respondents who admitted to having an internet gaming addiction also admitted to have depression, right? Whether it was mild, moderate, and severe. As you can see here, mild, moderate, and severe were the ones that they admitted to mostly, but 97% of those who admitted to having an internet gaming addiction also had some symptoms of depression. And this was the first study of our knowledge to be looking at internet gaming addiction in Jamaica. And so when looking at previous data and comparing to what we're seeing now, what we actually saw was that there has been an increase in depressive symptoms from before COVID. Looking at a study done by Dr. Lowe in 2014, we saw a roughly 15% increase from mild to severe depression. Right, there was approximately a 15% increase. And in looking at studies, there was an international meta-analysis which was done, and this showed that there was a 10% increase when we compared our findings to their study. There was a 10% increase in the moderate to severe symptoms, right? So generally what we're seeing is that there has been an increase in depressive symptoms. And we can see that the severity, as the severity of depressive symptoms increased, so did the alcohol use in that category, as well as the internet gaming disorder. Those who admitted also had symptoms of depression. And so what we think is that the students may be using this as a maladaptive way of coping, which may have been formed during the COVID pandemic. Sorry. Right, so in conclusion, what we're seeing was that the study does demonstrate that there has been an increase in the reports of depressive symptoms since the COVID-19 pandemic, with significant correlations of alcohol use, internet gaming, grade level. I forgot to mention that grades 9 and grades 11 were the ones who admitted to have the most severe symptoms of depression. As well as gender, females admitted to more symptoms of depression compared to males, and also those who came from a single-parent household admitted to having more symptoms of depression. And two-parent household was found to be protective. So some recommendations that we have was really to engage staff and parents about the symptoms of depression and also their role in the healing journey. We know the age-old saying that it takes a village to raise a child, but I also want to put forth that we need to educate the village on how best to raise a child as best as possible. And we live in a new era where we can see these symptoms of depression, and so we need to be able to educate not just the staff, but also educate parents on how we can best identify some of these symptoms so we can have interventions. We also need to have a targeted approach. You know, as you can see, 8% of those admitted to having symptoms of depression, and so we can look at a targeted approach where you can see those in grades 9 and grade 11, for example, females, for example, persons who admit to having maybe have symptoms of an internet gaming addiction. You know, we need to have a targeted approach to be able to reach some of these children to be able to have an intervention. And also, what would be good is to have a protocol for intervention when we have suspected cases of depression, right? Many times what we find is that when we wait until there is an incident which occurs before we respond to it. and not look at the depressive symptoms and looking at the trajectory and trying to intervene before someone attempts suicide, before we say that they're cutting themselves, So it would be good to have a protocol of intervention for those suspects of having depressive symptoms. And that is my presentation. Thank you very much.
Okay. Good afternoon, everyone. Once again, thank you, Dr. Mignot, for your kind introduction and for moderating the session. Just before I start, I just want to acknowledge Dr. Thomas. His research actually represents the first of its kind here in Jamaica and by and large in the Caribbean. And so my congratulations to you on a well-done performance. This topic that I'm going to look at now is cannabis addiction, and focusing on the factors that are related to severe use here in Jamaica. I just want to give you some global context. The latest World Drug Report that was just published 1 year ago highlighted that cannabis continues to be the most widely used drug worldwide. In fact, it's the #1 substance use disorder in 40 countries globally. Here in Latin America and the Caribbean, we account for 10% of the 210 million people that would have used cannabis at that survey. That's approximately 20 to 21 million people. And just to give you a sort of indication as to the increasing trend, this represents 25% more users since 2010. Now let me give you a couple of the local facts. 40 to 60% of adolescents indicated that access to cannabis in their mind was easy. 60 to 80% of adults indicated that cannabis access was easy. 2 in 3 who experiment eventually graduated to being a past year or chronic cannabis user. 2 in 5 drivers who currently use also admitted to driving under the influence of cannabis. And 1 in 5 persons who admitted to polydrug use indicated that cannabis was the most common substance use in their polydrug combination. And so you ask, why do we do this study? Well, a number of us at the university felt that this was the right time. Renewed interest in its medicinal value. Certainly, from its location, Jamaica represents a transshipment point for drugs to travel to the north and across the Atlantic. And so you recognize the spillover effect. Certainly from a political and social discussion, we know in the last 15 to 20 years, many countries, states in the US have decriminalized and legalized marijuana use. And of course, when you think about the paucity of research, certainly with regards to cannabis addiction, it is the first of its kind here in Jamaica and in the Caribbean, but it's also very limited in the global literature. And of course, the economic boom, or is that wishful thinking? Because this is something, another reason that also sort of catalyzed our approach to this research. And so our objectives were to survey chronic cannabis users. These would have been the past users who would have answered the CAST questionnaire. Now, the CAST questionnaire represents the Cannabis Abuse Screening Test. Now, this screening tool is well validated in general population studies world over for the last 20 years. It has also been used extensively in school surveys. And what it does is that it creates a score that highlights social and health dysfunction that indicate whether an individual will have mild, moderate, or severe cannabis addiction. And so for this study, we utilized that score of greater than 7 to identify severe cannabis addiction. And we sought to examine prevalence and quantity of use amongst chronic cannabis users, including the socio-demographic factors, psychosocial correlates, and their beliefs. Now, this was a secondary analysis of the Jamaica National Drug Prevalence Survey of 2016. And as we all know, that was the first national population survey on drug use, which hopefully now we have a new survey that was released just 1 week ago that we can offer comparisons. 4,623 participants were randomly selected throughout Jamaica for a face-to-face interview, and 786 persons would have identified as a chronic cannabis user. And once again, this also represents the first study of its kind here in Jamaica and in the Caribbean at large. Our analysis was quite extensive. We examined 19 variables, 8 socio-demographic factors, 4 psychosocial correlates, and 7 belief variables, including knowledge and perceptions. And again, our analysis was subjected to stringent measures to ensure accuracy in being able to predict those persons who had cannabis addiction from those who did not. In terms of prevalence and quantity, what did our results show? Well, 17% of the population identified as a past year or chronic cannabis user. More than 50% of these individuals, according to the CAS questionnaire, met the criteria for a severe cannabis addiction. The mean number of joints smoked among those with a score greater than 7 was 62 per month. That suggests 2 joints per day. And for those persons who did not meet the criteria, it was 1 joint. In regards to the social demographics, males were 2 times more likely than females to report severe cannabis addiction. And with regards to young, middle, and older adults, they were 3 to 5 times more likely to report a severe cannabis addiction in comparison to adolescents. And just for context, those persons who identified were young would have been between the ages of 18 to 34. Those who were middle-aged would have been between 35 to 54, and those who were older adults would have been 55 and older. And of course, adolescents 12 to 17. And again, these are international accepted recategorizations of the age variable. In terms of psychosocial correlates, those who started before 11 years of age, we considered that childhood. Those at 12 to 17, adolescents, and 18 to 25, which would have been considered early adulthood, were 5 to 7 times more likely to report severe cannabis addiction than those who were 26 years and older. Those who reported access was easy were 3 times more likely to report severe cannabis addiction. Now, with regards to beliefs, an area that I actually found quite interesting, increased odds of severe cannabis addiction was noted among those persons who had a high perceived need for treatment. They knew they wanted treatment. They also believed that the national drug use prevalence had increased, and they also were aware of the National Council for Drug Abuse. In fact, the only protective factor was that persons who perceived using cannabis for medicine often as being harmful were less likely to be a severe cannabis addiction individual. And so, I have 3 significant take-home points. I know I've given you at least 8 predictors, but I want you to remember these 3. 50% of Jamaicans who are chronic users are severely addicted to cannabis, and these persons smoke at least 2 joints per day. Take-home point number 2. The early age of initiation that I would have indicated in childhood, in adolescence, as well as in early adulthood, all had an increased risk of severe cannabis addiction. What does that tell us? Certainly when you think about the young persons, those who are in childhood and adolescence, you realize the impact is perhaps more individualized. The international literature will show that these persons with severe cannabis addiction may more than likely have academic problems, may more than likely have behavioral issues, may even more than likely experiment and develop polysubstance behavior. But what about those persons who are in early adulthood who now commence using? Those persons, the impact is far more widespread. They impact the collective, their family members, impacts the household income, relationships. And so you realize that commencing in early stages of adulthood have a more widespread collective impact. And so the messages and the interventions that we take cannot be a one-size-fits-all. They must cater to 3 different but critical developmental life phases. And my third point, those who reported severe cannabis addiction felt they needed treatment. They were aware of the NCDA, and they were concerned about the national drug situation. In fact, this is quite notable because in that last drug prevalence survey, 80% of the population, and I'm talking about everyone, did not know about the existence of the National Council for Drug Abuse, except for these individuals who admitted to having a severe cannabis addiction. They knew. So what these findings tells us is that the barriers are likely structural and financial, and they require intervention. And this, in essence, does make sense. If you think about in Jamaica, our only addiction treatment services inpatient program is located at the University Hospital here in Kingston. there are no additional inpatient programs around the island. And so you recognize that access is limited. One additional point that we must be able to acknowledge is that intervention can also be best guided by the real lived experience of the individuals who are accessing these services. In fact, who better to advise than those who are using the services? Their input can be instrumental. And so, as part of our recommendations, we must adopt a public health approach. It endorses a collaborative perspective. We utilize the experience of the psychiatrists, the physicians, the policymakers, the patients, the social workers, the financiers, in coming up with an intervention that can be utilized. We also have to be aware that the socio-cultural acceptance of cannabis here in Jamaica require that we integrate harm reduction strategies and not solely focus on preventative measures. And more importantly, as I had highlighted, we need to disseminate public education messages that fulfill the different critical phases of development. Of course, we can also consider a review of the current national cannabis policy. There was a wonderful paper, I hope you guys will get a chance to read. It was published last year summer, Potency and Trends on Cannabis Products here in Jamaica, written by Dr. Carol Lindsay, Professor Wendell Abel, Dr. Laurelie Young, and additional co-authors, which looked at almost 300 cannabis products over a 6-year period just prior to decriminalization and after decriminalization. And the significant finding was that the THC concentration, that is the psychoactive component of cannabis, ranged from between 1 to 30%. Now, why is that important? Because the same World Drug Report of last year indicated that individuals who use THC greater than 10% had a 4 times increased risk of a psychotic episode. And so you recognize what more needs to be done. We also have to consider that as much of a public health approach can help in terms of policy and legislation, they also can guide our clinical management. And so consideration perhaps to establishment of island-wide hospital-based drug treatment programs must be considered. In fact, this would be keeping with WHO's mandate of providing access to treatment in the communities where people live. My last slide, I'd just like to extend my gratitude to Professors Wendell Abel and Everard Barton. Now, these two gentlemen have been massive mentors of mine since I was a medical student. I also want to acknowledge the contribution of my fellow researchers, Dr. Winston Delahaye, Clayton Sewell, and Kevon Carr. And certainly, I'd also like to thank my family who continue to make my house a home. Thank you, everyone.
All right, so we have had 2 excellent presentations to end session 6. In the interest of time, we'll be only able to take 1 question per presenter. I don't know how we're going. Okay, go ahead, Dr. Alonge.
Thank you, presenters. Excellent work. I was just going to find out. When they introduced the Dr. Thomas and they said he's married, I say, praise God. And then when he was presenting he said that the children, you have to listen, the children who were having 2 parents, father and mother, was protective. Is that true? Yes, in the study, it was protective for the children. So, as a society, we have to think beyond the research room now. How do we take this back to the streets? How do we take it to downtown, everywhere? To encourage the people. The father and the mother are very critical in the home, so that those set of children, it's alarming to see that dimension of addiction. And I wanted to ask you, when you say most of them were in single homes, I didn't want to create anything. Will they be single mothers or single fathers? Did you ask that? Or it could have been more of mothers. You understand? So we really need to take this information seriously. It was just 1 school. Probably if you go to several schools, we don't know if you can get a repeat of the same or there might be difference. Thank you.
We have a microphone.
Can you hear me? It's on. Yeah, good. Thanks very much. Both presenters, excellent, thought-provoking. So to Dr. Thomas, number one, if it's appropriate, may I ask which parish, or was this a rural or urban location for the school? Whichever one you can answer if you can. And then regarding the findings of depression, is it possible, or could you tell if the depression that was detected existed before COVID, but was exacerbated by the lockdown, isolation, etc. of COVID, and therefore more push towards gaming, etc., because you can't go to school, you have almost nothing else to do. So did the depression exist before? And that's kind of why I'm asking you if the school was in a rural or urban, inner city or something location. You see what I'm saying? Okay.
Can you hear me? Yeah? No? Good afternoon again. Thank you for the comments earlier. And there are many things to respond to, but I will say there's a lot that needs to be done. I think a lot is being done, but there's a lot more that needs to be done as well. The study that I did, it looked at both, it was single parents, it was mothers only, as well as fathers, but because you had a majority of the students admitted to living with their mothers alone, around 46% admitted to living with their mothers alone, so there was a significant correlation with those who lived with their mothers alone as opposed to their fathers, which was around 4% of our respondents. In regards to your question, because of how the study was, it's a cross-sectional study, so it's really a cutting time. We weren't able to say whether depression was from before or afterwards, but what we did see was looking at the data previously, the study done by Dr. Lowe, which was here in Jamaica, that showed that there has been an increase since 2014. And then internationally, there was an increase, around a 10% increase, looking at comparing internationally before COVID and now my study in the post-COVID era. And it was my study used a high school here in Kingston. Yeah, I will go as far as say it was a traditional high school. Yeah.
Okay, do we have any questions from the online audience? All right. So that ends our question and answer segment. Thank you for tuning in, and we appreciate your being attentive to the sessions. And this is where we will end. Good. Thank you.
And before Dr. Mignot goes, we want to thank her for staying the course for our last two sessions and for doing an excellent job. And we just want to have another round of applause for two excellent presentations. At this time, we'll have a 5-minute break.
What you got? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are gonna drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not gonna produce enough milk. I better ask your nurse or your doctor. Me hear the matter about breastfeeding support program at clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to,
I don't eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
If you no want pop down and fenke, you fi burn mosquito and run with dengue. So no make water circle in open container. For them we read up under the danger. Usher them out, run them away. Slap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you no want pop down and fenke, you fi burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back.
Zoom in on the nutrition facts. It there in the table by the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table by the side or the back. Take note of the sodium, the sugars and the fats. 5% or less in on the right track. You fi zoom in on the nutrition facts. It there in the table by the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness. Jamaica Moves, the Heart Foundation of Jamaica, the
Zoom in on the nutrition facts. It there in the table by the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table by the side or the back. Take note of the sodium, the sugars and the fats. 5% or less in on the right track. You fi zoom in on the nutrition facts. It there in the table by the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. You fi zoom in, check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness. Jamaica Moves, the Heart Foundation of Jamaica, the
What you girl?
I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
I didn't even know. I now rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed.
Good afternoon, everyone, and welcome to the final session for today. It's scientific session number 7, and we will focus on maternal and child health. These presentations will close out the oral presentations for 2024, and we will have 5 presentations. We'll start with the first 2 presentations, followed by questions and answers. Well, one question per presenter in the interest of time, and that will be followed by the final 3 presentations. So allow me to introduce the first 2 presenters. Dr. Carol Lord. He's a public health specialist and currently serves as Program Development Officer in the Family Health Unit. Dr. Lord recently achieved a Doctor of Public Health degree from the University of the West Indies in 2024. Over the years, Dr. Lord has made significant contributions to research, authoring and co-authoring multiple papers in areas such as infectious diseases, sickle cell disease, pediatrics, and maternal health. Beyond her professional pursuits, she is a devoted mother of 2 young adults and a committed believer. Ms. Sachel Nelson is 23 years old, and she's an emerging epidemiologist with a passion for addressing public health challenges. She holds a bachelor's degree in experimental biology with first-class honors, and recently was awarded a master's degree in epidemiology with distinction from the University of the West Indies, Mona. Sachel has a strong interest in non-communicable diseases and their risk factors, as well as infectious diseases, and she plans to pursue a PhD in one of these areas. She lives by the mantra, true success is not measured by how much you have accomplished, but by how many lives you have impacted along the way. So let's welcome, first of all, Dr. Carol Lord.
Good afternoon. Thank you so much. I want to say good afternoon to the distinguished guests, colleagues, and fellow researchers. Today I will be presenting the results that examine the perinatal outcomes of mothers with eclampsia and preeclampsia treated at public hospitals in the Southeast region in Jamaica. This research aimed to highlight the impact of hypertensive disorder in pregnancy on neonatal health and the associated risk for adverse outcome. These are the authors. The presentation is outlined where we're going to look at some of the background and then look at some of the study findings. So preeclampsia and eclampsia actually is part of the hypertensive disorder of pregnancy. Hypertensive disorder of pregnancy actually have 5 categories. So preeclampsia and eclampsia is whereby we have blood pressure of greater than or equal to 140/90, taken on 2 occasions, 4 to 6 hours apart, and it's really in a mother that is greater than 20 weeks pregnant. Eclampsia, actually, is where they have high blood pressure, proteinuria, but this is associated with tonic-clonic seizure. And just imagine having seizure in a normal, healthy person, all right? So the global incidence of hypertensive disorder of pregnancy is about 4 to 25%, and it complicates about 3 to 10% of pregnancies. When we look at the mortality impact of hypertensive disorder of pregnancy, actually we find 80% of maternal deaths being associated with hypertensive disorder, and that's what makes this study very important. Remember, pregnancy is not a disease, huh? And so why would high blood pressure in pregnancy be killing our women and our babies? We find the perinatal mortality impact is whereby we have 16 to 31% actually having perinatal deaths. When we look at the risk factors for hypertensive disorders in pregnancy, we see nulliparity, advanced maternal age, a history of hypertension in previous pregnancy, or a family history, actually, of preeclampsia. We look at the complication of hypertensive disorder, is that we can have maternal and fetal complication, with maternal being postpartum hemorrhage or antepartum hemorrhage. And for the fetal, we can have prematurity, neonatal deaths, and stillbirths. So therefore, the objective of the study was really to investigate the perinatal outcome for neonates born to mothers with eclampsia and preeclampsia, comparing them with neonates born to normotensive mothers. And this is actually between 2015 and 2019. It is a retrospective cohort study at the 5 maternity hospitals in Southeast region. The study population was really women managed for preeclampsia and eclampsia. The 5 hospitals included Victoria Jubilee, Princess Margaret, Spanish Town Hospital, Linstead Hospital, and also the University Hospital of the West Indies. These are the 5 hospitals in the Southeast region. So we reviewed actually 788 medical records at the public hospital. The sample was divided into 3 groups, that is, those with eclampsia, those with preeclampsia, and the normotensive. The chi-square analysis was actually used, and logistic regression were used to examine the relationship between hypertensive disorder, that is eclampsia and preeclampsia, and adverse neonatal outcomes, such as low birth weight, low Apgar scores, and neonatal admissions. The SPSS 21 was used as well as Theta 16. Ethical approval was received from the University Hospital, Southeast Region, and Ministry of Health and Wellness. So the perinatal outcomes. We look at low birth weight, Apgar score, nursery admission, preterm birth rates, and perinatal asphyxia, as well as perinatal mortality and stillbirth rates. The inclusion criteria included those who actually, you were pregnant and you presented to the hospital, and you were actually found to have high blood pressure, and so you were included in the study. The thing is that anywhere where a pregnant mother presented, we were able to locate the dockets, even if they presented to the female medical ward. And this is 10 days post-delivery, because eclampsia includes 10 days post-delivery. If they presented to the female ward with seizure disorder, and they were admitted and delivered within 10 days, they were actually located and admitted to the study. If you had a previous known seizure disorder, you were not included. So this is the data source. So let us look at what the results show. Retrieval, we actually were able to know that the eclampsia was seen among the younger women with a median age of 22 years. Just imagine a 22-year-old come before you and just start seizing. This is a healthy young woman. That can be very frightening. And that's what's important here. The majority of women with eclampsia were nulliparous, and that's seen with the red bar. When we look at the neonatal aspect, we found that the neonates of preeclampsia mothers had significantly longer duration of stay in the nursery. For the perinatal outcomes, when we look at the key perinatal outcomes and the risk, we found that the results reveal a significant difference in the neonatal outcome between preeclampsia and eclampsia among the normotensive mothers. The neonates were born to mothers with preeclampsia were at a much higher risk of being low birth weight, that they were at 8 times greater risk compared to the normotensive mothers. Additionally, they risk having lower Apgar score at 1 minute, and the odds ratio was about 16.91. It was important to know, though, that these patients actually also were admitted to the nursery. There was increased admission to the nursery. And they were actually had the highest preterm birth rate of 51 per 1,000 births. When we look at the perinatal mortality, we found that both eclampsia and preeclampsia very high perinatal mortality compared to the normotensive women there. Not good. So therefore, what we found that eclampsia and preeclampsias, these were actually, once mothers presented with eclampsia and preeclampsia, they were at increased significant risk of having poor outcomes as it relates to the low birth weight, as it relates to perinatal asphyxia, as it relates to mortality. It was great among this group. So therefore, in conclusion, we found that our study demonstrated that mothers with eclampsia and preeclampsia experience significantly poorer perinatal outcomes compared to the normotensive mothers. These conditions are strongly associated with things like asphyxia, low birth weight, preterm birth, and high nursery admissions. So in light of these findings, it's imperative to improve antenatal care, especially monitoring and early management of hypertensive disorders during pregnancy. Additionally, providing medical support for the sick infant, because most often these babies are delivered before term. So providing support for these infants is very important. So by focusing on early intervention and timely treatment, we can reduce the risk associated with these hypertensive conditions and ultimately improve the health of our mothers and babies in Jamaica. What are some of the policy implications? While our primary focus was on the medical and the neonatal outcomes, strengthening the maternal health service, particularly for our high-risk mothers, would be important. Providing care for our sick and at-risk infants, and be able to have early diagnosis of these mothers with hypertensive disorders, because early diagnosis means early intervention, and that means preventing, have more favorable outcome for both mother and baby. Knowing that with the baby and with the mother, because of placental insufficiency, they both have substandard or compromised health during the pregnancy. So we want to be able to have early diagnosis, meaning that we have to identify them early. In addition, we want to have continued research and policy adaptation for maternal health improvements, in that we develop comprehensive guidelines to standardize care of these women and these babies. What is important here is that the delivery of the placenta is what is important. And so our findings are actually comparable to those globally, except for our perinatal mortality and stillbirth rate. Those are higher than the regular global, and so it means that we need to look more into that. So I just want to say thanks to my supervisor, Professor Afet McCobbins, and to the Department of Health and Psychiatry for their ongoing commitment and assistance. I want to say thanks to the Ministry of Health and Wellness, and a special thanks to the University of the West Indies and the Pan American Health Organization, and thank you for listening.
Good afternoon, everyone. Let me first just take this opportunity to thank the NHRC for allowing me to present my thesis findings, assessing dietary predictors of anemia in women of reproductive age, utilizing findings from the Jamaica Health and Lifestyle Survey 3. Anemia is an issue of not having enough healthy red blood cells or hemoglobin to carry oxygen to the body's tissues. As a result, anemia leads to symptoms such as fatigue, weakness, and shortness of breath, and it is seen that broader health effects of anemia include increased morbidity and mortality, which in turn decreases work productivity, thereby hindering social and economic development. Now, anemia is a significant public health problem, and it affects over 1 billion people globally. However, women of reproductive age, that is those between 15 to 49 years old, are quite at risk. But what exactly accounts for this susceptibility? Heavy menstrual blood loss, along with the increased physiological demands of pregnancy and childbearing, makes our women of reproductive age more vulnerable to anemia. Anemia in women of reproductive age is defined by hemoglobin levels, where a non-pregnant woman is said to be anemic if her hemoglobin level falls below 12 grams per deciliter, while for pregnant women, this is below 11 grams per deciliter. Anemia is also categorized by severity, that is mild, moderate, and severe, as displayed on screen. In terms of anemia prevalence, estimates reveal that globally anemia affects 30% of our women of reproductive age. Now, in the Caribbean region, the average prevalence is 29.2%. The United Nations has a global aim to reduce anemia prevalence by 50% by the year 2030. However, several countries, particularly our low and middle income countries, are failing to meet this target. And so what we see is that without significant intervention, anemia is actually projected to increase globally instead. As a result of this, it is imperative to understand the various types of anemia for effective assessment and management. Now, iron deficiency anemia is the most prevalent type of anemia, followed by anemia of chronic disease. However, another common type of anemia following these is known as megaloblastic anemia, and it should not be dismissed in our anemia assessments. So this occurs when the concentration of hemopoietic nutrients are insufficient for red blood cell production, but can also be as a result of increased nutrient losses such as hemorrhage associated with childbirth or heavy menstrual periods. In many instances where diets lack sufficient micronutrients due to poor dietary diversity, food insecurity, and iron deficiency, this type of anemia development may be an outcome. Additional risk factors include our socioeconomic status, sociodemographic factors, as well as physiological factors. Currently, there's a paucity of data on the epidemiology of anemia in women of reproductive age due to dietary diversity, food insecurity, and iron deficiency status in Jamaica, which is why this research aimed to investigate the impact of these factors on the prevalence and severity of anemia among our Jamaican women of reproductive age, while also assessing the contributions of additional covariates such as physiological, socioeconomic, and sociodemographic factors. Now on to our methods. So the study design was cross-sectional in nature, utilizing secondary data from the Jamaica Health and Lifestyle Survey 3. Our study participants included a subsample of women of reproductive age that matched our inclusion criteria. This was that the woman of reproductive age should have at least one biologically plausible hemoglobin or serum ferritin value. After applying our inclusion criteria, the final sample size was 353 women. However, due to the complex survey design utilized, this actually represented just shy of 744,000 Jamaican females nationally. The outcome variable was anemia, and it was explored as a binary variable using the cutoff points for non-pregnant women. The primary explanatory variables were food security, which was developed from 5 questions, followed by categorizing our women as either being secure or insecure. Dietary diversity, which was a modified version of the minimum dietary diversity score for women of reproductive age. And lastly, iron deficiency status, which was defined as serum ferritin levels below 15 micrograms per liter. Additional covariates are displayed on screen. For statistical analysis, all were conducted using Stata Software version 18. We began with descriptive statistics to summarize the characteristics of our study participants. Bivariate analysis used Pearson's chi-square and unadjusted logistic regression to explore associations with anemia, presenting odds ratios and 95% confidence intervals. Finally, in our multivariable regression analysis, we used the stepwise backward approach for variable selection, refining the final model for significant predictors. All estimates were survey-weighted to account for sampling design. Now on to our results. So the prevalence of anemia was found to be 28% in this study, and it was also seen that 25.5% of our women were iron deficient, 32.4% had low dietary diversity, and 63% were food insecure. Anemia prevalence differed significantly by iron deficiency status and dietary diversity, but not by food security. So for iron deficiency, we see that women who were iron deficient had a 60% rate of anemia compared to about 15% of those who did not have iron deficiency, and this was a statistically significant difference. For dietary diversity, around 35% of our women with low dietary diversity were anemic compared to those with high dietary diversity. Although food insecure women appear to have higher rates of anemia, and we see that's about 29% compared to about 23% of women who were food secure, this was not a statistically significant finding. We had also garnered that the attributable risk of anemia due to iron deficiency was 47.4%, and the population attributable risk was 42.1%. We had also looked at the prevalence of anemia severity by the 3 primary explanatory variables. Here is what we found. So for food security, while not statistically significant, insecure women had higher rates of mild and moderate anemia compared to those who were secure. For dietary diversity, women with low dietary diversity have significantly higher rates of mild and severe anemia compared to those who have high dietary diversity. Iron deficiency is strongly associated with anemia, where women with iron deficiency had significantly higher rates of moderate and severe anemia compared to their non-iron deficient counterparts. Regarding multivariable regression analyses, our findings reveal that women who were food insecure had lower odds of anemia. However, this was not a statistically significant finding. Women with high dietary diversity had a 43% lower odds of being anemic compared to those with low dietary diversity. This was a statistically significant finding. For iron deficiency, these women had a 8.47 times greater odds of being anemic compared to their non-iron deficient counterparts. And lastly, multiparity, which simply means that a woman has had 2 or more live births, was a significant covariate associated with anemia. So these women had a 3.15 times greater odds of being anemic compared to a woman who had no children. Overall, iron deficiency significantly increased anemia risk. Food insecurity was not associated with anemia. High dietary diversity was protective and statistically significant, and parity significantly increased anemia risk. Our findings reveal that there's a high prevalence of anemia among our Jamaican women of reproductive age. While food insecurity was not a statistically significant predictor, its potential role in anemia prevention should not be dismissed. We recommend that future studies should aim to assess the psychometric properties of the food insecurity tool in the local context, and ultimately, addressing anemia in Jamaica will require at the community level both nutritional and educational interventions. Thank you so much for your attention, and a special thank you to my supervisors and co-authors of this paper, as well as my mom. Thank you, everybody.
Very lovely applause for 2 wonderful presentations, and thanks for sharing your findings with us. I wonder if we have any questions, and of course, as indicated before, we'll limit it to 1 question per presenter. All right, so we have questions from online. You have the mic.
For Dr. Lord, what is the maternal mortality rate at this time? And are we improving as we have been working on this for a while?
Even though this is not, that is not actually part of the presentation, I can say to you, our maternal mortality rate is 136 per 100,000 live births. We have actually decreased from 2020 and 2021, where we went up to as high as 211 per 100,000 live births. So we're decreasing, but the general trend from within the last 2 decades is that it was going up. And so we are working very hard. We are trying to do things differently to decrease our maternal mortality ratio, because we can't do the same thing and expect different results. So we have actually developed guidelines. We are trying to get more messages out, because what we recognize, the gap in when we analyzed the death was really delays 1 and 4. 1 is that mothers not recognizing what are the red flags to go seek care. And so educating the mothers would be very important. Educating our population generally would be able to help, because grandma can help, mommy can help, cousin can help. And the other area is the care when they reach the institution, being able to receive the adequate care. And so the guidelines would help to standardize that care, and so we'll be having lots of training on the guidelines so as to standardize care. So we're working on that, and we expect to see a difference before 2030. Over.
One more for you, Dr. Lord. Do your findings do the findings from your study align with global trends in hypertension in pregnancy?
Okay. Actually, as it relates to poor outcome, because of the whole pathophysiology of hypertensive disorder in pregnancy, yes, in terms of low birth weight, because their placental insufficiency. So it offers, it gives mommy a substandard outcome as well as the infant. So as it relates to low birth weight, as it relates to nursery admissions, yes. But as it relates to the mortality and stillbirth rate, we're above the global area of which would be addressed as we look into closer monitoring, early diagnosis, so that we can have early intervention. We're above the global figures. Over. And it means that there's something that we need to do something differently within the Southeast region. And remember, the Southeast region is 47% of Jamaica's population. So it's something serious that we need to address.
It says community and home education is the way to fix the problem. Children don't know the basic nutrients that prevent dietary iron deficiency, and by the time they become teenagers, they hate iron-rich foods such as callaloo, etc. It's more sociable to order fries and burgers as they generally acquire taste for sugars and fats. So the question here now is, does your study support that as an intervention?
Most definitely it does. I do agree that to a wide extent our children are not educated properly in terms of nutritional interventions as well as just nutritional facts overall that they need to consume in order to prevent anemia and by extension other diseases. And a part of potential intervention strategies could actually be implementing just guidelines or bulletins or just some form of teachings as early as basic school.
Oh, sorry. Okay, thank you. My question was, in the presentation, you talk about food insecurity. So I was trying to find out, is it that the food was not available or there was no money to buy the food?
So food insecurity means that you do not have the food to consume. But I can say it also does overlap a lot with your socioeconomic status. So to some extent, the answer to your question could actually be both.
Okay, so the food is there in the market. You don't just have the money to afford to buy it. Okay, that's one aspect. Okay, now the next question is, based on your findings, what will you say as a researcher to a teenager? A young people. Yes.
Okay, so if I were to give advice to someone who is young, I'd first off start off by saying something similar which Doc said here. The only thing in life that is constant is actually change. And if you want to see changes in your life, in your dietary patterns, in how you operate as a human being, you have to be willing to go through that change and accept that change. So it's not going to be a very easy road, because with social media now, it's very, very easy to, put out a lot of fictitious information, and it's so easy to corrupt our young minds, especially our teenagers. So My thing is, I think I would just start. It only takes such a small step to make a big difference, and I can say, speaking from experience and even having conversations with my peers, having a post come from, let's say, somewhere like the ministry's Instagram page versus an unofficial, blog or side page on Instagram makes a big difference. So it's not easy to just go out and be like, hey, you need to eat this, you need to do this. But what I can say is that if we take the step, it is actually possible to educate our youths. And the good thing about information, and the good information, is that when it is ready to spread, it will spread. So we just need to get it among our youngs, in our schools, and they will actually pass it on not only to their peers, but perhaps to their family members as well, to their church, any area or institutions or organizations that they may be a part of.
Okay, thank you. And I think another thing we might to force feed them the callaloo.
All right, let's thank the first two presenters again, and thanks for engaging them. All right, so we'll move to the final three presenters. I'll introduce them. The third will present from online. We'll start with Dr. Shekinah Hayden Matthews, to my left. She is currently the pediatrician at the Kingston and St. Andrew Health Department, where she's dedicated to improving the pediatric care at the primary health level and advocating for children's health and well-being. She holds a Doctor of Medicine in Pediatrics with over 7 years of experience working at the Victoria Jubilee Hospital, Bustamante Hospital for Children, and the University Hospital of the West Indies. In 2021, she was recognized as the top exam candidate for DM Pediatrics Part 1, and in 2023 received the UHWI Pediatric Research Forum Research Prize. And she is deeply devoted to God, her family, and her patients, balancing her life as a wife to a wonderful husband and a mother to 2 adorable children. Next, we have Dr. Alistair Carvalho. He is a recently graduated pediatrician and the chief pediatric resident at the University Hospital of the West Indies. Dr. Carvalho completed his medical training in Santiago de Cuba at the Instituto Superior de Ciencias Médicas. You can correct me when you come. And later specialized in pediatrics during his residency at the University Hospital of the West Indies. As the chief resident, he oversees the pediatrics residency program, coordinates clinical rotations, and helps to manage patient care on the pediatric ward. Dr. Carvalho looks forward to furthering his career in pediatric medicine as a neonatologist and contributing to advancements in child health care. And the final presenter, who I'll introduce, but she's not yet online, so we'll see. Okay, do you want her to go first, though? Okay. I'll introduce her, but we'll see if she will be able to join us. Dr. Venicia Cruikshank Reynolds is a child of God, wife, and mother. She's a proud graduate of the St. Andrew High School for Girls and the University of the West Indies, Mona, where she recently completed her graduate studies in pediatrics. She enjoys the performing arts and currently serves as president of the Health and Wellness Committee at the Duraney Park New Testament Church of God. She fervently believes that the most important thing that our society needs is world peace and a safer environment for our children. So we'll have the first presenter now, Dr. Shekinah Hayden Matthews.
Good afternoon, everyone. I'm Dr. Shekinah Hayden Matthews, and there's a stand that I can fit at. Right. So I'll be presenting on the early clinical outcomes of neonates born to mothers with severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2 or COVID-19 at the University Hospital of the West Indies. Other authors are Dr. Campbell Mitchell and Professor Trotman Edwards. December 2019, China declared a COVID-19 outbreak caused by the novel SARS-CoV-2. March 11, 2020, WHO declared a global pandemic due to the virus' highly transmissible nature leading to global spread. And I remember, I don't know if you remember, March 10, 2020, Jamaica had its first case of COVID-19. Mommy called me, everybody called me worrying. After that, there was just a series of waves of COVID-19. So over the several years, there's increased morbidity and mortality rate that justify the need for us to identify and protect vulnerable populations in society. And as you know, vulnerable population are our children, and they comprise less than 2% of the diagnosed cases, and typically they tend to present with mild disease compared to us as adults. Infection is recognized as a leading cause of death in neonates worldwide who are prone to sepsis due to their immature system. There is particular concern about the effects of this virus at the time on the neonatal population because I was young at that time. SARS-CoV-1 outbreak caused high case mortality rates and severe complications in neonates. Several studies from developed and developing countries reported no difference in the birth parameters, the need for respiratory support, morbidity and mortality between neonates born to positive women and those born to SARS-CoV-2 negative women. However, few studies reported that neonates born to SARS-CoV-2 positive mothers required respiratory support post-delivery and were likely to be born preterm. Most studies reported no or low positivity rate of COVID-19 amongst exposed neonates. 2 studies from Saudi Arabia and Spain reported that majority of neonates born to mothers with the virus were admitted to the NICU due to primary maternal infection with COVID-19. Numerous studies highlighted that the neonatal deaths among neonates born to positive mothers were low, and there are still no published studies done within the English-speaking Caribbean on the clinical outcomes of neonates born to mothers with COVID-19 infection. So our rationale was that the literature on vertical transmission of this virus and neonatal outcomes among exposed neonates is emerging, but findings have been inconsistent. And we believe it was important to provide information regarding the clinical characteristics and outcomes of neonates born to mothers with the virus compared with mothers without the virus in the local setting to help our neonatologists in providing optimum care for neonates born to women who are positive. So our aims and objectives. Our aim was to compare the clinical manifestations and outcomes of neonates born to women with the virus with those of neonates born to mothers without the virus. The objectives were to describe the demographics of neonates born to positive women, describe the clinical manifestation and outcomes of neonates born to women with the virus, to compare the clinical manifestations and outcome of neonates born to SARS-CoV-2 positive women with those born to SARS-CoV-2 negative women, and to compare the outcomes, admission, low birth weight, preterm delivery, and death of neonates born to positive women than those born to negative women within each COVID-19 wave. So it was a retrospective docket review, all neonates born to women with or without the virus at the University Hospital of the West Indies between August 2020 and January 2022. The study participants were identified using our labor ward admission logbook. The case was a neonate born to a positive woman, and the control was neonate born closest in time to the index case to a SARS-CoV-2 negative woman. So the maternal and neonatal demographics, neonatal clinical manifestation, morbidity, and outcomes of cases and controls at the hospital discharge were recorded using a data extraction sheet. Thank you. So this is where we had our regular wards, and we also isolated those. So those who were exposed went on to our neonatal HDU and isolated ward. We used, for our demographics, clinical characteristics and outcomes were compared between neonates born to women with or without the virus using a chi-square test, independent sample t-test, and Mann-Whitney U-test. And we analyzed our data with SPSS version 22, and our statistical significance was taken at a p-value less than 0.05. So we had a total of 162 neonates that were entered into the study, equal distribution between negative and positive women. Of those born to positive women, 91% were asymptomatic, and we have a relatively equal distribution between females and males, and 88% were born at term. I'm not sure how clear this is. However, we did not have any significant difference in the demographics of the SARS-CoV-2 positive and negative mothers who delivered during that time period. We essentially did not have any significant difference with our demographics for the neonates born to exposed, well, born exposed, right, versus those who were born to negative mothers, except for the admissions. So we noted that neonates born to CoV-2 positive mothers were more likely to be admitted. The common reasons for neonates to be admitted were prematurity and its complications and transient tachypnea of the newborn. Our results show that there were no difference in the length of hospital stay or morbidity noted between the neonates born to both groups. 2.5% of SARS-CoV-2 exposed neonates tested positive for the virus and were discharged home with their mothers. 3.7% for both exposed and unexposed neonates died, and there were no excess morbidity or mortality that was noted. For the waves, I know the first, the second, and the third wave. In the first wave, we saw that there was more, or neonates were more likely to be admitted, and we'll talk about that in the discussion, but they were more likely to be admitted during our first wave. So our findings confirm that early neonatal outcomes of babies born to SARS-CoV-2 positive women are favorable and are in keeping with earlier studies. Our results concurred with several studies that there are no significant differences in the mode of delivery, gestational age, birth weight, Apgar scores, and need for respiratory support between neonates born to positive and those born to mothers without the virus. The rate of SARS-CoV-2 positivity in neonates born to SARS-CoV-2 positive women was low as seen in other studies. There was no increased risk of morbidity and mortality in neonates born to positive women, as well as neonates who tested positive for the virus. Similar to previous studies, neonates born to positive women were more likely to be admitted than those born to negative women. This is because during the first COVID-19 wave, when we're all just knowing the virus, neonates born to SARS-CoV-2 confirmed women were more likely to be admitted because we were uncertain about the neonatal outcomes at the start of the pandemic. There are some limitations to our study. We had missing data. Thank you. We had missing data for maternal and neonatal demographics and clinical manifestations and outcomes. It was a single-centered study, so we had not had from different institutions to compare. This study did not examine the presence of the virus in the placenta, cord blood, and breast milk of the COVID-19 confirmed women. It would have been ideal for antibody testing to have been conducted on all neonates born to or positive women to more accurately determine positivity. So our recommendations were that exposed neonates should follow the standard protocol as per institutions. There is no need for a routine real-time PCR testing for all neonates born to positive women, except if other clinical conditions are identified. Positive mothers can continue to provide routine care for their neonates and breastfeed their infants once both are clinically well to do so. In conclusion, there is no excess morbidity or mortality for infants born to women with SARS-CoV-2 compared to neonates born to women who are SARS-CoV-2 positive. And these are my references. Thank you.
Hello, everyone. Good afternoon. I'm Alistair Carvalho. Thanks for that wonderful introduction. And thanks to the Ministry of Health and Wellness for affording me this opportunity to present my research topic. My research, titled Hypoxic Ischemic Encephalopathy, Incidence, Outcome at Discharge, and Predictors of Poor Outcome. It was a retrospective study of a Jamaican cohort. Thanks to my advisors, Professor Helen Trotman and Dr. Gillian Lewis. I have nothing to disclose. Hypoxic ischemic encephalopathy, basically it's a form of brain injury in newborns resulting from restricted blood flow and as a result, reduced oxygen supply. It is characterized by diminished consciousness, so there are varied symptoms, which is based on the organ system that is involved, and symptoms may vary from altered consciousness, seizures, decreased muscle tone, and reflex responsiveness. It is a global problem, and we see it having significant morbidity and mortality in newborns in many countries, including our low and middle income countries. Several studies conducted across the globe have provided insight into the incidence, the outcome, and predictors of poor outcome diagnosed with hypoxic ischemic encephalopathy, HIE. However, there is a lack of recent data on these factors out of Jamaica, and this is really what prompted this particular study. My objectives include to determine the incidence, outcome at discharge, and predictors of poor outcome in neonates at or greater than 36 weeks gestation diagnosed with HIE at the University Hospital of the West Indies, UHWI, between January 1, 2018 and December 31, 2022. Secondarily, I wanted to compare the incidence of HIE in this study with that of a previous study that was done at the UHWI over a 5-year period, which was more than a decade ago. It was a retrospective, descriptive docket review looking at all neonates that were born at or greater than 36 weeks gestation with HIE that were born at the UHWI between January 1st, 2018 and December 31st, 2022. Descriptive analyses were performed and differences in neonates by Sarnot staging, which is used to classify into mild, moderate, or severe, with what will translate into HIE stage 1, 2, and 3, respectively. And outcome were determined using the chi-square test for categorical variables and one-way ANOVA for continuous variables. The predictors of outcome were determined using multiple logistic regression models, and data were analyzed using SPSS software, and statistical significance was taken at the level P less than 0.05. The inclusion criteria, so all live newborn neonates that were at or greater than 36 weeks gestation delivered at UHWI between this time period diagnosed with HIE. So we excluded all those who weren't born at UHWI, who were less than 36 weeks gestational age, or those with lethal chromosomal and congenital anomalies. We defined a poor outcome as either mortality or having significant neurological sequelae indicated by an abnormal neurological exam at discharge or abnormalities observed in brain imaging, whether it's a cranial ultrasound, a CT, or MRI. An abnormal neurological examination at discharge was defined as having an altered level of consciousness and activity, abnormal muscle tone, signs of bulbar dysfunction, and evidence of neurological deficits. So coming to our results, we found that the incidence was 3.9 per 1,000 live births, and we had 32 neonates who fulfilled the criteria from a total of 8,226 neonates delivered during that time period. And if you look at figure 1, you'll see that the trend, we saw a low of 1.75 in 2019 in comparison to the highest, which was 6.2 live births, 6.2 per 1,000 live births in 2021. In terms of the severity of HIE, we saw that majority had stage 2 or moderate HIE. 11 neonates of the 32 had HIE stage 1, and 8 neonates had the most severe form, which is HIE stage 3. In terms of outcome, we had 12 of the 32 infants with a poor outcome, which we described earlier as abnormal neurological examination or mortality, or having an abnormal brain imaging. 5 neonates died. 4 were classified as the most severe form of HIE stage 3, and 1 as HIE stage 2. In terms of neurological sequelae, we had 27 survivors. Of those 27 survivors, majority, 74.1%, had a normal neurological examination at the time of discharge. 25.9% had an abnormal neurological examination at the time of discharge. 4 of those 7 who had an abnormal neurological examination at discharge had HIE stage 2, and 3 of the 7 neonates had a HIE stage 3. We saw, in terms of poor outcome, the parameters of acidosis, so pH, bicarbonate, and base deficit. Those were had an association with the poor outcome of neonates diagnosed with HIE. In terms of, in addition to poor outcome, we had need for mechanical ventilation as a contributor to poor outcome with a significant p-value. 9 of the 12 infants with poor outcome required mechanical ventilation, which was significant, and only 4 of the 20 infants with good outcome needed mechanical ventilation. The need for therapeutic hypothermia, which is now the standard of treatment for neonates diagnosed with HIE stage 2 and 3, and in some institutions, stage 1 as well, had a significant p-value of 0.01. 9 neonates received therapeutic hypothermia. 4 had stage 2 HIE, and 5 had stage 3 HIE. Of the neonates who died, 3 received therapeutic hypothermia. And I will say at this point that therapeutic hypothermia was introduced at the University Hospital of the West Indies in 2020. So it was considered in the latter 3 years of my study period. So in terms of predictor of outcome, the sole predictor of outcome was the severity of encephalopathy that had a significant p-value 0.01. And we compared it to other possible predictors such as seizure on admission, the need for more than 1 anti-seizure medication for seizure control. But the sole predictor of poor outcome was the severity of encephalopathy. When compared to the study that was done over a decade ago, we saw that the incidence decreased from 6 per 1,000 live births to 3.9 in the study period 1998 to 2003 in comparison to 2018 to 2022. We saw where right across the board, stages 1, 2, and 3, there was a significant reduction in the incidence. So we concluded that the incidence of HIE at the UHWI was significantly decreased over the past 2 decades. However, the mortality rate, which was approximately 15.6%, has not shown a corresponding decrease. Approximately a third of neonates experienced a poor outcome, and a quarter had an abnormal neurological examination at hospital discharge. The need for therapeutic hypothermia, severe acidosis, the need for mechanical ventilation, indicators of disease severity were factors associated with poor outcome. And the sole predictor of poor outcome was the severity of encephalopathy. In terms of study limiting factors, missing or unavailable medical records at the time of data collection, data obtained may have been incomplete, limited by what was recorded in the medical records, lack of an amplitude integrated, what we call EEG, electroencephalography, which will pick up on seizures that is not obvious to the naked eyes, and inability to obtain neuroimaging promptly. Therapeutic hypothermia was only utilized from year 3 of the study, and this may have impacted neurological examination at discharge. This was a single-center study that was conducted at a tertiary level institution. However, so as a result, results may not be able to be generalized to other centers in the country. My recommendations include enhancing the quality of intrapartum care services, implementing interventions such as continuous fetal monitoring for high-risk patients, and introducing fetal scalp pH testing in labor and delivery units, ensuring the timely and appropriate delivery of at-risk patients, and provide comprehensive counseling for women and potential risk factors. Timely neuroimaging for infants diagnosed with HIE and continuation of therapeutic hypothermia as an effective intervention for neonates diagnosed with HIE stage 2 and 3, and to maintain a strong and collaborative relationship between the neonatal and the obstetrics team. Final 3 recommendations are to continue follow-up of infants diagnosed with HIE stages 2 and 3 in our pediatric neurology specialist clinic, while those diagnosed with stage 1 are usually followed up in our general outpatient pediatric medicine clinic. The need for future studies and follow-up investigations is extremely important, and then to tackle healthcare access, infrastructure, and socioeconomic challenges in low and middle-income countries, necessitating coordinated efforts for sustained improvements. Special thanks to Dr. Oligui, who is our pediatric cardiologist at UHWI, and of course, thanks to my friends, family and colleagues who made this possible. These are my references.
All right, thank you to our 2 presenters, and we won't have the 3rd presentation, so we'll go to the questions and answers now. And we have a question in the room. Can we get a mic to her?
Hello. All right. Afternoon again. So my question is for Dr. Hayden. Great presentation. Yes, you. It's kind of like akin to the study. I was wondering if while you were doing the study, if you picked up on any patients who presented with Miss C later on, like, you're just looking through the docket. And also, what about breastfeeding? Meaning, was breastfeeding encouraged for those COVID? Okay, or so I guess just one question then, because you answered the second one.
It's on. Okay, so the first question. So there was one case that the patient was negative. That was the neonate was negative, but the mother is positive, but had all respiratory conditions and everything. And then I think we found that they did an antibody testing on the baby, and the baby was COVID positive. So that was just one case, but everybody else. That was one of the cases that died. But everything else was no Miss C or following up. But I want to piggyback on what you said, that if anyone out there would like to, in pediatric residency land, would like to take up where we can look on our kids like 2 years after this study or like a year after this study to see what's happening with them, how are they respiratory wise, or if they needed admission post this research. And yes, we encourage breastfeeding. Breast is best. That's what the ministry says, so we continue that.
Okay, this question, good afternoon again, everyone. This question would be for Dr. Alistair Cavallo. Yes. So, wonderful, everyone. I do enjoy the presentation. It's very rich and very impactful at this time. As it relates to your study, though, Dr. Cavallo, were you able, based on the outcomes that you would have garnered from the research, looking at the results, were you able to compare this with any international studies being done on in the same area? And what did you find?
So, thank you for that question. So we did a significant comparison with studies done in other low and middle-income countries, such as Jamaica, And we also compare it to studies that were done in developed countries. What we saw in terms of the incidence was that the incidence was significantly less in more developed countries. And we have a plausible explanation for that. More resources, so we have more robust monitoring. And the incidence usually in developed countries is somewhere between 0.8 and 1.3. And in low and middle income countries, we have as low as 1.6 to as high as 26.9. So I think we're doing pretty good in terms of the incidence. When we compared predictors of poor outcome and to the predictors of poor outcome to our study and to other studies, they were actually comparable. We find a lot of countries in the Caribbean as well with similar studies, with similar results.
Okay, thank you so much.
You're welcome.
Harris? Sorry. I know you said one question, but just the last one.
We have one. Oh, we do? Okay.
Yes, just the last one. Dr. Carvalho, just one question. You mentioned the study 2 decades ago. We're not seeing any real change, right? That's what you said.
No. So the incidence significantly fell from 6 to 3.9.
To 3.9.
Which is
but
remarkable.
The mortality, was similar.
Similar mortality,
right.
Correct.
But in your graph, you had a blip in 2021, like it went sharply up.
Mm-hmm.
And I think that was round about the COVID era, and you just started your hypothermia. Do you think that might have impacted your results somewhat?
I would say there is a possibility. There are multiple factors which could have contributed to that. And what you suggest in terms of the association with the pandemic that happened around that time, so there is a strong possibility. But I want to say in terms of the incidence that there was a significant reduction, but in terms of mortality, we think that, of course, there is more room for improvement, and we hope to get our incidence down to the rate of a developed country, and we will definitely work on the mortality. We have postulated that this could have been because of lack of specific resources. Maybe during that time, a baby may have needed mechanical ventilation, and if there isn't a ventilator available, then unfortunately, it's not available. There's also a need for parenteral nutrition, total parenteral nutrition, which oftentimes isn't available, and that's a significant part of, it has a significant impact on the outcome nutrition for a baby diagnosed with HIE. You're welcome.
All right, thank you very much for all the presentations and all the information that was shared. For presenters, a round of applause. All right, thank you. So that concludes the presentations for today, and we'll go now to a little break or the closing remarks.
Before we go to the closing remarks, we want to thank Dr. Harris for ably leading us through our last presentation. So at this point in time, we'll just invite Dr. Harris forward. We also want to congratulate our presenters, all very interesting presentations, and we can continue to ask questions after the session, and we're going to invite them at this time. They can leave the stage. Thank you. We have come to the end of 2 days of oral presentations. It is hard to believe, but we have been blessed with many thought-provoking presentations, all excellent, and all have the opportunity for further interrogation in terms of policy implications or further exploration. We would encourage you to further explore the findings, and you can do so by exploring on our conference webpage. You will find the abstracts in our booklet, and those are available online. We also encourage you to view our poster hall, where you will have the opportunity to interact with our poster presenters. For those who will log on tomorrow, we have a panel discussion on work-life balance, a presentation on submitting to the advisory panel on ethics and medical legal affairs, as well as workshops on quantitative analysis and writing a research paper. There are prizes awarded to persons with the highest leaderboard score, which are given to those who will explore our conference webpage, so we encourage you to do so. Please join us tomorrow, and remember that we begin promptly at 9 a.m. So we wish you a good afternoon, and thank you for joining us.
What you got?
I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are go drop.
No go so. A 5 I want me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not going to produce enough milk. I better ask your nurse or your doctor. Me hear them talk about breastfeeding support in the clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to,